to medical field and society, Gaikwad's Gold Medal for Academic Excellence and nomination for the Vikas Ratna Award by the Government of India. Many more things. He is an institute in himself. And now, to chair this session, I would like to call upon stage Dr. Nikunj Chovatia, Clinical Cardiologist, Gujarat, Dr. Chirag Bhatia, Clinical Cardiologist, Gujarat, Dr. Renuka Verma, Clinical Cardiologist from Jharkhand, and Dr. Deepak Jain, Clinical Cardiologist from Uttar Pradesh. And for the first talk of this session on domiciliary management of ischemic heart disease, I would like to call upon stage our first speaker, Dr. Vineet Jagnani. And I would like to call upon stage Dr. Nikunj Chovatia to introduce our first speaker, Dr. Vineet Jagnani.
Hello. So, good morning all delegates. On the behalf of Iaccon, I welcome you all and I am thankful to you all for sparing your valuable time. Without taking much time of yours, let's begin our first topic, that is to be delivered by Dr. Vineet Jagnani. He is a diploma in clinical cardiologist from Apollo Hospital, and he's a consultant physician. His main specialty is cardiology. Besides cardiology, he practices diabetology as well. And he has many publications as national level as well as international level. And he is a member of national and international bodies. He is founder president of Jharkhand ISCC and executive body member of Jharkhand RSSSDI ISCC. And he is organizing chairman of this conference as well. So, Dr. Vineet Jagnani, I welcome you. And the session is all over you.
Thank you. Thank you so much. At the outset, I must thank Gujarat team for giving me this opportunity to talk on this particular topic, and overwhelmed with the hospitality which we have been receiving since yesterday, and of course from months that the preparation has been going on. Probably this is a topic for clinical cardiologists. We are here to talk about the domiciliary management of ischemic heart disease. Well, we all know that in present scenario, when we talk of ischemic heart disease, we are talking of PTCA, the bypass surgery, but this comes with a cost of therapy. And many of us, many of the patients are not willing, either because of the cost or because of the mental bias, and they prefer domiciliary management instead of intervention. So is it appropriate? Can all of them be provided this? Let's see. So for this particular study, we took certain things into our consideration. The clinical presentation of the patient and diagnosed as NSTEMI, non-ST elevation MI on terms of ECG, troponin or echo. If any of these two are positive, we should consider them ischemic heart disease acute onset. And it also included the patient is unwilling for intervention for any reason of his, or a STEMI which is at least 24 hours old. then only the patients were included in this particular study. The patients who were willing for intervention were not included, or any comorbid condition other than diabetes and hypothyroidism were also excluded from this particular study. Coming to the management included 5-day subcutaneous therapy with enoxaparin 60 mg twice a day, along with thiazide type diuretics, beta blockers, ACE or ARB, but not both of them, nitrates, nicorandil, trimetazidine, aspirin with a loading dose of 300, similarly clopidogrel, high dose of statins, and patient was advised rest with low salt and fat diet, maybe for gastritis ranitidine, and maximum tolerable doses of these particular medicines were used. For management of diabetes, patient was put on insulin, and for hypothyroidism on levothyroxine. Patient were put on this therapy for at least 6 weeks with enoxaparin for 5 days. There were 30 patients in this study with an average age of around about 64, and 70% of patients were male. 9 of the patients were inferior wall MI anastomie, 13 were lateral wall, and 8 septal MI. The comorbid conditions, diabetes was present in 9 patients, hypertension in 24, and hypothyroidism in 3 patients. What did we observe? We found that there was significant reduction in the basic pulse rate by more than 10 beats per minute, systolic blood pressure reduced by 14 millimeters of mercury, diastolic by 9, and there was improvement in ejection fraction by almost 5%. There was also reduction in cholesterol, total cholesterol by 48 milligram percent, HDL improved by 2 milligram percent, LDL and TG reduced by almost 30 milligram percent. There was improvement in A1C by 0.5%, the fasting and PPG also reduced by more than 10 and 30 milligram percent. So, and most all of the patients were enzyme positive, TROP-T was positive in all of these patients. So this is what we observed at the end of 6 weeks. So we can say that on an average, all the patients showed improvement in heart rate, blood pressure, diastolic blood pressure as well, with improvement in ejection fraction, lipid profile, and the glycemic parameters. Most important, the patients became asymptomatic in by the end of 6 weeks. So we can say that ischemic heart disease can be managed even on conservative line. Of course, we need to explain the prognosis very much in detail. A full explained written consent must be taken into consideration. This is probably a good option for those patients who are financially constrained or not willing for intervention at any cost. So if the patient is not willing for intervention, they should not be denied the management of ischemic heart disease. Of course, we need to weigh the risk-benefit ratio, and there is definite improvement in overall morbidity, and the patient should be advised for coronary angiogram and revascularization if there is recurrence of the symptoms. So here I rest my presentation. These are the references with which we could manage these patients. Thank you so much. Any questions? Yeah. This was domiciliary management. We measured the oxygen with a pulse oximeter. The oxygen level was normal, and no patients were hospitalized, no patients were given any oxygen therapy. Pulse oximetry showed that the oxygen levels were normal, so oxygen was not required also.
Sir, I wanted to ask the role of trimetazidine, right? Because there is lots of controversy whether it is real beneficial or not when we are giving beta blockers, agents.
Condition. We all know that the present therapy goes with intervention. But when we are doing domiciliary management, we do not have an angiogram report with us. So we should give the best possible chance. Of course, trimetazidine, ranolazine, all these molecules do not have very much definite data with us that they are of benefit. We have both type of data with us. They are beneficial, they are not beneficial. So giving the benefit of doubt to the patient, why take a chance?
Thank you.
That was a wonderful presentation. What about the complications in domiciliary treatment?
There is definitely a risk of complication. The patient can go into failure. There can be some valvular rupture. We all know that. But as we said that we have explained everything to the patient, the possible complications, and we have chosen only those patients who are not willing for any reason whatsoever may be for intervention. So my point here is to stress that if for any reason patient is not willing for intervention, we should not deny the treatment. We should do whatever possible at our level to the best improvement that can be provided, maybe in terms of morbidity. We do not know about mortality. This is something that will take time to understand. But morbidity is definitely visible within 5 days of therapy by the time the patient is finishing his enoxaparin. So taking everything into consideration, the take-home message would be this can be an ideal therapy for those patients who are not willing for intervention. We should not deny the treatment. That is what I want to establish by this particular presentation.
Good morning, sir. My question will be how enoxaparin was given at home.
The paramedical staffs were involved for giving enoxaparin subcutaneously, 0.6 milligram in most of the patients. In high weight patient more than 80 kgs, 0.8 milligram subcutaneous twice a daily for 5 days. And patients were closely monitored.
So if any complication with enoxaparin is there?
In general, we know that enoxaparin has practically no complications. The risk of bleeding is there, but that too is too less with enoxaparin if we compare with streptokinase or unfractionated heparin. As such, in this study, there was no complication.
Sir, if the paramedical staff is not available or someone who doesn't want to involve the patient side, doesn't want to involve the paramedical staff due to price constraint or anything, so should we then also advise enoxaparin with the same dose?
If we want to go with this therapy, and if the patient is not willing to involve paramedic staff, as happened with me also, in that situation, I was giving enoxaparin myself to those patients. But I guess that should be included in this type of treatment. We should not deny that benefit to the patient.
Thank you, sir.
Sir, after 6 weeks, is there any data that कितने टाइम के बाद पेशेंट को इंटरवेंशन की ज़रूरत पड़ी या प्रोग्नोसिस पुअर आया, ऐसा कुछ?
Now, none of these patients have went for intervention, but these patients are still with follow-up with me, and as much as 5 years have passed by for some of these patients, and we have not seen any complications, but all of them are on continuous medical therapy with regular follow-up in terms of clinical examination and investigations.
I think session is very well covered by Dr. Vinit Jagnani in the term of domiciliary management of ischemic heart disease. I request all guests to limit the questions to 3. If time permits, we can go over 5, but not beyond 5. So we can cover the session within time period. Now, I hope that concept has been cleared by all you, by the lecture given by Dr. Vinit Jagnani. So now we welcome. Now I would like to.
Thank you so much.
I would like to hand over the moment to Dr. Vinit Jagnani. So Dr. Vishmi Parmar will hand over the moment to Dr. Vinit Jagnani. Thank you so much, Vinit sir. Thank you so much, Vinit bhai. Mr. Bhai.
Thank you, Dr. Vineet. Now, for the next talk of this session on role of colchicine in acute coronary syndrome, I would like to call upon stage Dr. Sheetal Jadhav. And to chair this session, I would like to call upon stage Dr. Chirag Bhatia and Dr. Deepak Jain.
Yes, good morning friends. For the next sessions, we have Dr. Sheetal Jadhav. Sheetal Jadhav is a consultant physician and clinical cardiologist from Vijaypur. She is running Sri Tulang Singh Diabetes Hospital and Diabetes Research Foundation, Vijaypur, Goa and Bagalkot. She is a president of IACC Karnataka chapter. She is a joint secretary of the Central IACC, organizing secretary for more than 10 annual conference on diabetes at Bagalkot, Vijaypur, membership and affiliation with IACC, AE and many more associations. Now I request Dr. Sheetal to start her talk. Dr. Sheetal, please.
Good morning, everyone, and a very warm welcome from Vijaypur, the city of victory. It's a city in North Karnataka. I am inviting you all to be there and do visit the hospitality of the city. So at the outset, I'd like to thank you, the chairpersons, for the kind introduction, and I would like to thank Dr. Pragnesh sir and his entire organizing team for having invited for this SOU visit yesterday. Like rightly Amitabh Bachchan has said, kuch din guzaro Gujarat mein. He made sure he made me spend at least one day entire day in Gujarat, and that was a lovely day yesterday. Thank you, thank you. So today I'm going to be speaking about colchicine. It's an age-old drug which has been used before for gouty arthritis, for Mediterranean fever, and even viral pericarditis. We're going to see how is it, or what are the possible benefits in ACS management. So colchicine is a tricyclic alkaloid extracted from the flowering plants of Colchicum autumnale, and among its pleiotropic effects, colchicine affects the immune system and has anti-inflammatory properties. It downregulates multiple inflammatory pathways, leading to a decrease in neutrophil function and migration through vascular endothelium by tubulin disruption. Moreover, it also inhibits the NLRP3 inflammasomes. It reduces the local production of coronary chemokines such as MCP1 and secretion of tumor necrosis factor alpha by macrophages. In addition to the inhibition of transforming growth factor beta signal pathway, colchicine may also exert some anti-fibrotic effects. So this is a slide which is summarizing the same. So coming to pharmacokinetics shortly, it is absorbed in the jejunum and ileum and accumulates in tissue. It is metabolized in the liver, and the absorption of oral colchicine is rapid but incomplete. It is mainly excreted by biliary system, intestines and kidney. So like I said, the indications are in treatment of gout flares, familial Mediterranean fever and in acute viral pericarditis. The contraindications are severe renal and hepatic impairments. It should not be given, and it should not be used in conjunction with PGP inhibitors like apixaban, cyclosporin, dabigatran, digoxin, endoxaban, rivaroxaban, tacrolimus, and clarithromycin, erythromycin, dilzim, itraconazole, ketoconazole, such antiviral drugs. In these patients, life-threatening and fatal colchicine toxicity has been reported with colchicine taken in therapeutic doses too. So the most common side effect that has been observed earlier in the treatment of gout was diarrhea, whereas in the studies where we did it for cardiovascular patients, the diarrhea was not seen very commonly. The most common adverse side effect would be abdominal pain and nausea, vomiting. But these effects are usually mild and transient and reversible upon lowering the dose. So in special population, like I said, in presence of mild to moderate renal or hepatic impairment, adjusting of dosing is not required. But in patients with severe renal impairment, you need to be careful before initiating colchicine. Coming to one major trial, that was the COLCOT trial. In COLCOT trial, patients were randomly assigned to receive colchicine or placebo within 30 days of post-MI. The primary efficacy endpoint was composite of cardiovascular death, resuscitated cardiac arrest, MI, stroke, or urgent hospitalization for angina requiring coronary revascularization. The relationship between the endpoints and the various TTI, time to treatment initiation, was examined using multivariable Cox regression models. And what were the results? After a median follow-up of 22.7 months, there was a significant reduction in the incidence of primary endpoint for patients in whom colchicine was initiated within 3 days of the MI, compared to patients in whom it was initiated in between days 4 to 7. And it was even better when it was more than, it was even worse when it was more than 8 days. So beneficial effect of early initiation of colchicine was also demonstrated for urgent hospitalization for angina requiring revascularization, all coronary revascularizations, and the composite of CV death, resuscitated cardiac arrest, MI, or stroke. So to conclude from COLCOT trial, the patients benefit from early in-hospital initiation of colchicine after MI. That is within 3 days when it is initiated, it helps more. Another meta-analysis was done to evaluate the utility of colchicine in patients with acute and chronic CAD. A systematic review and meta-analysis was performed from Medline, Embase, Cochrane Central. Around 3,000 odd citations were taken, and 13 randomized trials were included in this. What was the result? Colchicine versus placebo, standard therapy in patients with CAD reduced risk of new myocardial infarctions and new strokes or transient ischemic attacks. But treatment with colchicine compared with placebo or standard therapy had no influence on all-cause and cardiovascular mortality. Colchicine did increase the gastrointestinal side effects over here with a significant p-value. So these slides show sorry for the crowded slide. It just shows about how all-cause mortality was not affected with colchicine. The p-value was not significant. Neither was cardiovascular mortality affected in this. However, new myocardial infarctions had a significant value of p-value of less than 0.01, and even new stroke or new MI cases, they were significantly reduced in the studies. So to conclude, in patients with acute and chronic CAD, adding colchicine to standard therapy seems to reduce the risk for ischemic events, namely MI and stroke TI. Colchicine therapy, it also reduces the risk for repeat revascularization procedures. Colchicine therapy may have an increased risk for gastrointestinal side effects and therapy withdrawal. There is no influence on all-cause mortality. Another randomized trial, a double-blind trial, this is the LODOCO trial. It happened in 2 phases. One was in 2013 and another in 2021. This is a randomized double-blind trial involving patients recruited within 30 days after MI, and the patients were randomly assigned to receive either low-dose colchicine, that is 0.5 mg OD, or placebo. The primary efficacy endpoints were the same, composite of CV causes death and resuscitated cardiac arrest. Here 4,700 odd patients were taken into the study, 50% to colchicine group and 50% to placebo group. They were followed for a median of 22 months. The results were, there was a significant reduction in the primary composite endpoint in the following points. Death from cardiovascular causes were reduced, resuscitated cardiac arrest, myocardial infarction, stroke, urgent hospitalization for angina leading to revascularization. Secondary composite endpoints like death and DVT or pulmonary embolism was not significantly reduced though. So this is the same Kaplan-Meier chart that I've showed earlier. So among the patients with a recent myocardial infarction, colchicine at a dose of 0.5 mg daily led to a significantly lower risk of ischemic cardiovascular events than placebo. So I'll talk about 4 RCTs where the same incident comparing these RCTs compared the incidence of cardiovascular events between patients with clinically manifest CAD randomized to colchicine versus placebo. The primary composite endpoint was CV mortality, MI, ischemic stroke and urgent coronary revascularization. These 4 studies were the LODOCO trial, the low-dose colchicine trial, then the COLCOT trial, the COPS trial and LODOCO 2 trial, which happened in the second phase in 2020. So the results of these 4 RCTs, I'll tell, the reduction in CV events among patients randomized to colchicine was driven by statistically significant reductions in MI, ischemic strokes and urgent revascularization, significant p-value, and all relative consistent among subgroups. The incidence of safety outcomes did not differ between the groups. To conclude from this, in secondary prevention of CV events, the addition of low-dose colchicine to standard medical therapy reduces the incidence of major CV events, except CV mortality when compared with standard medical therapy alone. So this is one of a good article, colchicine is in acute coronary syndrome, a systematic review. Randomized trials of, out of 627 titles, 9 trials were included, and here also the same results. The major adverse cardiovascular events, MACE, was not significantly different at 30 days in 3 studies who were administered 1.8 milligram of colchicine pre-procedurally or scheduled 1 mg daily. One study only found there was a significant reduction in MACE with colchicine over a median of 22 months. So within 30 days, the beneficial effects were not found, but after around at the end of 22 months, beneficial effect of colchicine was documented. Of course, colchicine is associated with increased GI events, but it is generally well tolerated. And like I said, with a low dose, colchicine is not causing too much of gastrointestinal side effects. The couple of 5 studies, again, in which I'll tell just what did the study say. Like around 80 patients were studied by Raju et al. In this, ACS patients were taken 1 mg per day of colchicine was given. Colchicine did not significantly reduce the HSCRP levels at 30-day here. Another study by Deftrose et al. 151 STEMI treated with PCI patients were taken. In this, 1.5 of colchicine was given immediately, then 0.5 mg 1 hour later, and then 0.5 mg BD. For 5 days it was given. Here the CKMB level was significantly reduced by 50% in these patients. One more study by Ekoda et al. 44 patients semi-treated with PCI, but here there was no significant difference in the CRP levels or in the inflammatory markers. Another study by Martinez et al. Here the transgrandian level for IL-6 and IL-B interleukin levels were reduced significantly again. Another study by Vaidya et al. 80 patients were studied. It reduced the LA volume pressures. So even here it was beneficial. One more landmark trial was the colchicine PCI randomized trial. Even this studied the effect of acute colchicine administration prior to PCI patients. I'll just tell the summary of this study. This investigator-initiated single-site prospective randomized double-blind study was the first to evaluate the effect of an acute pre-procedural administration of colchicine versus placebo on markers markers of myocardial injury and inflammation in patients undergoing PCI. Compared with placebo, the short-term pre-procedural colchicine did not reduce PCI-related myocardial injury or MACE at 30-day, but it did attenuate PCI-related increase in IL-6 and hsCRP concentration at 24 hours post-PCI. So this is the first study to demonstrate that an oral load of colchicine prevents a rise in inflammatory biomarkers in acute injury. One latest study, article that I found in JACC September 15, 2021 issue, even this mentions the same thing. To summarize, it tells about when to commence colchicine. The insights emanating from recent large clinical trials studying the role of colchicine as an anti-inflammatory treatment in patients with coronary disease comes with new questions for regular clinical practice, such as when to commence the treatment. And current data suggests that initiating treatment early after MI or in patients without cardiorenal failure treatment in OPD clinic, in outpatients. The effect of colchicine persists throughout prolonged treatment irrespective of timing of a prior acute coronary syndrome. So my take-home message would be, colchicine is still not into the recent guidelines about it should be used for ACS patients or not should be used. There are a couple of multiple articles are there, multiple studies have been done, but still it is not included in the guidelines. We need to think about it, given so many studies. So inflammation plays a pivotal role in coronary artery disease. The anti-inflammatory drug colchicine seems to reduce ischemic events in patients with CAD. So far, there is equipoise about its safety and impact on mortality. Colchicine represents a promising supplementary drug for secondary prevention of ischemic events among patients with acute and chronic coronary artery disease. The reduced risk of potentially debilitating secondary coronary vascular or cerebrovascular events will need to be balanced against the side effects and interaction profile of colchicine. Nonetheless, several questions regarding colchicine treatment in coronary artery disease patients remain uncertain and warrant more research, including patient selection, drug dosing, and therapy duration. Thank you. No, I have used it personally as of such. Like I have not used personally colchicine, but I've spoken to like couple of my colleagues who have used them more frequently in viral pericarditis, but we have not yet started using for ACS patients. Anybody here who has used it in ACS patients?
Yeah.
Because
Myself using colchicine in the brand Xy colchicine, 0.5 mg. It is very cheaper drug, sir.
0.5.
10 tablets nearly cost 30 or 40 rupees only.
Yes.
For last 3 years, I am using. One more event, arrhythmia. To be very frank, for last 3 years, nearly more than 300 patients I have thrombolized. I do practice in periphery, where most of the people are non-affordable. They don't have my Iacc card also. So on next day after thrombolysis, I start colchicine 0.5 BD. I have not seen a single patient with arrhythmia. We see mostly after anterior MI, we do see ventricular tachycardia most common, but none of the patients in whom I have given colchicine, there is no arrhythmia at all, and patients do benefit very well.
So you have used for how many days? 30 days?
After 1 month, I do stop. Till the patient is admitted 0.5 BD. When discharged, I do 0.5 mg OD because GI side effects most common diarrhea. So rather than patient stop, it's 0.5 mg OD is okay, no diarrhea.
Have you using ACS, acute coronary?
Exactly after thrombolysis. No.
Have you used for acute coronary syndrome, myocardial infarction? You have used Iacc, but
No, not in unstable angina or stable angina.
no.
Even in NSTEMI also. Yes, sir. Only in STEMI after thrombolysis.
Thank you. Thank you for that. Yeah.
Thank you, Dr. Sheetal. Now I would like to call upon Dr. Chirag Bhatia to felicitate Dr. Sheetal. Shekhar Ambadekar. For the next session on narrow complex tachycardia and wide complex tachycardia, I would like to call upon stage Dr. Shomu Bora.
Very good morning, and thank you, Dr. Pragnesh, for having me here. It's a wonderful place to be in Baroda, and I personally welcome you all also. I have so many known faces, especially from Ahmedabad, UN Mehta, and it's a pleasure being here. So my job for 1 hour, narrow complex, broad complex. Everybody knows, I suppose, so we'll just go in a revision mode if possible. I'll want your interaction, and it will be fun to see how much you know as well as how much I can teach further. Okay, so let us see this slide. We'll know how to differentiate any tachycardia. So what is tachycardia? Heart rate of more than 100. Anything more than 100, it may be sinus tachycardia or it may be an abnormal tachycardia, right? Now, how do you know it is sinus tachycardia versus another tachycardia? P wave followed by QRS doesn't mean it is sinus tachycardia. It means the P wave morphology should come from the sinus node. And how do you know from the sinus node? Upright in 2-3 AVF, and V1 is positive and negative. Right? So these two morphologies, but then you can have atrial tachycardia from there also. So a tachycardia, sinus tachycardia is responsive to autonomic stimulation, right? There will be bradycardia in evening, night when you sleep, and there will be tachycardia when the patient exercises. So any tachycardia which is under autonomic influence with this morphology is sinus tachycardia, right? So that is how you will differentiate a tachycardia from atrial tachycardia, sinus tachycardia from atrial tachycardia. With that premise, how do you differentiate narrow complex tachycardia from broad complex? QRS what? Duration. So duration of QRS in which lead? Any lead. Maximum duration of more than 120. So if it is 120 above, it is broad complex. 120 below, it's narrow complex. However, there is a catch. Not in pediatric age group. Pediatric age group, it may be 100 milliseconds or even 80 milliseconds to say it is broad, because in a pediatric age group, up to 80 millisecond is the cutoff. It's more narrow because the heart is small. Okay. So it is in adults that you have this differentiation of 120 versus less than 120. Okay. Now we go on to narrow complex. So I will be able to not point in this. The first initial evaluation of any narrow complex tachycardia should be whether it is hemodynamically stable or not, right? Why that is important? So if you are having a patient with a tachycardia, you have seen in a patient and you have attached a rhythm strip on the monitor, right? And if the patient is hemodynamically unstable, what is hemodynamically unstable? So pressure below 90, but he has come walking to you. It is not hemodynamic unstable then. Anybody? So patient with a decreased mentation, if you would say. So decreased mentation with a low blood pressure is possible. So hypoperfusion, cold clammy extremities, patient's urine output is decreasing. That is one. Other two? Sorry? That doesn't help. The patient may have claudication, so not. Ongoing chest pain. A patient who is having CAD and patient has tachycardia, ongoing chest pain is a emergency to look for. And third is a patient who is in pulmonary edema. So these are the three manifestations of a hemodynamically unstable rhythm. If you have any of the three, what you should do? Cardioversion. Any tachycardia, but cardioversion directly ऐसे ही कर दोगे. Rule out sinus tachycardia first. However, do you cardiovert in sinus tachycardia? No, na. So Rule out sinus tachycardia, rule out that this is not sinus tachycardia, and then only cardiovert. And how do you cardiovert? In a narrow complex, it's always a synchronized cardioversion, okay? Not a asynchronization. No it's only in VF that you do defibrillation, that is asynchronous. In narrow complex tachycardia, it should be synchronized always, okay? So synchronized cardioversion should be done. So that is clear. Once you have a stable, you assess the patient, you have a stable rhythm, then what do? Take at least a 12 lead ECG before you give any medications. Many a times we receive, sahib, ye to patti ma joyi lidu ne dawa api didi. That is not what you should do. You should take a 12 lead proper ECG and if possible a long rhythm strip also. Any tachycardia, it will help and we'll see why. Okay. So the first thing that you should do is a 12 lead ECG, and once you take a 12 lead ECG, on a 12 lead ECG, what do you find? If you have a irregular rhythm, right, that is the step. Second, a irregular rhythm, what do? C for P waves. C for P waves. In a irregular rhythm, the next step will be C for P waves. If the P waves are absent, it is likely to be atrial fibrillation. Done. Your diagnosis is there complete. If P waves are seen and it is the number are more than QRS or equal to the QRS, but the P wave morphology is changing, more than 3 non-sinus P waves, that means it is multifocal atrial tachycardia. Irregular rhythm can also be in atrial flutter or atrial tachycardia with varying conduction, right? So that morphology of P wave will be single morphology, right? But P waves will be more than the QRS, okay? Now once you have seen that it is a regular tachycardia, so irregular is done, regular tachycardia, the next step would be to see whether P wave is present or not, okay? If P wave is absent, you cannot see a P wave in a tachycardia. What on a ECG, I am saying on a ECG, what should be your diagnosis? Regular tachycardia. So we go to that P wave not seen on this part. A P wave not seen, the first thing that you see is a R prime is present or not in V1 and pseudo S is present in inferior leads. And if it is present, it is likely to be AV and RT. We'll see examples. So this is the basic slide that we are going to carry. The next, if it is not there, will be STT changes and QRS alternance. If STT changes are present and QRS alternance is present, it's more likely to be AV RT. Okay. And lastly, if the patient has a slow rate tachycardia, 150, 160 rate with no P wave seen, it's more likely to be AV and RT. If P wave is seen, the next step is to see the A to V relationship, right? Whether it is 1-to-1 relationship, whether it is 2-to-1 relationship, or it is more or it is less, 1-to-2 relationship. So let us see 1-to-1 relationship. 1-to-1 relationship, what should you do? See for RP, the relation from the QRS to the P wave. If it is a short RP tachycardia, it is AVNRT, AVRT or atrial tachycardia. If it is a long RP tachycardia, it is atypical AVNRT, PJRT or atrial tachycardia. Okay? If A's are more than V's, it cannot be AVRT. Is it clear? AVRT has to have 1:1 relationship always. So if it is more than 2:1, then it cannot be AVRT. P wave morphology we will not go into. So with this background, this is clear. We will go into cases, right? I'll want your participation in this. So let us go to the first. What do you find? We'll go step by step, okay? The first step is, because I have taken a 12 lead, it is a hemodynamically stable. 12 lead ECG showing. No, step by step. Otherwise you miss some steps. Narrow complex, irregular QRS, P wave seen or not? Not seen. So it is atrial fibrillation. Very good. So my work is done. The first diagnosis, atrial fibrillation. Now this. So first narrow complex, regular or irregular? So what is the definition of regular and irregular? Same means how much same? Exactly same as chalega. It is not always the same. So up to 10% variation is acceptable in a regular tachycardia. More than 10% is irregular. Okay. So now if you see the fifth beat, if I can get something, no, it is not coming with this. It's not coming. એક મિનિટ કરું છું હું કરું છું ચાલો પણ નથી આવતું આમાં. Anyway, so if you see this, ફરે છે તો બહુ છે. So this, if you see, what is this? How many squares? This is 7 squares and this is 10 squares. So how can that be so much variation? So you have to see this rhythm strip. Always, as I said, take a 12 lead ECG and see a rhythm strip also. So this is very important. In a rhythm strip, it is showing irregularity. And once you see that irregularity, you see for P waves, right? You see this P wave is here, you see this P wave is taller, you see this P wave is down. So multiple morphologies of non-sinus P waves. That means what? Mat. Very good. So you have diagnosed the second also well. Now let us go to the third. So you have a regular narrow complex tachycardia. So the next step would be P wave seen or not. Is it seen? Present or absent? No, it is present or absent. I am asking you, P wave seen or not? R prime is not a P wave unless you see it. Right. So P wave is not very clear. So if you see this, then the next step would be R prime present or not. What do you see here? R prime here and S waves in, so S waves in inferior leads, 2-3 AVF. What does it mean? But what does it mean? Why it comes? Right. So AVNRT is from the junction below, and when it goes retrogradely 1 to 1, it manifests itself as a R prime or a pseudo S. That is 2-3 AVF negative P waves and positive in V1. So is it possible that this is not pseudo? That's very important, right? You have to see, compare it with the ECG on sinus rhythm. So if it is not present, R prime is not present in V1 and S wave is not present in 2-3 AVF, then only you call it pseudo, right? So pseudo S and R prime in V1, right? This suggests AVNRT, right? Okay? Come on. Narrow complex regular tachycardia. No. P wave seen or not? Don't skip steps. P wave absent. Are you sure? Seen. Yes, see. So V1 you can see this. So this is P wave, is it? So then what do we say? Long RP, short RP? Long RP tachycardia. And long RP tachycardia would be AVRT, or is it AVRT first? It's atypical AVNRT, PJRT or atrial tachycardia. That is how you go about. However, just in one lead, just a thing, why not this is P or this is inverted P? How do you know that? So compare it now. Nowhere else. So then? So we don't know. That's the answer. Don't be dogmatic that this is a P wave. So we don't know is a better answer. And then you can say possibly it's a P, I don't know. And then you go to the next step. Maybe it's not a P, and then we'll go to STT changes present or not. STT changes are present, QRS alternance is present or not? See in V1 also, so lead this, na? You can see alternate beat small, short. So QRS alternance is present, STT changes are present, likely to be AVRT more, right, as compared to atrial tachycardia. So now what do? You terminate the tachycardia maybe and always look in for sinus rhythm also. So sinus rhythm, does it show anything significant? Nothing significant. Good. Another patient. Faster. Very good. P waves are not seen. R prime is not seen, pseudo S is not there. STT changes are also not there. Right? So what do you think? Can be anything, AVRT, AVNRT, whatever you feel. So you terminate the tachycardia and you find this. Perfect. So what was that tachycardia? AVRT. So if you have a baseline pre-excitation, the likelihood that the tachycardia would be AVRT is more likely, right? So why it is narrow complex tachycardia? This is WPW is broad, na? So there are two kinds of AVRTs. One is the common variety is the orthodromic, which goes antegradally via the AV node and retrogradely via the accessory pathway. That is the most common. It results in a narrow complex regular tachycardia, while the other is antidromic tachycardia, which is a broad complex tachycardia. Okay? So the next. Narrow complex regular tachycardia. P wave is not seen. Are you sure it is not seen now? Now what you see in V1, you should understand this. See this. Now T wave cannot have a notch. That's very important. If a T wave has a notch, then you should think that there is a P on T. Okay, that is how you would recognize it. And in the same site, you can see that this ST is going down. So this is a going down like this. So it is a inverted P wave. Why STT changes occur in any tachycardia is the presence of a P on the ST segment. That is how the ST segments can be manifest. Okay. So now you have this tachycardia with a P wave which is present. So is it short RP or a long RP? Very good. Short RP tachycardia. So what are your differentials? AVNRT, AVRT or atrial tachycardia. Simple. Can you rule out any one of them? Based on this ECG, can you rule out any one of them? No, it can be all 1-to-1. So you cannot rule out, especially if you have a 2-3 AVF which is negative. So if you have 2-3 AVF which is negative, it is coming from below. So AVNRT is possible. However, if 2-3 AVF was positive, you could have ruled out AVNRT. Okay? Simple. 2-3 AVF positive in inferior leads means AVNRT is unlikely. Okay? P wave, P wave. This was inferior. If you see the inferior leads, the P wave was negative, right? This is a P wave which is negative. If it is positive in 2-3 AVF, it is unlikely AVNRT because it's coming from down below, right? That's how you get a pseudo S, right? Your eyes have to get adjusted to that slower mode. So slower mode is better when the rate is very fast, to be honest enough. When the rate is 200, then it doesn't help much. Okay. Come on. Narrow complex tachycardia. सब थक गए. बहुत जल्दी जल्दी है. So, did I ever tell how to differentiate all the three? No. Please go systematically. Again I am saying, narrow complex regular tachycardia, P wave seen. But why this is, it is long RP or short RP? When P wave is seen 1 to 1, then you have to see long RP or short RP. So long RP tachycardia, differential, atypical AVNRT, AVRT, atypical AVNRT, AVRT which is PJRT type, or atrial tachycardia, right? So can you differentiate again in this? Again, P wave is negative in 2-3 AVF, V1 is positive, it can be any of them. PJRT is generally CSOS, AVNRT is near that area, so it can be any one of them. But one characteristic you should always see, what is the rate of this tachycardia? It's a slow tachycardia. Generally, slow incessant tachycardia is with PJRT. Remember, because it's a slow conducting pathway, the tachycardia rate will be slow, incessant tachycardia, and therefore the chances that this is PJRT is more likely. And if you give carotid sinus massage and it terminates, it's likely to be AVNRT or PJRT rather than atrial tachycardia. Okay? Clear? P waves are seen, good. Short RP, long RP. In between RP, equal RP, right? You can put in both. So don't be dogmatic saying this is long RP, this is short RP. In AVNRT, generally it is shorter RP, right? That is why you get a pseudo R and S wave, right? It's very short RP. So generally this will not be AVNRT, okay? So now you see P wave. Now when it is a long RP or short RP, what do you see? It can be AVNRT. Is it AVNRT? No. Positive 2-3 AVF, and therefore you can confidently say this is not AVNRT. So either it is AVRT or it is atrial tachycardia, right? So one more thing, the P wave is very narrow, right? Can you think the P wave is very narrow? Right? This is very narrow, right? So generally a narrower P wave, then a sinus P wave would be more likely a septal origin. So either the pathway is near the septum or it is a atrial tachycardia arising from near the septum. Okay? Not seen, seen, not seen, not seen, seen, not seen. Again, please see all these things, na? Very sharp. You can see this hump kind of thing. So you have to see all the leads. If you have a T wave, it should be a very smooth character, right? If you have a peaked character, it is likely P on T, right? And once you see that, it's likely to be a P wave. And once you say that it's a P wave, it's likely to be the same way, right? AVRT, AVNRT, or atrial tachycardia. AVNRT, yes or no? No. Because 2-3 AVF is positive. Done. Atrial tachycardia or AVRT, right? So now the same patient with carotid sinus massage. Ah, perfect. Again, AVRT should have 1-to-1 relationship, but here now the P waves are more than the QRS. So the diagnosis was atrial tachycardia. Okay? So A is more than V's, diagnosis atrial tachycardia or atrial flutter. Okay. Perfect. Go ahead, fatafat. P wave seen or not seen? Seen where? V1. So it is what? Long RP tachycardia. Is it 1-to-1 tachycardia? The next question. Yes. Please always remember this. See this. This is P wave, right? You said this is P wave, but then why this is there? possible P wave, right? So if you, and anywhere else you are seeing this, yes, you are seeing this now. If you see this and this here, so it is a 2 to 1 tachycardia. What do you mean by 2 to 1? 2 P waves for 1 QRS. So therefore you cannot do RP and PR, right? So once that is there, it cannot be AVRT, that's it. It can be atrial tachycardia, it can be AVNRT also. 2 to 1 is possible, and it can still be atrial flutter also. When you have a heart rate exactly of 150, remember, heart rate of exactly 150. What is this? Heart rate? Exactly 150. Think of it as flutter. Okay? Always, and you can see this, na? Where is this? This is going down like this, and if I was to do like this, it will be like a sawtooth pattern, right? So think of it as a flutter, right? What is this? Flutter, same. So if you give adenosine, if you give a carotid sinus massage, you will get this kind of morphology. Typical sawtooth pattern in inferior leads, V1 will be positive, right? Typical flutter. Understood? Guess. Yes, so wherever they are sharp down, it is likely to say that this is more negative. Okay? Sharp down is more negative and sharp up is more positive. Okay? Chocolate question. Chocolate will be provided by Pragnesh bhai. I don't have. Yes, who did say that? Chocolate ક્યાં ગઈ? But AV dissociation નો મતલબ શું? So this is what? AV dissociation means what? A more than V or V more than A? That is AV dissociation. It can be anything, na? V more than A is also AV dissociation, A more than V is also AV dissociation, and it's not related. That's more important. So within the stipulated time, no chocolates received. Now again, narrow complex tachycardia. Your next step should be what? P wave seen or not seen? Oh, come on here, you should see all these P waves. This is a P wave, this is a P wave, this is a P wave, and this is a P wave. P waves are less than QRS or more than QRS? Less than QRS. So it is what? Huh? P wave less than QRS is atrial tachycardia. VT. કોણ હિસ્ટ્રી વાંચે છે? કોણ હિસ્ટ્રી લે છે બરાબર? Who takes a proper history? What is written? Tell me what is written. Read. Baseline LBBB. Now if there is a baseline SVT with LBBB, baseline LBBB is there, SVT will be what? LBBB or non-LBBB? If you have a sinus rhythm which is LBBB, if you have an SVT, the SVT should be LBBB or non-LBBB? LBBB, no, it cannot be narrow. So if you have this anterior wall MI, severe LV dysfunction, baseline LBBB, and you have a narrow complex tachycardia, it has to be VT. Clear or not? So history pehla lo. You have to have a good history and then go to ECG, okay? So that chocolate question did not come. Right answer, Eco Atlas book. Okay. હમણાં તો ચોકલેટ ગયો, મારે જ આપી દીધો. Yes. Yes. Whenever you have a P wave which is less than QRS, AV dissociation. How can a QRS be more than P wave? Means. So it is from the septum. Upper septal VTs are narrow. Even junctional tachycardias can have AV dissociation. So junctional tachycardias, AV NRTs and upper septal VTs can have V's more than A's. Okay. Chocolate question? Nahi. Book question. Eco Atlas book. Sorry? Excellent, huh? Book apo bhai wahan. Sinus tachycardia. So to recognize sinus tachycardia is very difficult. Very, very difficult. You know why? Because you try to find out a pathology, but that book will only suffice if you find the cause of sinus tachycardia, isn't it? So can you judge the cause of sinus tachycardia in this? To him only, nahi to ardhi book ka chapjo. Hai? Anybody. जोड़ती. अरे जोड़ती यार. Perfect. Pulmonary embolism. Why? See, RBBB is there. S1, Q3, T3. Is it very sensitive? No. It's just 20% of cases. Specific? Possible. 90% of cases may have this. Okay? So very important to rule out sinus tachycardia. Okay? અડધો કલાક પૂરો થાય છે. Narrow complex, I have to stop. Irregular or regularly irregular? Irregularly irregular or regularly irregular? Yes. So the last line again, the importance of a rhythm strip. That's the most important takeaway. Always see the rhythm strip. This may show one-to-one conduction, but this may show something like this. This is the P wave marching through the QRS, right? The P wave is coming in front now, and there is a drop here. Similarly, going till here, drop here. Similarly, going to here, drop here, right? So this is A's more than V's. P wave is clearly seen, and therefore it is likely to be an atrial tachycardia, right? Clear? So narrow complex tachycardia ho gaya. So what is a treatment? Just a basic of what is a treatment. Immediate treatment of a regular narrow complex tachycardia. So hemodynamically unstable, you cardiovert, right? You cardiovert. Cardiovert means synchronized cardioversion, okay? So medication, if it is a regular narrow complex tachycardia, do a carotid sinus massage, do a Valsalva maneuver. If it terminates, it's a AV nodal dependent tachycardia, okay? Remember this. If it doesn't terminate on these maneuvers, the next step is to give adenosine. 6 milligram of IV adenosine through a large vein in the cubital region, not in here, with a good saline push, should be given immediately, right? And once you do that, and within 10 seconds, 15 seconds, the tachycardia terminates, it suggests what? AV nodal dependent tachycardia, AV NRT, AVRT. Sometimes atrial tachycardia can also terminate. So to differentiate based on adenosine is not correct. As electrophysiologist, I would say it's not correct. However, garden variety, AVNRT, AVRT terminate on adenosine. Okay? Rarely we have to give calcium channel blockers or beta blockers. In which condition will you give? Not prefer adenosine. If it is not available, mongi pade chhe. If it is costly, a patient cannot afford, it's not available in the hospital, then only. So adenosine should be given in all patients with narrow complex tachycardia, which is regular. I'm saying regular, not in atrial fibrillation, okay? So asthma patients, those who have severe triple vessel disease, or patient who has been taking derifylin for any reason. Okay, so in that adenosine will not be given. Otherwise you have to give calcium channel blockers. Generally people give verapamil or diltiazem, whatever you can prefer. Beta blockers are less preferred over all these. And in atrial fibrillation, the drug of choice is not amiodarone. Please remove amiodarone from your head. Either it is a pill in the pocket, flecainide, propafenone, or IV ibutylide as the treatment of choice in a non-structural heart disease. Non-structural heart disease. In a structural heart disease, then only you give amiodarone. Okay? Clear? DC cardioversion can be done for a hemodynamically unstable or as a immediate procedure so as to get better the hemodynamics, and ablation for incessant tachycardia. We have given medications, the tachycardia continues, then ablation is done. For long-term management of a regular tachycardia, if no treatment is required, if it is the first episode or the patient is elderly with possible indication for a beta blocker, like patient is hypertensive and you want to give beta blocker for that also, you start with beta blocker. It will treat both the hypertension to a certain extent as well as the tachycardia recurrence. So if it is a very infrequent tachycardia, no need for daily treatment. If you have fever, you don't give crocin daily to prevent fever, right? You are not treating the tachycardia by this medication. You are preventing the recurrence of tachycardia by these medications, okay? So remember this, don't try to give a lifelong verapamil or beta blocker for a narrow complex regular tachycardia. Please don't do that again and again. I am saying it is just as a bridge if recurrent episodes are there to ablation, or patients in whom you have another indication like a CAD, maybe migraine, maybe something else that warrants beta blocker as such. Okay, clear? Medications is only for patients who have atrial tachycardia, atrial flutter or fibrillation with structural heart disease in which you know that your ablation may not be very effective. It can be used as a bridge to these in which there is no structural heart disease. In long-term medication, you prefer calcium channel blockers, sometimes with beta blockers. Digoxin, especially in the pediatric age group, is good. Flecainide for patients with atrial fibrillation is better than amiodarone with no structural heart disease. So don't try to give amiodarone to prevent atrial fibrillation in AFib. NOACs is important in AF. Ablation is the preferred treatment for recurrent narrow complex tachycardias. It gives you a lifetime treatment, one-time procedure. And if you have atrial fibrillation, flutter, you can treat with ablation. Lastly is cardioversion for a persistent atrial fibrillation. If you have atrial fibrillation in spite of medication, you can cardiovert this patient. Okay? Any questions in narrow complex? Because we have to go uphill. Broad complex is more dangerous than narrow, right? To understand. So any questions? We'll take a break. What is this place? You must have gone? Eh? Pavagad che bappa. How? This is Pavagad. So it is just 40 kilometers from here. You must have taken to SOU, right? This is Pavagad. Go there. So I'll keep this now as my first slide. So should we go to the next? Anything? Anything that you would comment in narrow complex?
Fantastic talk.
Yes. Thank you. Sorry?
Frequently, what we are telling, frequent episodes of narrow complex needs EPS.
Yes.
What is the definition? How much we should say frequently, weekly, monthly?
It is subjective, na? Frequent to you, so frequent to a dadi will be different than an active individual, right? So in general, more than 3 episodes a year is a frequent episode, but it is very subjective. Means a patient who is very active, who will have to run to a hospital, right? From a distant place maybe, and the patient is very much symptomatic in the first episode, did not get treatment well in the first episode or did not respond to treatment, may be an ideal candidate for a ablation in the early itself. right? While a 70, 80-year-old gentleman who can be given beta blockers, is not very active, can be kept on medical follow-up for some time. Okay, so broad complex tachycardia, why it is important? Yes? So normally if you find a typical history of AVNRT, વળ્યા એટલે ઝુકને से ચાલુ हो गया. The act of bending is an important inducer of a tachycardia, a narrow complex tachycardia. So if you want to tell a patient don't bend, એટલે કોઈકના પગે નહીં લાગતા. That is not appropriate, right? They'll have to bend. So then you can tell patients that if it starts, you can do Valsalva maneuver like straining at stools, maybe cough violently, or you can do a gag to terminate the tachycardia. That can sometimes terminate the tachycardia in 10 to 20% of cases. So that is a lifestyle change that they can undergo. For atrial fibrillation, patients who snore, their weight reduction is very essential, and snoring is actually a very important factor for atrial fibrillation. And always any patient, if you find for atrial fibrillation and if the patient is obese, get him to decrease his weight. His episodes will decrease most of the time. For MAT, definitely lung issues and medications need to be optimized. And for atrial tachycardias, I would say that you wait for 3 to 6 months. Generally, 30% of them will resolve on its own. So don't keep them on lifetime medication. You can maybe 3 months, 6 months medication, taper it off and even stop it if they don't have recurrence. ज़्यादा से ज़्यादा क्या होगा? Recurrence होगा, right? No atrial tachycardia or SVT should receive ivabradine. It is only for sinus tachycardia. Now there are a group of atrial tachycardias in which we have published a report how to recognize that, but that is a separate entity. So automatic atrial tachycardias would respond to ivabradine, but not any other tachycardia. So ivabradine is not to be used for a pathological narrow complex tachycardia, except inappropriate sinus tachycardia. Inappropriate sinus tachycardia. Okay, so the most important thing on a broad complex tachycardia is it incorporates a true broad complex tachycardia and also a narrow complex tachycardia with aberrancy. So it incorporates everything. Understood? So now you have to differentiate whether it's a true broad complex tachycardia, which is a VT, and a narrow complex tachycardia with aberrancy, right? So how do you differentiate that? That is step 1. And the importance of a broad complex tachycardia is people think that a broad complex tachycardia can be dangerous, right? People think. Now do you think? Why? See, he is saying stable patients don't have any complaints. So is it correct? The problem with broad complex tachycardia is unless you have investigated, you associate it with structural heart disease. While narrow complex, you don't associate it with structural heart disease, right? That is the whole thing. So if you have a narrow complex tachycardia, say atrial fibrillation or flutter with mitral stenosis severe, it is dangerous, right? But if you have a narrow complex tachycardia with no structural heart disease, it is not dangerous. While VT, unless proved otherwise, you are associating it with structural heart disease. That means CAD, HCM, DCM, like that. And therefore, it might be dangerous. So that might be becomes a synonym with dangerous for everybody unless you rule out structural heart disease in the first instance. Okay? So that is the most important thing. Now, the difference on an ECG is what you want to recognize, right? But clinically, how can you differentiate VT with SVT? Anything? A history of any cardiac illness prior, especially LV dysfunction, makes 95% of a broad complex tachycardia a VT, unless proved otherwise. So if you have a history of CAD and you have a broad complex tachycardia, think it as to be a VT. Okay, don't try to even differentiate, treat it as a VT. Patients who have Canon A waves, changing heart sounds, they may have more likely to be a VT. Okay, so that clinical we'll see on ECG only. So here SVT with aberrancy is A more than V or A is equal to V. Rarely is A less than V, but most of the VTs have V more than A. It can still have V equal to A because the retrograde conduction from the ventricle can go to the atrium. Okay, 1 to 1. And that is not a very good way to differentiate the two. So retrograde VA, if it is 1 to 1, it can still be a VT. If you have a AFib with ventricular tachycardia, you can still have A more than V, right? So that can coexist also. The most important is this 3, right? AV dissociation. So what is AV dissociation technically? It is the A and V don't have any relationship, but for a VT, the A's should be less than V's, okay? So that is one. A fusion beat and a capture beat, and we'll see with example, right? They are commonly seen in VT, but not seen in SVT with aberrancy. A QRS morphology is typical, so it has to be either right bundle branch block or left bundle branch block as compared to the same sinus rhythm, or it can be rate related in SVT with aberrancy. While this will have atypical in nature, rarely it can be of the same morphology if it is a bundle branch reentrant VT. Axis doesn't change significantly, but if you have a change of more than 50 or even 70 degrees from the baseline with a northwest axis, that is AVR is only positive, that means it's likely to be a VT. A QRS duration in a VT can be more than 160 milliseconds. Rarely it will be more than 160 in a SVT with aberrancy because it's the bundle branch that is getting delayed. What is concordance? Chest leads V1 to V6. If it is negative, all is negative, it's likely to be VT because it's arising from the anterior area, apex to base. SVT with aberrancy cannot go from apex to base, right? So a negative concordance or a positive concordance makes it VT more likely, okay? Irregularity is more with atrial fibrillation. Irregularly irregular is AF, unless proved otherwise, can be present with this. I don't think so you need to differentiate AF from this. We'll see examples. If the onset is with a P wave, then it is a SVT. With a QRS complex, it's a VT. And in sinus rhythm, if you have pre-excitation, atrial enlargement, SVT becomes more likely as compared to a ventricular tachycardia in which you have scarred myocardium, okay? So we'll see examples. Before that, Brugada algorithm and Verikes algorithm, right? सबको पता है कि मेरे को बताना ही पड़ेगा? गुम जाते हो ना? अभी नेक्स्ट टाइम जब ब्रॉड कॉम्प्लेक्स टैकिकार्डिया हो ना, तो ये याद रख के बाजू में रखने का, और हर बार याद करोगे तो every time you will remember and every time you will understand also. So Brugada algorithm, I'll tell you what is important in this. Absence of RS complexes in precordial leads. That means what? Concordant. Either it is totally positive or totally negative. No RS, right? So वो सोचना जरूरी है. ये वो थियरी लगा दिया पर पता ही नहीं क्या बोल रहे हो आप, क्या सोच रहे हो. So absence of RS means negative concordance or positive concordance. That means it's a VT. R2S interval of more than 100 milliseconds in one precordial leads, not V1, one precordial lead, any one. What does this mean? So from a ventricular tachycardia, which is generally scar, the initial is in the myocardium, scar tissue, slow conduction, and then involves a more myocardium, so fast conduction. So initial slow, later fast. That means it is likely to be a VT, okay? Third, AV dissociation we have seen, fusion beat, capture beat, and P waves less than QRS, right? And last is morphology criteria, right? Typical RBBB or atypical RBBB, typical LBBB or atypical, we'll see with examples. The same Verikes is very easy. AV dissociation present means it's a VT. Second is R in AVR. R in AVR means northwest axis. R in AVR means northwest axis, cannot be present in SVT with aberrancy. Then comes the morphology criteria, and this is the same. VI means initial part of QRS is slurred as compared to the terminal half of QRS, which is the same as this criteria. So ऐसे कान पकड़ रहे, कोई ऐसा कान पकड़ रहा है, कोई ऐसे कान पकड़ रहा है. So it's the same criteria basically. It is based on AV dissociation, it is based on your morphology, it's based on the presence of initial slur and later fast. Okay. So let us see examples. This is an easy example for you. All these criteria are for broad complex regular tachycardia. Please understand broad complex regular tachycardia. Okay. Sorry? No, broad complex regular tachycardia. Now the first absence of RS is there or not? So RS is present, R and S is present. So this concordance is not there. Second is R2S. So R2S is more than 100? Yes. So then the second criteria is met. Now if you go by Verikes, then AV dissociation is the first, right? So then that's easy. So always look for P waves in V1 and lead 2. Because V1 the P wave is very clear and lead 2 it is very clear most of the times. Therefore you look in that leads. So here you can see P waves, a P wave here, P wave here, P wave here, which is less than the QRS. So this is AV dissociation present, likely to be a ventricular tachycardia. Okay, good. But there is a 1-to-1 P wave. So your AV dissociation is gone. So AVR is negative now. Then next. So it is a LBBB with right axis and it is a typical LBBB morphology or not? It's not a typical. There is no initial R. And you can see the initial slur, right? From year to year it is 100 milliseconds. Initial slur and terminal fast. So it's likely to be a VT. But why 1-to-1? Something I can do a carotid sinus massage and you can see that 1-to-1, 1, 1 and then the P wave is dropped. Then P wave, P wave, P wave and dropped. P wave, so retrograde VA venke back. Okay, so you can do even a carotid sinus massage to see that. What is a fusion and capture? Basic understanding is a must. What is this beat? It's a narrow beat in a broad complex rhythm, right? Why capture? So first, for a capture, it should come early. Capture should come early because something is getting captured before the broad complex rhythm comes. So this comes early and has to be preceded by a P wave, right? You have to look in for a P wave whether it is present or not. So generally P wave will be present. So P wave present with this, a capture beat which is similar to a sinus beat, right, in a broad complex rhythm. And what is this? This is a fusion beat. It is not very broad, but it is in between this and this, right? So dono ke beech wala hai and this is a fusion beat, right? Understood? So now you can see this rhythm. You have a capture beat, you have a fusion beat, and you also have a P waves which are lesser than the QRS, right? So this is a typical ventricular tachycardia. So remembering a QRS morphology, you can see SVT with aberrancy. V1 should have an initial R, a faster initial stroke, and then the slurred is later, right? In a SVT with aberrancy, in a LBBB. In RBBB, the R initially is smaller as compared to the terminal, right? RS, R dash. R dash is bigger than R. Always, right? All these three. While in a VT, what you have is the initial R is taller than the later R, right? So that is, or you have a QR. So remember this, it will help. For a LBBB VT, you have in V1 QS pattern or initial which is very slurred as compared to this, right? This is a very sharp. This is for septal activation. This is slurred. This is ventricular activation, okay? And in V6 it's not very important, but remember this. So in RBBB you have an S wave, but in VT you can have a QS pattern or a deeper S wave as compared to the R wave. Okay. So to bring this example, this is a RBBB which is typical sinus beat, R smaller than S and R dash, right? While in a VT you can see this, R is taller in the first and then smaller, right? So in the same beat, baseline RBBB, you have a ventricular beat, right? It's not aberrancy. The slurred from year to year more than 100 milliseconds. Sometimes you will have to see these kind of beats. So it's not in V1 or 2, you will see this kind of thing, right? Notches at regular intervals. This is a possibility of a P in the QRS, right? So that is what you would see, that this is less than this and therefore likely to be AV dissociation. So if I were to go with criteria, it's a broad complex tachycardia with this is positive or negative, I don't know. Yeah. So if you are finding it difficult, this is negative, right? So this is negative, go down, 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 and this is positive. So lead to is positive. So you can go like this. So this is positive and therefore you go loud, this is positive. Okay. So initial slur you can see 100 millisecond and above, and it is broad complex more than 200 milliseconds, so it's likely to be a VT. This one, broad complex regular tachycardia, bolte jao, bolte jao. Apply the criteria, means you have to do that, means present or absent. I have shown arrows, this is P wave. So it is one-to-one conduction. It doesn't make any sense. Now you don't have a fusion beat, you don't have a capture beat, and you have one-to-one conduction. So AV dissociation absent. AVR is showing, bas to pati gyu. It's a VT likely. But you see for others also, right? It is a RS and here is deep S wave, right? So it is a atypical bundle branch block morphology and therefore it's likely to be a VT. So concordance, that is negative in all. You can see V1 to V6 negative, so absence of RS, and positive in V1 to V6. It's more likely to be a ventricular tachycardia, right? So let us see this example. So no, AV dissociation present, absent? Absent? Present or absent? Jodhti? Absent. AVR? Negative. So again not a VT. Third? Morphology criteria. Morphology criteria means typical LBBB or atypical? Typical, na? R ekdam narrow che, main kidhu na. It is a very narrow R initially. So narrow R initially S wave and typical no Q waves in V5, V6. So typical LBBB. Last is initial slur faster or later slur faster? Later is slower, maybe don't know, so keep it that way only. So it is likely to be SVT with aberrancy. SVT with aberrancy. Hi sir. Next time કે પતી ગયું. સો આ ક્યાં છે? પાવાગઢ ઉપર તમે ચડીને ગયા ને તો જોશ તો હોવું જોઈએ. સો પાવાગઢથી નીચે આ દેખાય. હા, broad regular, now irregular broad. Ventricular fibrillation everybody knows. Torsades everybody knows. Polymorphic VT everybody knows. No. AFWPW everybody knows. That is a problem. Okay, chalo. એનો શું મતલબ? તો
but how do you say this is WPW? તો કાઢી નાખું, લખી દઉં? ના તો બોલો ને શું છે? First, it is irregularly irregular. That you have to understand. It is broad, right? It is fast, it is broad and irregular. But does it make it a WPW? So how do you know? How do you know it is WPW? See the smallest RR interval. If the smallest RR interval is less than 1 square, that means the heart rate is more than 300. If it is more than 300, can a bundle branch go fast than that? No, it is unlikely. So such a fast tachycardia will only occur if there is a accessory pathway, and therefore it is more likely to be a AF WPW. How do you treat this? Shock the patient or doctor? Shock to the doctor. ये है, चले जाओ. How many shock? How many of you will shock? How many will give amiodarone? No. Why? So you will not treat. So nobody will shock, nobody will give amiodarone, and therefore refer. That is what I understood. तो अच्छा दूसरा क्या करोगे? देखोगे आराम से ऐसा? एडिनोसिन कौन देगा? How many will give adenosine? IV adenosine? कुछ भी नहीं करोगे यार, कुछ तो करो. शॉक करेंगे, शॉक करेंगे. So शॉक ओनली. व्हाट शॉक? मैं इलेक्ट्रिकल तार पे लगा देने का ऐसा? DC shock. So cardioversion, again it is a DC cardioversion, not of defibrillation. So you have to do it synchronized to the QRS complex. Why not amiodarone? So amiodarone has an initial beta blockade effect, and therefore it can actually degenerate into ventricular fibrillation. However, if you don't have a shock machine, then what do you do? फिर you give amiodarone. तो shock machine रखो ही मत amiodarone देने के लिए. The treatment of choice is procainamide basically, but you don't have it available, so you have to give either amiodarone if you have medication, but shock is the treatment of choice for this. So you want to refer to the CVTS guy also to have a fractured rib, huh? Yes? Fast, broad, irregular. हैं? हैं? No, sorry now. इसलिए तो रखा है, नहीं तो क्यों रखता? What is this? Fast, broad, irregular according to your definition, na? So WPW? Who? To the patient or to you? To us. No. So again, you have to go via the same criteria. You can see here, na? You can see a typical LBBB. It's a typical LBBB, right? And it's a irregular rhythm. But in a narrow complex, you don't have a very well-formed P wave, but you can see a very small. So a later QRS has removed the aberrancy. So this is SVT with aberrancy basically. So it's a AF with aberrancy. So to differentiate this from this, you can see the initial slur is more. WPW is like a VT. Approach it like a VT and approach this as SVT with aberrancy. Okay? So initial slur is sharper as compared to the later slur. Okay? Shwetal madam not allowed. Broad complex regular tachycardia or irregular tachycardia? अच्छा चलो यहाँ Typical RBBB, atypical RBBB. Typical. Typical है. Second is taller. RBBB left axis, so it becomes a VT. ऐसा कैसा? पर नीचे देखो ना, क्या है नीचे? रिदम स्ट्रिप में क्या है? फ्यूजन है. अरे रेगुलर है कि इरेगुलर है वो तो बोल दो. See this. See this 10 squares, 11 squares, see this 7, 8 squares, irregularly irregular. What is irregularly irregular? Atrial fibrillation, ventricular. ऐसा मत बोलो यार. This is atrial fibrillation with aberrancy. Please see a rhythm strip. Again, advice. Please see a rhythm strip. Though it may look as regular here, though it may look as VT here, you can clearly see this as atrial fibrillation with aberrancy. Okay? Please remember this. What is this? किसने 12 लीड ECG लिया बताओ अभी? VF में कौन 12 लीड ECG लेता है? लेने के बाद ही पता चला. देखो क्लिनिकली पता ही नहीं था कि वो मर रहा है. This cannot be taken. This cannot be taken. A patient is dying in front of you and you are taking a 12 lead ECG, attaching and then showing it as VF. This cannot be taken. This is criminal. सबको पता है, right? This axis ना ये DNA वाला type torsades. Torsades is generally preceded by what? Long QT, right? Remember this. So going on to torsades, but multiple morphology, the QT is borderline, right? So this becomes a polymorphic VT. You don't have a torsades, but this is polymorphic, multiple morphologies. Polymorphic VT, again? हाँ क्या ना? तो ये क्या है? नहीं नहीं नहीं, ये क्या है? होल्टर में ऐसा बहुत मिलेगा तुम्हें और सब VT भेजोगे तुम लोग मेरे को और फिर देन आई विल सेइंग नहीं नहीं ये डॉक्टर तो गलत है एंड फिर बोलोगे ये डॉक्टर अच्छा नहीं है उसके पास मत जाना. Artifacts. Yes, so the artifact, this is an artifact actually. This tells you that there is a QRS. That's very important. If at any point of time in a 12 lead you have a QRS which is coming clearly, you can see here also, right? Which is coming clearly. These are all artifacts. So please, please, please think about artifacts if you have this kind of rhythms, right? How can you recognize artifact? They are not present in some of the leads, or a patient is alive and doing well. Pulse is, if you check pulse is regular, 60 per minute, 70 per minute, and you have this ECG, okay? That's how you can see. Very easy, I'm sorry. कितने क्या है कहाँ है कावी कंबोई. Specific patterns are there, right? Relatively narrow complex, so you call this a narrow complex tachycardia, right? But it is RBBB in morphology with left axis deviation. You term it as SVT with aberrancy and you give verapamil, it terminates. What is the diagnosis? Fascicular VT. Remember this, some people will come one day to you, you will term as SVT with aberrancy but terminates with verapamil also. So RBBB, which is atypical, left axis deviation, relatively narrow, terminates with SVT, it is fascicular VT. LBBB, V1 is negative and 2,3 AVF positive, RV outflow tract VT, idiopathic VTs, right? Structural normal heart. RBBB inferior axis, LV outflow tract VT, non-sustained VT, right? So to say outflow tract VT, you should have two things. 2-3 AVF should be positive, that is the inferior axis, and AVR and AVL negative. So for a outflow tract VT, 2-3 AVF positive, AVR, AVL negative. Okay? If it is RBBB, it is left ventricular outflow tract. If it is LBBB, it is right ventricular outflow tract. This is a patient with a baseline rhythm and this is the tachycardia. Same, right? What does it mean? SVT with aberrancy or bundle branch reentrant VT. Okay? Bundle branch reentrant VT. Typical pattern, baseline PR prolongation, trifascicular block, and you have a VT of the same morphology. This is, we'll leave this. What is this specific pattern? Bidirectional VT. One is negative, one is positive. One is negative, positive, negative, positive. Bidirectional VT is characteristic of CPVT, digoxin toxicity, right? Chocolate question. कहाँ गया? Chocolate नहीं. Eco book question. Who said pacing? Pacing वहाँ. It is a pacemaker. It is a pacemaker rhythm. Spikes दिख रहे हैं? हाँ, दिखे तो सही कुछ. So it is very important to see the ECG properly. You can treat this as a broad complex tachycardia, but you just see that this is a pacemaker and patient has a PMT, pacemaker mediated tachycardia, right? So these are the specific patterns that we talked about. क्या? कहाँ है? प्रज्ञेश भाई कहाँ है? અઘરા છે નહીં, 2 કલાકથી અહીંયાથી 2.5 કલાકનો રસ્તો. હું ગવર્મેન્ટ ઓફ ઇન્ડિયા નહીં ભાઈ. This is Vilavdar. It's a black buck sanctuary. So the indication for therapeutic would be for a narrow complex tachycardia, which is idiopathic in nature, VT, and for atrial flutter and fibrillation if recurrent. It can be used as diagnostic for palpitations and syncope, and it can be used for prognostication purpose in patient with severe LV dysfunction. So this is how we do EP studies, go into the heart, check the arrhythmia and treat it permanently. આ તો ક્યાં છે? આ પાવાગઢ ચાંપાનેર છે, પણ પાછળ પાવાગઢ છે. Thank you.
Hats off to you. Thank you very much.
Thank you.
Thank you very much. Friends will all agree that he is not only extremely good in his subject, but he is a very good speaker and a very good teacher. And this is, I must say that in a conference like this was one of the best talks on this subject that I have attended.
Thank you.
Thank you very much.
Thank you.
And I also thank the audience for participation. It was very good. You know, like such sessions become live, full of life because of participation of the, audience. Otherwise, he is teaching so well, and if everybody had sat just like that.
No, it is always good to have participation. Even if you don't know, participate.
Exactly.
Nothing.
Exactly.
I will not remember you.
And in such, of course, for very good answers on difficult questions, there were chocolates and books. And for wrong answers, there was no punishment. So you don't need to worry.
Yeah,
so,
it gives you a stimulus to maybe read. Next time you go technically well, try to see it in all patients what points where what we discussed is more important rather than just try to say this is tachycardia and we'll see what happens. We'll give amiodarone. Don't worry.
Right. So, extremely good. Thank you very much.
Thank you. Yeah.
sending patients with ECG so that they want to give some medication which can increase the QTs. And they come with RBB or LBBB, what should be done at that time?
So when you have a RBBB, LBBB, the problem is QT will be prolonged artificially. So you remove that part of it, maybe 100 milliseconds minus. So you do a QTC of that and minus 100 milliseconds from that. And that is the corrected QTC. So from the corrected QTC, so that is corrected QTC minus 100 millisecond in presence of RBBB or LBBB, which is nearly 200 milliseconds QRS, right? So just one question. Broad complex tachycardia, unstable, what will you do? VF nahi hoga, to cardiovert, DC cardiovert. What, and defibrillate if it is a VF. What is difference between the two? Shwetal madam is not allowed.
Hello.
So if you DC cardiovert in a VF, what will happen? It will not deliver because it cannot synchronize. So remember this, काफी बार ऐसे sync on है, patient को दबा रहे हो और shock ही नहीं जा रहा है, देखो तो सही sync on है, right? So sync should be off. And if it is a stable tachycardia, what will you do? Still cardiovert. If hemodynamical, what? So evaluate and medical. If it is a no structural heart disease, think of SVT with aberrancy also. In those patients, you can actually give adenosine and see. Many a times it will be working. But if you think that this is actually a VT, then you can still give what? Beta blockers, amiodarone, procan. Structural heart disease, don't give ibutylide. Structural heart disease, don't give ibutylide. No structural heart disease, beta blockers can be given, calcium channel blockers or adenosine can be given for a broad complex tachycardia. I'm not saying VT, for a broad complex tachycardia. But for a broad complex tachycardia, structural heart disease, amiodarone or lignocaine. That's what you have easily available, right?
Thank you, Dr. Shomu. Now I would like to call upon stage Dr. Shekhar sir to felicitate Dr. Shomu Bora. Now I would like to call upon stage Dr. Tanvi to felicitate Dr. Shekhar and Dr. Sagar. And now for our next session, I would like to call upon chairpersons Dr. Nikun Chovatia and Dr. Patil Prasad. Dr. Kamaldeep Chawla is currently the HOD and Senior Consultant at Sterling Hospitals, Vadodara. He is an MD, DNB Cardiology, FD, FRCP from Edinburgh, FACC, FESC, FSCAI and FICC. He has done his fellowship in Interventional Cardiology, ICPS from Paris. He has published multiple research papers in international Indian journals. And he's the author of the book Management of Diabetes Mellitus, a Complete Practical Guide. He has given several talks of national, regional and state conferences. He's the best cardiologist of Vadodara 2022 as per the Times of India. Thank you.
Thanks, madam, for the kind words, and many congrats to Dr. Pragnesh Shah for
organizing such a wonderful conference here in Vadodara, focused only on pure cardiology. Shomu is there or he left? Yes, sir, yes, yeah, okay. So wonderful presentation, Shomu, but I have a complaint against all you EP guys. You put up one slide like VADODARA where there is not a single black buck and you expect us to answer that it is VADODARA. I mean, it's so... No, but black buck in VADODARA is the QRS, yaar. Come on. So don't try to confuse us, okay? So coming back to my talk, dyslipidemia management beyond statins. So this is bread and butter for all of us. And I'll be taking you to this journey. So why this topic is important or why it has been chosen, I don't know, but I'll try to justify it. So Fredrickson classification, just a recap for all of us. Phenotypically, class 1, 2A, 2B, 3, 4 and 5, depending on which component of the lipid profile is elevated. So primarily triglycerides, it's type 1. Primarily LDL involved is type 2A. LDL and VLDL, so again, focus on LDL when we see is type 2B. Type 3 is like intermediate, wherein plasma cholesterol, plasma triglycerides, everything is highly elevated. Type 4 is where VLDL as a component is increased. The rest of them are not majorly increased. And type 5 is VLDL and chylomicrons. I think in our clinical practice, we don't pay much attention to type 5, right? So what are the available lipid-lowering drugs? So bile acid sequestrants, cholestyramine, celestipol, and one of the molecules which I can't even spell and not available in our country. Cholesterol absorption inhibitors, azathimide, fibric acid derivatives, gemfibrozil, fenofibrate. Statins, that is HMG-CoA reductase inhibitors. All of us use 90% in our practice. Niacin, nicotinic acid, and statin plus niacin, which came and has gone also out of market, right? How many of you in this room have used cholestyramine? None of you have used. How many of you have used gemfibrozil? Madam has used, okay. I have used gemfibrozil for myself. My triglyceride 10 years ago was 1400. But one course of gemfibrozil brought it to normal. After that, statin and no need of any other molecule. Very well maintained after that. So what are the newer drugs? The topic is beyond statin. So what are the newer drugs available? So all of us are aware of PCSK9 inhibitors. That is pro-protein convertase substilin kexin type 9 inhibitors, evolocumab, alirocumab, now being available. They have been introduced to the market. How many of you have used PCSK9 inhibitors? Then apolipoprotein B synthesis inhibitor, that is mipomersen. It is going to come, not yet available. Microsomal triglyceride transfer protein inhibitor, mainly for Indian subcontinent. This is going to be the molecule. Lopitapine, which basically gives good reduction of triglyceride. So patients like me who were 10 years ago may now go on this type of molecule. And CETP inhibitors, that is torcetrapib and dalcetrapib. They are available in the Western world. I'll not go into the details of physiology, but the modern concept of lipid-lowering strategies is concept change 1, start early, less lipid exposure leads to prevention of lesion formation. So anybody has a risk factor also is to be initiated on one of the therapies. Concept change 2 is treat much more aggressively from desirable target to LDL cholesterol near elimination in the blood. This is a new concept that is coming in and I'll take you through this journey. And concept change 3 is use combination therapy like statin plus ezetimibe plus minus the new PCSK9 inhibitor so as to reduce LDL cholesterol to the maximum. So over time, with emerging data, the targets have been evolving. Earlier, the targets to start cholesterol-lowering medications was 190, then brought down to 160, right? If you see the ASCVD risk categories and treatment goals, it began that even in low-risk patients, you should bring down LDL to 130, which once upon a time was 160. Then in high-risk patients, like 2 risk factors or diabetes or CKD, bring down to 100. Then the new data came in and those having established clinical ASCVD that is proven atherosclerosis. In any of the territories, you bring down LDL to 70. And now, with the latest European guidelines, the guideline is that if patient has established progressive or history of premature ASCVD, you bring down LDL cholesterol to 55. So all of you clinical cardiologists in this room, how many of you think it is easy to bring down LDL cholesterol to 55 with only statins? Not majorly possible. LDL cholesterol goal threshold among various cholesterol treatment guidelines and consensus statements for the highest risk patients, which are diabetic CKD. The 2019 EAS guidelines have also come to a point of saying that bring it down to 40. Though in 2020 we have evolved around 55 as the target. So why the goals are lowering? We all were aware of something called Cruikshank's J curve, right? So once upon a time the data came that below certain level of cholesterol, LDL cholesterol, there is mortality. But with the new data coming in, with new studies chipping in, the lowest is the best, and that is what we have to obey because this is the guideline or evidence in the present era. So the lower the achieved LDL cholesterol values, the lower the risk of future cardiovascular events with no lower limit for LDL cholesterol values or J curve effect. This is the consensus statement from 2019 EAS guidelines for management of dyslipidemia, lipid modification to reduce cardiovascular risk. So coming to us sitting in our clinics, are these realistic and achievable, and how? Will patient with compliant with aggressive therapy? And if you go on to more statin dose, you add ezetimibe, you add something else, more cramps, more leg pains, more non-compliance. Most importantly, what is the target for my patient? The clinician's dilemma, which is a universal target or risk-oriented approach. So the treatment goal for LDL cholesterol, when the score is less than 1 or low risk score is 116. For moderate, when the score calculated by ASCVD is more than 1% and less than 5%, it is moderate, that is 100 milligram per deciliter. For when you want more than 50% reduction from baseline in the high risk category or very high category, the targets are 70 milligram per deciliter and 55 milligram per deciliter. So I would like to ask one of the senior colleagues from Vadodara who has the highest database of cholesterol patients. Sir, would you bring down cholesterol to 55 for your angioplasty patients? Thank you, sir. Yeah, I also believe in the same thing that one vessel angioplasty, no other risk factors will keep around 70, but the highest risk, any other confounding, especially diabetics, we'll try to bring it down to 55 milligram per deciliter. So, very busy slide. We all know that statins do have its own demerits in forms of leg cramps, myopathies, non-compliance because of overall fatigue. And when you see that you have prescribed statin, ultimately it's only 70 to 80% of the patients who stick around to that therapy. So statin-associated muscle symptoms are one of the most common side effects of statins. And over-the-counter patients don't go to buy it, but still they don't listen to us when we impress upon them about having statins to the purest forms. However, the data says that statin is one of the most important part of your prescription and you should never miss that prescription in your patients. So what we can add to statins is ezetimibe, when we add fenofibrates, when we add bile acid sequestrant agents, and when we add niacin. So the major reduction in LDL that occurs even on a total dose of statin plus ezetimibe to all these molecules is somewhere around 5 to 15% reduction only that you get. So if your target is 70 and you're going to get a 10% reduction, it still comes to 63 milligram per deciliter and not 55, which is the goal. Omega-3 fatty acids are a good substitute for HDL cholesterol, but nothing to do with reduction in LDL cholesterol. So every doubling of statin dose causes on an average only a 6% additional reduction in LDL cholesterol concentration. So, we have cholesterol around 120 and we want to bring it to 70 and we make from 20 to 40, it's not going to do anything for our patients. PCSK9 inhibitors, very promising. I have almost 11 patients right now currently on this. The youngest is 21-year-old patient with stented 2 years ago in Ahmedabad, but 3 MIs after that stent and always a flowing artery. So we don't know, but I have kept him on PCSK9 inhibitor now. So concerns with PCSK9 inhibitors are, one is cost is a very important consideration because it comes to almost 20,000 per month with that. Influenza-like symptoms occur usually with the first dose, not after that. And it's a sub-Q injection, patients may not want it. And now we have a new introduction in form of bempedoic acid, which is the first oral once daily non-statin LDL cholesterol lowering medication. So in this group, one medication has come after 20 years almost. It causes LDL cholesterol reduction with a first-in-class mechanism, and now it's commercially available. The dose is 180 milligram orally to be taken at night time along with statin. Indicated in adults with established ASCVD or heterozygous familial hypercholesterolemia as an adjunct to diet and maximally tolerated statin who require further lowering of LDL cholesterol. So it acts on the same pathway as statins but at a different level. Targets a different enzyme called ATP citrate lyase enzyme. So basically in the cycle of HMG CoA reduction, it acts at another level to causes complete blockade. So you can just remember what complete RAS blockade was. So something of statin and bempedoic acid will cause complete blockade of the HMG CoA reductase inhibitor. Because of this additional feature, bempedoic acid has a protective mechanism against myotoxicity. The BA neither have any other effect on cholesterol synthesis in muscle cells or induce any muscle-related side effects. So CLEAR trial was one of the largest, clinical trial programs involving almost 17,000 patients randomized to either receive placebo or the molecule. And as you can see from the data that is shown over here, almost 23.5% reduction in hypercholesterolemia who were unable to tolerate statins, and persistently hypercholesterolemia despite maximally tolerated statins to the tune of 16%. So it's a good reduction. There's no major side effect of bempedoic acid. Only two things we have to remember. One is keep a watch on uric acid, and second is keep a watch on RBC count, because it's known to cause reduction in RBC count, and we have to keep a watch on that. So Lipid Association of India also now has our India-focused expert consensus guidelines, consensus statement of 2020. And they say that high-intensity statin, if you want further reduction, ezetimibe. If you want further reduction, then you can add bempedoic acid or PCSK9 inhibitor, depending on the role. At this point, a question might come that where you should use exclusively PCSK9 or where you should use bempedoic acid. So the data that I have analyzed, beyond scope of today's talk, it says that in ACS, if you want to initiate, better to start with PCSK9 inhibitors. And in a routine clinical practice, when you want to start, bempedoic acid is better in the indications that we have shown. So inclisiran is one of the newest molecules which will be entering very soon in India. It's a PCSK9 inhibitor approved by FDA in 2020 and will soon come to India. Orion was one of the trials which launched inclisiran and its effects on LDL cholesterol, showing almost a 40% reduction in LDL cholesterol with inclisiran. So will there be a vaccine against atherosclerosis? Yes, there are some features going on, and we may soon have a vaccine focus for atherosclerosis in terms of targeting the lipid molecule. Will new technologies prove disruptive in the practice of preventive cardiology? So yes, we will. This PCSK9 inhibitors are shown that they'll bring down to LDL cholesterol to less than 40 also if we desire so. Vaccine is one of them, gene editing is one of them. So coming to us back in our clinics, risk-oriented approach is very important. The greatest challenge in prevention is treating asymptomatic conditions like dyslipidemia. patient will say, I don't have anything, why you want to treat? But his LDL cholesterol is 190, so we have to treat, right? We have to explain him what prevention is. Be aggressive as you are with blood glucose control and blood pressure control till you achieve targets. Try to bring the physiological levels, no risk unlike hypoglycemia or hypotension. Important is to balance between cost and benefit. So statins are affordable, PCSK9 inhibitors, near elimination, and touted to increase longevity of mankind. This is what some of the research is coming in that direction. And bempedoic acid, oral preparation, not very costly, and if it is able to give us the target that we want, then why not? Thank you. Any questions I can take?
Any role of saroglitazar like lipaglyn?
Yes, saroglitazar is for Indian Southeast Asians, especially when you want triglyceride reduction and elevation of HDL cholesterol.
But vaccine is usually only for infective diseases. So is there any infection playing role in atherosclerosis, or how do the vaccine work in non-infectious etiology?
Okay, so I'm not an authority to talk on that, but definitely you are aware that mycoplasma and various viruses have been implicated in promoting, aggravating atherosclerosis. But I, at this point, really don't know what vaccine is going to work on what level. You might be aware that there is a vaccine for hypertension also.
See, sir. Hello. Hello. For statins, like few patients who are high-risk patients, and we have to give statins, and patients complained of myofascial pain and all that, and we have to give statins. Then whether if patient is in Atorva, then we can switch to Rozua or any other molecule, whether it will reduce or it is always dose dependent. And third, what is the exact mechanism of action this statin is causing myofascial pain, and any other path to prevent that path so that we can utilize this?
So sir, it's a class effect. I'll go by the word myopathy or statin associated muscle symptoms. So it's a class effect. So changing the molecule usually does not affect. It is definitely dose dependent. So if patient has mild symptoms, first you can always try with reducing to half dose of what you are actually giving, because statins for a high risk patient is almost considered that it should be there unless it has caused myopathy and caused CKMM enzyme to rise beyond, or patient has gone into rhabdomyolysis. In those, we have one patient in Sterling Hospital where we actually had to stop statin because he went into rhabdomyolysis because he was on SGLT2 inhibitor and statin, both of them, which is very rare. Second is, sir, most of our Indian patients are vitamin D depleted, So if we can give them a substitute of vitamin D, then many times muscle symptoms go away even on the statin and they can tolerate it better. Theoretically, coenzyme Q10 is one molecule which you can give, but I personally have no experience. I have never used that. HMG-CoA reductase, which is the mechanism for statin, is also present in the skeletal muscles, and through that mechanism they are known to cause myopathy. Which in bempedoic acid, if you add ezetimibe, it's a contraindication for myopathy, but bempedoic acid added to statin is not known to cause myopathy. Oh, I don't remember exactly at this. It was 10 years ago. But I think to lower triglyceride, it was one of the most effective molecules. I think VC Chauhan sir can answer gemfibrozil because these guys have used it for n number of years. And more than that, statins have actually given us good reduction in the components that we want. Sir, he already asked that question. Maybe you are not there. So, sir, it's a good molecule, especially in our subcontinent, because as a typical Indian dyslipidemia, we have more of elevated triglycerides and lower HDL cholesterol levels. It is the junk food which has raised the LDL for all of us. But genetically, we have other type of dyslipidemia. So, saroglitazar is a very good molecule for that. But it does not substitute statins. Okay, so if your patient has a cardiac issue, statins is must. Pardon? Sir, I am not aware of the price.
arachidoic acid, we should go lower for statin
So
and we
if
should
you
add on.
have listen carefully, you have to add bempedoic on the fully tolerated dose of tolerated dose. So it might be 20, it might be 40. No, there's no reduction required. Okay. Okay. So it's a word of caution from the marketeers of this molecule, because in the study it was shown that this is occurring, but it was not statistically significant. So as clinicians, it is our responsibility to keep a watch on that. So uric acid, as you know, 7 or 7.5 in males and up to 6.5 in females, we tolerate it. After that, or if they go for gouty symptoms, then we have to stop the molecule. 3 months. If patient is coming every 3 months.
Sir, it is always fasting or any, because there is always controversy.
Okay. Yeah, it's a good controversy. We have time, no? I mean, I don't mind continuing. The next speaker might be waiting. Okay, sir, so when you want to initiate a treatment and patient has come with some report, then always ask for a fasting report. But for surveillance, any of them is fine. Because when you're surveilling the patient after initiating the...
It is always better, it should be random, not within 2 hours of lunch or dinner.
Sir, the thing is, when you want to initiate the therapy, then you may get a faulty report with any time thing, right? Because chylomicrons and everything gets absorbed. But once you have initiated, that stigma is gone, then you can do it anytime. Thank you.
Thank you, Dr. Kamaldeep. Now I would like to invite on stage Dr. Nikunj to felicitate Dr. Kamaldeep. And now I would like to request Dr. Mitesh to felicitate our chairpersons for the session. And now for the next session, I would like to call upon stage Dr. Sheetal Jadhav and Dr. Mayur Chaudhary as the chairpersons. Our next talk is on ACC 2022 and ESC 2021 guidelines. And for that, I would like to invite our next speaker, Dr. V.C. Chauhan, who is one of the first interventional cardiologists. So due to some technical issue, we'll be postponing this session. So let's proceed to our next session, sleep apnea and hypertension. And for the same, I would like to call upon stage our speaker, Dr. Kumar Gaurav.
good morning to everyone, and beautiful city of Vadodara, and great speakers till now. And first of all, I would like to thank Dr. Pragnesh for the beautiful event yesterday what he had organized, and I think he deserves an applaud for it. Thank you so much. And after the nice sessions, I would like to ask a few of you, how many of you sleep more than 6 hours a day? Please raise your hands. How many more than 8 hours a day? Only 2. And how many sleep less than 6 hours a day? Well, this is for you. Okay, so we'll just go through some things which I'm supposed to talk on obstructive sleep apnea and hypertension, but without the introduction of sleep, most of you would not appreciate this because everyone is talking about sleep apnea, kya hota hai, kya nahi hota hai, everyone knows about it. So I'm not going to blabber about it today. So what happens when we sleep, what happens when you don't get it, and what interferes, diagnosis and understanding sleep. Okay, so sleep, it's a physiological process. And what happens, it allows us to rest, it allows us to get relief of tiredness, it helps in restoration of our body, conservation of energy, restoration of our cognitive, that is thinking ability. And change in the sleep in different body systems, what happens? The central nervous system increases parasympathetic tone, decreases sympathetic tone. In cardiovascular, there is 5 to 20% fall in blood pressure. Then respiratory system, the ventilation is decreased, mainly due to the decrease in tidal volume, and upper airway narrows as tone decreases. Gastrointestinal, decreased salivation, gastric acid production, and gastric emptying. Well, in endocrine, many hormones show increased secretion during sleep, including growth hormone. And in renal, decreased renal blood flow and decreased urine production. When a skill is learned that requires a particular part of the brain, performance will decrease over successful hourly testing unless the person has restorative nap. It's just like, listening to all our lectures. After 40 minutes, you start going down and you start looking at each other, kab khatam hoga. Okay, so okay. Studies show that sleep really does make you smarter. Okay, this was a study in 2008. Where according to Dr. Robert, a Harvard medical professor, chief of sleep division, Massachusetts General Hospital, they claim that sleep on it is a rightly said thing. If you don't sleep on it, you'll not be able to perform a lot of tasks. So the people who are not married, if someone asks you, do you want to marry that girl, sleep on it, okay? But no matter how much you sleep, you never get the right answer. Okay, when you want to be more productive, you need to sleep on it. More sleep could turn grades around. Yes, this is true. So I remember the time when we were kids, सारा time सोते रहोगे तो बनोगे क्या life में? But studies have shown that if you sleep more, it is good. And sleep helps learn complicated tasks. Astronauts were made to sleep more and they perform better. And why do we sleep? Still we do not know. I mean, medically we do not know why we sleep. Okay. Molecular consequences of not sleeping are not currently unknown compared without eating or not breathing. Our understanding as to why we sleep is mainly a result of what happens when we don't sleep. Why do we need sleep? Well, stop a healthy rat from sleeping and it will eat more but lose weight. The rodent will expend more energy but lose the ability to maintain body heat. It will develop skin lesions and scurfy appearance, and sometimes between 13 and 21 days it will die without sleep. Okay, so what happens we don't sleep? Well, most of you can recollect your PG times. This is what we looked like after 48 hours of duty. Okay, and consequences of sleep deprivation. Well, there is decreased alertness, increase in irritability, lethargy and other mood problems, lack of concentration and judgment, a decline in productivity, and higher risk of anxiety, depression, traffic accidents, obesity, cardiovascular risks, type 2 diabetes, and unintentionally falling asleep. So this was the effect of tiredness is immediately apparent by observing the increased frequency of motor vehicle accidents during the midnight dawn, with the peak ranging from 3 to 4. This is for the people who believe कि अरे दिन भर काम करेंगे, रात में जाएंगे और सुबह पहुंच जाएंगे. Sleep deprivation and metabolic function. The prevalence of diabetes, obesity is increased in an alarming rate worldwide, and the reason for this pandemic is not fully understood. Chronic sleep curtailment is a behavior that has developed over the past 2 to 3 decades. In 1960, a survey found average sleep time between 8 to 9 hours, where in 1995 it came up to 7. And the greater percentage of adult Americans report 6 hours or less in 2004 in less than 85. Today, more than 30% of adult men and women between 30 and 64 years report sleeping less than 6 hours. The decrease in average sleep duration has occurred over the time period, and an increase in prevalence of obesity and diabetes. Well, how has it been proven? Well, women who slept 5 hours or less were 32% more likely to put on 15 kgs or more over the 15-year study period. Adults who slept less than 5 hours per night have 60% increase in the risk of obesity compared to adults who sleep more. Children who slept less than 10 hours per night are nearly twice as likely to be obese as children who slept more. Well, how does it affect the weight? With the current data, the relationship between sleep deprivation, weight gain, and diabetes may involve at least 3 pathways: alteration in glucose metabolism, alteration in hormone secretion during upregulation, and decreased energy expenditure. Here you can see, what does this mean? This is 4 hours in bed, 12 hours in bed, okay, the clock time and clock time. So it's not that you go to sleep and you just go to sleep. You just go there, it takes around 3 to 8 minutes for average for a person to go to sleep. So sleep deprivation suppresses leptin. Low levels of leptin increases feeling of hunger. Leptin levels have stimulatory effect on TSH secretion, and decreased level of leptin causes decreased level of TSH, which in turn has significant effect on metabolic rate. So you can see this. So, well, these are all the lovely contributing factors: alcohol, pills, jet lag, shift work, bedroom light temperature, technology, coffee, and improper temperatures in the bedroom. Well, how many of you have a TV in the bedroom? Well, for the people who are married for more than 30 years, the question does not manifest. For the people who are younger, how many of you have a TV in the bedroom? Don't be shy, raise your hands. Only 2? Baki sab gareeb hai kya? Don't mind it. Okay, and how many of you use phone before sleeping? Well, almost everybody. Okay, I haven't put that slide, but it reduces your attraction towards your wife. Well, that doesn't happen after 1 year as it is. Okay, second thing, it increases your chances of sleeping less. I'm sorry I couldn't put those slides up. Okay, now we're coming back. Getting a good night's sleep, what is the good way of doing it? Maintaining a regular bedtime and awake time. That is more important. I believe Dr. Sagar sleeps on time and wakes up on time. Keeping a bedroom dark and quiet at a comfortable temperature is very important. Do not nap during the day. No alcoholic beverages. This is very difficult. Avoid caffeinated beverages. It's more difficult. Do not smoke before bedtime. Well, most of you don't. Do not exercise within 3 hours of sleep. This is very important. There's a whole study behind this. A lot of patients say, sir, सुबह में time नहीं मिलता, हम रात में exercise कर सकते हैं क्या? Most of us say yes, exercise is very important, but do not exercise before 3 hours of sleep. Do not use bed or bedroom for anything other than sleep and sexual activity. Do not watch TV, read, or do crosswords also. Okay, avoid mental stimulation 1 or 2 hours prior to sleep. Well, your wife is going to stimulate it anyways. Okay, so sleep is for people without access to the internet. So switch off your Wi-Fi. Now coming to, I will just skip this slide. This is wakeful, the REM. I've actually deleted this slide so that we keep it brief. I'm sorry, I'm going to go over the time stipulated. So sleep pattern changes with age. Well, most of you look like 20, 25, so that's okay. Well, common sleep disorders other than sleep is insomnia, narcolepsy, restless leg syndrome, periodic limb movements, and parasomnias. I'm not going to go into these definitions. Okay, so sleep disordered breathing refers to any breathing related disorders that occur during sleep. There are many forms, however, the most common ones are the obstructive sleep apnea. You can see the whole blue is obstructive sleep apnea. Then you have central sleep apneas. We have nocturnal hypoventilation and NH. Oh, that's nocturnal hypoventilation. So obstructive sleep apnea, meaning and symptoms. OSA is basically a breathing disorder during sleep when the muscles of the back of the airway relax and the upper airway partially or completely collapse, leading to obstruction in breathing and restricts airflow. Apnea occurs when a person stops breathing for 10 seconds or more. Symptoms of OSA is snoring, daytime fatigue, excessive drowsiness, overweight and obesity, high blood pressure, nighttime gasping or pausing in breathing, morning headaches, difficulty in concentration. How many of you have more than 4? How many of you have more than 4 of these symptoms? Snoring, how many of you snore? You have to ask your wife if you snore. Yeah, most of the people don't know that they snore. That is the biggest problem. So it happens mostly in the OPD. You ask the patient, "Aap karate marte?" He'll say, "Nahi, nahi." And then you turn towards his wife, "Arey, doctor sahab, bahut karate marte, sone nahi dete mujhe." Okay. So it's very important that you ask the wife this question, not the patient. And a lot of people actually have morning headaches. They think that they have not taken their morning tea, that's why they're having it. So please be very cautious about this symptom. This is a visual interpretation not required. Okay. So this is this has not been added as a risk factor, but it's a major modifiable risk factor of hypertension, and hypertensive patients with OSA are at increased risk of cardiovascular disease. A sustainable number of studies have revealed that OSA and hypertension have synergic effect on cardiovascular symptoms and are therefore the pathophysiological interaction between OSA and hypertension. It is well known that obstructive sleep apnea is one of the most common secondary cause of blood pressure elevation. Moreover, hypertensive patients with OSA are increasing risk of developing resistant hypertension and experiencing cardiovascular alterations and events compared with their hypertensive counterparts without OSA. Importantly, it has been reported that 50% of sleep apneic patients have hypertension and 30% of the hypertensive patients are suffering from OSA. OSA occurs during nocturnal sleep, and diagnosis of OSA requires polysomnography to assess key variables such as arterial oxygen saturation, chest and abdomen respiratory movements, electroencephalogram findings, and quantified airflow. All of these indices are subsequently used to determine the apneic-hypopnea index. The apneic-hypopnea index is total number of episodes of apnea, that is complete blockage of airway for more than 10 seconds, hypopneas, more than 50% reduction in respiratory airflow, accompanied by more than 3% reduction in arterial oxygen saturation for 10 seconds. Patients with OSA are classified into mild, that is AHI score between 5 and 15, moderate 15 to 30, and severe, that is more than 30. So this is the same thing what I just spoke about. Risk factors are male obesity, alcohol abuse, anatomical abnormality of upper airway, family history, typical clinical manifestations, daytime sleepiness, fatigue, snoring, frequent awakening, nocturia, reduced concentration, impaired memory. Suspicion of obstructive sleep apnea, get polysomnography. Again, the AHI score 5 to 15, 15 to 30, and more than 30. So what happens in sleep apnea? There is hypoxemia and hypercapnia, systemic inflammation, oxidative stress, endothelial dysfunction, sympathetic nerve, RA activation, sleep deprivation, peripheral vascular constriction, heart rate increases, arterial stiffness happens, and you go into hypertension. Okay, so this is the whole thing I synergized in the one slide previously. Okay, resistant hypertension, which is defined as blood pressure that remains higher than 140 by 90 despite treatment with 3 different classes of antihypertensive medications, including diuretics, at their optimal dose, is a common secondary effect of sleep apnea. So the take-home message is, sleep is essential. There is serious health consequences when a person does not get enough sleep, either in quality or quantity. It is essential that quality and quantity of sleep are routinely assessed, especially in people who are either overweight or obese. So this is the new status symbol. Okay. How many of you changed your mattress in the last 5 years? I mean, every 5 years, how many of you change your mattress? We need to change our mattress every 5 years. We don't do it. We need to change our shoes at least once in 2 years. We don't do it. Especially the walking shoes. Jab tak they are shining from top, shining it, it's good enough. So these are all very important things for doctors. We don't get time to buy shoes, so that's why we just buy whatever comes to us. So please change your mattresses once you go back. I'm not related to any mattress companies. I'm just telling you because these are a part of the study. Right. Thank you so much.
Any questions from the audience?
My question should not be misunderstood because I don't drink, but many patients say that if we don't take alcohol in the night, we don't get sleep. And you are saying that it should be stopped. Then
Yes,
what
sir.
kind of advice I should give to my patients?
Take hot milk.
Hello?
Glass of hot milk.
Sir, दारू पीने वाला hot milk कैसे पिए?
It really helps, sir. I've tried it. Yes, I actually developed taste for sleep apnea because I suffer with sleep apnea. Back in 2017, I had sleep apnea index of almost 60. My brother actually noticed it and he told me, and I got a sleep study done, and it was very horrifying. I actually had started developing hypertension, which I didn't know, and I was almost 106 kgs. I've come down to 93, and it has really helped me. The blood pressures are very well controlled. Ambulatory blood pressure, we all talk about it, but most of us do not get it done. Please get it done. It really helps differentiate the patients with sleep apnea.
In case of high HI score, do we always need to give CPAP trial, or we should first ask the patient to cut down?
See, what happens is depends on which study you are doing for him. Most of the companies which are offering a sleep study are doing a level 3. You need to get a level 2 because you have to understand which sleep apnea is there. But yes, CPAP does help. I am on it and it is really effective. But once you lose weight, you get off the CPAP also. Yes, sir. Yes. Yes, it is not necessary to be obese. A lot of women who are slim, lean, do suffer with sleep apnea, especially during their menopausal age. People as slim as Dr. Pragnesh also can, I mean, not that, I'm just trying to compare his size, okay, can have sleep apnea. I have seen people as slim as him having sleep apnea.
Doctor, how to combat when my husband is got sleep apnea?
Sorry, ma'am, I couldn't get the question.
When my husband has got sleep apnea and I am not able to sleep because of that. So how about
Ma'am, is he overweight? Ma'am, if he is put on the CPAP machine, you will not be able to hear his snoring. But the important part is losing weight. You have to try out every wish thing. No.
I think we are running short of time, so we can discuss all things during lunch time.
Right.
We will move forward. Yeah.
Thank you, Dr. Kumar, for that excellent presentation.
Thank you.
Thank you, Dr. Kumar. Now I would like to call upon stage Dr. Sheetal Jadhav to felicitate Dr. Kumar.
चालू
I would now like to request Dr. Hitanshu to felicitate our chairpersons for the session, Dr. Sheetal and Dr. Mayur.
स्विच कर स्विच स्विच करो ना एक बार एक बार स्विच करो सरल लगा
For the next session, I would like to invite Dr. V.C. Chauhan sir, and for that, I would like to chair the session by Dr. Hitanshu Panchal. Dr. Hitanshu, please. Dr. V.C. Chauhan sir is a very senior cardiologist in Baroda city, and I think he is the first cardiologist of Baroda city who is performing coronary procedure. And presently he is associated with Bhailanamin General Hospital, and in his account there are multiple papers, publication and international talks. So now I request Dr. V.C. Chauhan sir to start his session. Dr. V.C. Chauhan sir, please. And I also request Dr. Dennis to chair the session. Dr. Dennis, please.
I hope I'm seen because I'm small. So now, see, basically my lecture is go with the guidelines. And as usual, guidelines are confusing. So it took me a lot of time to find out which was my lecture. And that's why I had to delay the lecture. So I'm sorry for the delay. See, first of all, I would like to thank Dr. Pragnesh and all the office bearers of All India Clinical Cardiologists. This is one of the best conferences I've seen. And then when I was looking at this lecture, I realized Iaccon 2015, 16, that means I must have given lectures in 15 and 16 for the same conference. So see, my lecture is about guidelines, go with the guidelines. I'll talk in general about guidelines and specifically for the heart failure and specifically for certain medicines. Why it's going down? Yeah. So, slides. Okay, so now. No, હું જોઉં છું 1 મિનિટ આમાં જોવા દે આમાં થાય છે કે નહીં. Oh, that's why it's not changing here.
So can we allow Dr. Urmil sir to talk and we will see?
Yeah. So this is what happens when you follow guidelines. You get totally confused, chaotic, and you don't understand what's happening. So we follow the guidelines.
Yeah. Yeah, sorry for the technical error. Now I request to show their side, Dr. Urmil sir's side. And now I request chairperson to introduce Dr. Urmil sir. Dr. Urmil sir, please.
I think I should go without guideline then.
So friends, we have Dr. Urmil Saha sir from Ahmedabad. He is MD DM cardiology, and I think introduction has gone. Slides. Yeah. Yeah. So he's a senior most international cardiologist and director of Department of Cardiology at SIMS Hospital Ahmedabad. He is an ex-assistant professor of cardiology at UN Mehta Civil Hospital Ahmedabad, and he is actively involved in many academic as well as research activities. He also has many publications in peer-reviewed journals. He has presented many papers and posters at both national as well as international level conferences in the field of cardiology. And he has been also part of various clinical trials and studies. And he has been invited regularly to deliver scientific sessions by various bodies such as CSI, APA, AMA, and other associations. So now I would like to hand over the session to Dr. Urmil Saha sir. Please, sir. Carry on.
Thank you. Thank you, sir. First of all, I would like to thank the organizers for inviting me for such a nice conference. What I'm going to do is a little bit talking about the this is what's more of a case discussion, and we try to highlight the importance when we want to give ARNI to our patients. We all know that NYHA class 2 patient, ARNI is probably the first line of management or class 1 indication, and we normally give to all our patients. The problem usually occurs when the patient has either renal dysfunction or because of some other problem, there is increase in the serum creatine or maybe some blood pressure fluctuation or hyperkalemia, and that is the reason why we may not be able to give this molecule, and that is what I'm going to discuss now. Now this is a case scenario. It's a 62-year male patient, NYHA class 2. Patient has presented 1 year back to me. At that time, patient's ejection fraction was 30%, blood pressure was 110 by 60, creatinine was 1.4, serum albumin was positive, serum potassium was 4.6, and this patient had already known case of diabetes more than 5 years and had a renal dysfunction. I can say a little bit of diabetic nephropathy has started. Patient undergone angioplasty before 5 years. And patient was on bisoprolol, aldactone, patient was on single antiplatelet agents, statin therapy, and patient was also on metformin and dapagliflozin. Now this patient already had, before he came to me, patient had an episode of acute breathlessness 6 months back, okay, and that time the patient's creatinine, patient was hospitalized, the creatinine went up, and the physician had stopped ACE inhibitor, thinking that the ACE inhibitor might have caused increase in the serum creatinine. At that time, the serum creatinine was definitely high. So, and in last 1 year, before patient came to me, patient had 2 episodes of heart failure. One time patient has to admitted, and one time just OPD diuretic was accelerated. And this is the clinical scenario, and patient has come to me for further management. And as you can see, when patient came to me, I thought that patient had, though renal creatinine is high, but patient had a recurrent of heart failure, and let us give the guideline-directed therapy like ARNI therapy, and which I started. Following that, the blood pressure little bit gone down, maybe 100. Serum creatinine went again up to 1.7. Potassium was relatively okay. The family physicians worried, the relatives were worried, but what to do, because now again the problem is occurring. I assured the relative that let us continue this molecule, and we continued that, and after 3 weeks when patient came, symptomatically patient was better, blood pressure was relatively okay, creatinine was about 1.6, okay, and potassium was 4.8, and later on also the patient but continued on the ARNI therapy. Later on I escalated dose to 100 milligram BD, and patient remained absolutely stable. So this is in nutshell a scenario which you may come across in our day-to-day practice when patient is already having diabetes, renal dysfunction, and you need to give a guideline-directed therapy, and what needs to be done. So regarding, let us have some case discussion, what should be doing in this kind of situation. Renal dysfunction, we all know, is a real barrier when we are treating the heart failure patients, and we know that RAS therapy has a definite benefit on improving the quality of life, reduce hospitalization and mortality rate also. At the same time, whenever there is a worsening of heart failure, we know that it is associated with decreased survival, it is associated with increased hospitalization, and this is progression also might be taking place. So we really have to balance between these two, whether we should be giving the guideline-directed therapy and what to do in this kind of situation. Now, if you stop the ARNI therapy or say ACE inhibitor or ARB therapy in this group of patient, when the patient has increased serum creatinine, when the patient is admitted with acute LVF, and you stop RAS therapy, definitely creatinine will improve. The potassium will also improve. But we know that the guideline-directed therapy, which is an important part, like ARNI therapy, patient is not taking, and ultimately patient deteriorates clinically, and later on again the patients worsen. So what we should be doing in this kind of situation, many times we of course have to balance, but definitely a RAS therapy or a ARNI therapy should be continued. Initially it may cause slight increase in the creatinine or little bit of variation in the potassium, but overall, if you look at the patient's recurrent heart failure admission, that's going to be definitely better, and overall outcome for this group of patients will be better. So that we have to keep in mind. We all know that continuing RAS therapy is essential in this group of patients, in spite of worsening of renal function, that we have to keep in mind. Uptitration of guideline-directed therapy like ARNI therapy from 50 to 100, 100 to 200 is essential. We know the benefit of increasing this therapy. And the RAS therapy on renal function is many times misunderstood. We clearly have to understand that RAS therapy or ARNI therapy is basically not a nephrotoxic drug. Okay, it basically causes more of a functional effects on the renal function. But overall, if you look at the outcome, is not bad. We have certain previous data which clearly tells that either we give ARB or ACE inhibitor, we have deterioration of renal function and might have caused little bit of worsening of overall outcome of the patient. But let us clearly understand that we really need to balance. It is not necessary that when the patient has slight increase in the creatinine at the time of heart failure admission, it may be because of so many things. Okay, it may be because of diuretic which has increased. So we really don't know whether the creatinine which has increased or EGFR which has gone down, it is because of some real CRF or it is because of just transient elevation. And we definitely need to avoid the nephrotoxic therapy in this group of patients because we don't want a further deterioration of renal function. But we have to keep in mind that ARNI therapy is not a nephrotoxic drug, and we know the benefit is a class 1, so as far as possible that therapy should be there. We all know that recent guideline clearly tells that ARNI therapy is very important in the patient of NYHA class 2. Those who are tolerating ACE inhibitor or ARB, we have to switch over to ARNI therapy. That is one. ARNI therapy can be de novo started in hospitalized patient at that time also. And mild increase in renal function or asymptomatic reduction in the blood pressure should not avoid us from stopping this class 1 indication therapy in most of the patient. At the same time, direct RNA therapy also is very important. We can straight away start RNA therapy. There is no need at present to switch to start plus ARB or ACE inhibitor and then switch over to RNA therapy. Even the European guideline also clearly tells that those patients who are remaining symptomatic, RNA therapy should be the first line of therapy instead of the ACE inhibitor, which we used to give previously to most of the patient. At the same time, when we are giving to dose adjustment, whether it's required or not, we have to clearly understand eGFR is more than 60, there is no dose, dose adjustment is required. Even moderate renal dysfunction, eGFR between 30 to 59 also, there is no adjustment of the dose which is required. If there is a severe eGFR less than 30, then definitely we have to give 50 milligram once, 2 times, and gradually go up to 100 milligram and 200 milligram. So as such, there is no dose adjustment which is required. Now, why we are keen in giving? Because we have evidence backing use of this molecule. We can definitely tell that if you are given RNA therapy, this is the data which clearly tells that compared to the when we are lower incidence of renal dysfunction was found with the RNA therapy compared to the ACE inhibitor, that we have to keep in mind. Many times the eGFR later on improves also. Of course, not that much, but definitely it improves. At the same time, normally we come across the patient who are having CKD stage 1, 2, 3. Okay, slight increase. They may not be having creatine very high. And these are the group of patients. There is almost 14% reduction in cardiovascular death and heart failure admission when we are giving to this. At the same time, if the patient is having CRF class 4 or 5, there is almost 28% reduction in long-term outcome. So what we have to keep in mind that this therapy is beneficial, and renal dysfunction which occurs temporarily because of heart failure admission should not let us stop this very guideline-directed therapy, which we have to keep in mind. Dose titration also very important. We start with a lower dose, but try to go to the higher dose, because we know that higher dose, maybe 100 milligram BD or 200 milligram BD, is much advantageous compared to 50 milligram BD. If you look at the ejection fraction improvement also, that is significant. If you go for the higher dose, then definitely heart ejection fraction has improved. And that is the reason we have a terminology which we call as improved ejection fraction. That means previously the ejection fraction was low, and now it has improved, because now we have the molecules which improve the ejection fraction also. Indian subset of patient also, it is found to be beneficial, because this study, many of the patients were the Indian patient, and the benefit of global versus Indian is almost same. So we can definitely tell that in Indian patient also this molecule is going to be beneficial. Recurring hypertension, definitely it is a little worrisome thing, but if you look at the data and study compared to the ARB or ACE inhibitor which was used in the study, there was no stoppage, okay, of RNA therapy. So we don't have to withdraw because of hypertension. Of course, we know that we might have to reduce the dose of diuretic little bit, or we might have to little bit increase. We have to reassure the patient. Many times after RNA therapy, blood pressure may go to about 100. We normally accept it. We don't worry about that thing. Sometimes it may go below that, maybe 95. The physicians are many times worried, or maybe the patient also is many times concerned. But we have to reassure that if you don't have any symptoms of hypoperfusion like giddiness or something, we have to continue this therapy, because this is a real good therapy as far as heart failure thing is concerned. At the same time, hyperkalemia also we normally check once we start RNA therapy, maybe about 15 days. But if it has not gone up really, and we also have the data that compared to the ARB therapy, the hyperkalemia incidence also is not very high. On the contrary, it has been found that many times we combine spironolactone with this, because that is also a class 1 molecule, and we combined RNA therapy and ACE inhibitor, RNA therapy and aldosterone receptor antagonist, there is high chance of serum potassium high. But it has been found out that if you are given RNA therapy, then we can definitely add on aldosterone receptor antagonist much safely, and there is no much increase in the aldosterone, much increase in the potassium level. So that also we have to keep in mind. So what we have to do is, we know that whenever a patient is having NYHA class with renal dysfunction, definitely we have to give a directed therapy. Starting of sacubitril valsartan with or switching from ARB or ACE inhibitor to RNA is beneficial. There are reasonable evidence and data which suggests we have to start it and we have to up-titrate to the maximum level which is tolerated by most of the patient. And it has clearly been mentioned in 2022 ACC guideline that mild decrease in renal function or asymptomatic reduction in blood pressure should not stop us from giving RD therapy, which has a significant advantage as far as outcome is concerned. And even European guideline also clearly mentioned that sacubitril valsartan combination should be the first line of therapy. In spite of the patient is having little bit of renal dysfunction because of starting medicine, or maybe because of the acute heart failure episode, which has temporarily worsened the creatinine, we should not stop this molecule in this group of patients. Thank you very much. Any questions are there? No. Yes, sir.
Up to which creatinine level I should continue with the ARNI? And if I have to choose two molecules, ACE inhibitor was ramipril particular or ARNI, which is better in such conditions? And frequency of measuring calcium level, potassium level,
yeah.
Frequency, whether it should be every month or every 3 months, and creatinine every month, 3 months, and up to, I should wait up to 2 level of creatinine or 2.5, in which I should continue this molecule.
At such the concept what we have to keep in mind is it is not depending on the baseline creatinine, okay? Once we start the molecule, okay, if there is a significant increase, okay, then temporarily we might have to stop. Suppose the creatinine is say 2 and we have started an RD therapy, okay, and it has gone to say 3, okay, which is very less likely, okay, but suppose that thing, in that kind of situation, we may think of withdrawing. Otherwise, slight increase is likely, it is going to occur. We should not stop this therapy, that is one. At the same time, potassium is always a concern. We have to keep in mind. But what we have to understand is if you use ARNI therapy versus ACE inhibitor has more chances of having hyperkalemia compared to ARNI therapy. So in this kind of situation, ARNI therapy may be a better option. At the same time, when we are combining, say either ACE inhibitor and you are giving spironolactone, or say ACE inhibitor and spironolactone, we have to keep in mind that if you are giving ARNI, then there is more chance you will be able to continue aldosterone receptor antagonist because there is less chance of hyperkalemia. So this is also a class 1 indication. So all the patients should be on mirocorticoid receptor antagonists like aldosterone, okay? And if you want to give that therapy, and because of potassium we are not able to give, so if you switch over from ACE inhibitor to ARNI, there is more chance then you can continue. Because many times what happens, suppose patient is on ACE inhibitor and we give spironolactone, potassium level goes high and we many times would stop. But suppose ARNI is there instead of ACE inhibitor, then you can be able to continue the this molecule, because we want that therapy, mineralocorticoid receptor antagonist also should be there as a mainstay of the therapy, because 4 pillars of heart failure which we know, this is one of the important pillar. Repeat checking, of course, maybe 7-10 days is by and large fine. But if, once we have checked, okay, once we have checked, say about 10 or 15 days, then there is nothing much to worry, okay? As I was shown in my case also, the creatinine might have gone slightly up, maybe 1.7, 1.8 from say 1.4, but we don't have to worry about that. It may be a little bit stabilized, and only just looking at the serum creatinine, we may not we should not think that something really bad has happened and we should stop this molecule. So we have to continue this molecule in this kind of situation.
Is it cutoff line of EGFR or creatinine? Suppose patient came with me with 3 creatinine, then only I can start
Yes,
heart failure
yes,
ARNI?
yes, it can be given. See, basically the concept also is you can give ARB also. Okay, you can give ARB to this group of patients also. Okay, we don't have to as such worry. Many a time there is a big debate or discussion with nephrologists and cardiologists. Nephrologists, we have seen that many a time. Some of the nephrologists, they immediately stop the ARB as a first. But when the heart failure is there, okay, it's simple hypertension is a different thing, okay. But heart failure is there, we know that we are giving this molecule for heart failure, not for hypertension, okay. And in this kind of situation, the heart failure, this is an important molecule. Though creatinine may vary a little bit, but overall beneficial effects will be there, because temporarily when you stop it, ACE inhibitor or ARB or even ARNI, creatinine will improve. Okay, so you many times feel that we have done something good, or whatever harmful effect we have stopped. But overall what you have to see is, and it is never shown in any of the study that should be withdrawn. Okay, so that needs to be continued. Of course, we have to be a little bit careful when starting potassium level. If there is a marked increase in this creatinine, then of course definitely we have to stop. But many a times what we have seen is the patient is admitted with acute heart failure. At that time creatinine may fluctuate. Okay, creatinine may go a little bit high, and we worry that the creatinine has gone up. Now we cannot give ACE inhibitor or ARNI to this. But definitely we have to keep in mind that it's a transient elevation, and continuation of especially ARNI is very important. We have the advantage of comparing, if you compare the ARB versus ARNI therapy has much better advantage, and that is already has been shown that that should be switch over. Suppose the patient is previously on ARB, we have to switch over to the ARNI therapy. That also clearly the guideline is mentioned.
So my question is,
yes, sir.
When we have improvement in LV ejection fraction, diastolic dysfunction, and improvement as well, and especially patient with postpartum cardiomyopathy or viral cardiomyopathy, can we, is there any particular guideline when do we stop RNA for young patients like 30 years old, 40 years old, or young female patients?
See, peripartum cardiomyopathy is a little bit reversible condition, okay, and definitely ejection fraction improves, and they usually don't have problem later on, okay. So normally what happens is maybe 6 months, 1 year, 2 years, if the ejection fraction has gone up, now patient is absolutely fine. Definitely we can think of stopping ARNI therapy.
At least for 1 year we should.
Yes, but overall guideline tells that not for pericardium cardiomyopathy. Otherwise, if there is a LV dysfunction which has improved, they really tell that we should continue the guideline directive for the long time. There are data which have shown that 2 years later on, if the patient has improved ejection fraction, they have followed that patient. And what they have seen is they have little bit of similar sort of problem later on. So it is better to continue guideline directed therapy. But you are right. Peripartum cardiectomy, I have many patients where after 1 or 2 years, I have gradually withdrawn. Many times I continue beta blocker in this group of patients, but ARNI therapy I am stopping for a long time. Yes.
Excuse me, sir. Here, sir.
Yes, sir.
Sir,
yeah.
As the same question I had, but many times what I have experienced in different kind of cardiomyopathies, especially when it is ischemic cardiomyopathy, and suppose the LED territory infarct and the myocardium is thinned out, LV is dilated. In this case, I have seen the ARNI is not working as efficiently as the other cardiomyopathies like dilated non-ischemic cardiomyopathies. So is there any relation with the thickness of myocardium?
See, basically, when you have more of a aneurysm, okay, and which has caused, then definitely you are right. That patient may not get that much benefit with this.
Yes,
so
sir.
If there's a ischemic cardiomyopathy, routine, when there is no aneurysm, little bit of LV dysfunction is there, okay, like our patient had ejection fraction 30 years undergone angioplasty, but not like aneurysm. So that ARNI therapy is going to benefit. But you are right that if there is aneurysmal dilated, then many a times patients do come with
we are keeping increasing doses, but the EF is stable.
Aneurysm or surgery might be required in this group of patient, because this patient may not get that much benefit like a routine non-ischemic cardiomyopathy or ischemic cardiomyopathy with not sort of an aneurysm.
Yes, sir. Yes. Thank you, sir.
Yes, sir. After 36 hours, that is standard. We stop it. Many times what I do is, I personally, if the patient is having, say, heart failure and symptomatic, okay, and so suppose the patient is admitted, then I switch over to ARB first, okay, because I don't want to stop ARNI and ACE inhibitor both, okay, and then because 36 hours is reasonable time, but sometimes patients do deteriorate. If the patient is relatively stable, I can stop 2 doses, and then third day we can start the ACE inhibitor. The logic is basically it's because of bradykinin and there is more a little high chance of anaphylaxis sort of a reaction. That is the only reason. Otherwise, there is no other reason. But 2 options. One is stop 36 hours and start ARNI therapy. That is one. And second is switch over to ARB. Give ARB for, so normally I give valsartan for 2 days, okay, and then I start. Many times I do in the OPD that I write down only 4 tablets to be taken, 1 morning, 1 evening, and after 48 hours you start this therapy. I explain to the patient that we are stopping this therapy, ACE inhibitor. After 48 hours, you have to start ARNI, but in between, for 2 days, I will be giving only ARNI.
Thank you so much, sir. Thank you so much for nice presentation, sir.
Thank you, Dr. Urmil. And now to felicitate Dr. Urmil, I would like to request Dr. Danish to hand him the memento.
switch कर दो.
And now for our next session on ACC 2022 and ESC 2021 guidelines, I would like to call upon stage Dr. V.C. Chauhan.
Thank you very much. And I feel as if I'm a student who's appearing on an exam for the third trial. And I pray that I pass this time. So I know, yes, I passed this time. So that's a good thing. Now see, my topic is more or less similar to Urmil. So those who want to sleep can sleep, because I'm going to talk more or less similar topic. You can also sleep if you want. So it's a more or less same topic, but a little bit more stress on the guidelines. I hope, how many of you follow the guidelines? Very good. Which guidelines? That is the problem. So, anyway. So, these are a few things I am going to talk about. The heart failure and its burden in the country, especially India. What are the guideline recommendations? One case, not too many, don't worry. And about the conclusions. Now see, I have some slide which some of the students of Baroda, they have seen it many times, so it will be repetitions. Just I am asking for people who are from outside Baroda, of these animals, which animal kills the maximum people in Africa? Very good. Majority of people will consider lion, crocodile, anything. Same is true for a heart failure. When you tell patient cancer, they are scared. They will not ask you any question. They accept the fate. If you say it's a major stroke, intracranial bleeding, corona, they accept it. But when you say it's heart failure, majority don't take it seriously. So heart failure is like hippo. It looks very benign, but actually maximum people are killed by hippo. Same is true for the heart failure. It's a disease which doesn't look deceptive. It is deceptive, but it kills many people. So the burden of heart failure is really increasing. If you say what is burden of heart failure in India, you will be surprised that, of course, we don't have exact statistics, but about 13 lakhs to 2 crore people are suffering from heart failure. 50% or more are because of ischemic heart failure. And because we are a diabetic capital, because we are having trends of the developed countries, even if we are developing, the disease of lifestyle are increasing. And that's why we are seeing more and more people suffering the heart failure. So that is really something which we have to diagnose in time if you want to really reduce the mortality and morbidity. You can see that at any stage of the heart failure, mortality is very high. As for example, when patient admitted for the first time, the almost 10% people that died during the first hospitalization. So you can imagine it's a really high. In fact, the mortality of heart failure is more than majority of the cancer, except maybe lung cancer and a few of the cancers. Within 3 years, 45% people are dead, and within 5, 50% plus people are dead. So it's a really high mortality. So what do we do it? There are many therapies, of which one of the most important is pharmacological therapy. The aim is to reduce the mortality. But apart from that, to reduce the morbidity, to improve the quality of life, to control the comorbid factors, to prevent the heart failure hospitalization. There are many things that we want to do in this type of patients. We also want to prevent many problems, like as for example, further dilatation of the heart. So these are the aim of pharmacotherapies. And why we see such a high mortality in spite of such a good medicines for last few decades. One of the reason probably is that we do not follow the guideline directed medical therapy. That is the main reason. We know which are the medicines. We know what are the combination, what are the dose. But many times we are not either following or we are not able to follow it. So this is what I am going to talk about. And this is one study which shows that even if you put patient on the similar medicines or similar treatment, if you do not follow the guidelines, that means either improper combination, improper doses, improper follow-up, the mortality is significantly high. So here you can see the difference is quite significant between guideline directed medical therapy versus non-guideline. We have so many guidelines and so many trials comparing different type of medicines, and they have proved that these medicines are really versatile. As for example, AC inhibitors reduces mortality by 16%, beta blockers 34%, mineralocorticoid inhibitors 30%, IRB is almost 17%, and ARNI actually it is more than 30 to 40%. Evaporatin also may reduce mortality in appropriate case if there is a tachycardia. And if you combine these medicines, probably mortality reduction will be more. So this is the foundation of heart failure treatment. Actually, not only heart failure, even it's blood pressure, IHD, there are so many diseases where guidelines actually work and we have to follow them. And depending on the stage of the disease, this is how we manage. If patient comes to you, first step is that they should be on all these medicines, provided they can tolerate, provided there are no contraindications. So patient should be right from the first diagnosis, first medical contact should be on ARNI, that's the first choice. Of course, cost is the issue. Then you put ARB or AC inhibitors. And if they are contraindicated, then you don't use it. Otherwise, like bilateral renal artery stenosis, you don't use either of the three. But otherwise, ARNI is first thing to start. along with that beta blockers, mineralocorticoid inhibitors, SGLT2 blockers, and diuretics acute phase when there is a positive congestion or signs of symptoms of heart failure. But first 4 medicines should be always there. This is now 4 pillars of the heart failure therapy. Then you call the patient on follow-up. Depending upon degree of clinical response, creatinine and potassium, you uptitrate the dose. If suppose beta blocker is already maximally tolerable dose and still heart rate is high, you add ivabradine. Otherwise, we usually don't add. If there is atrial fibrillation fast rate, then you add digoxin. Otherwise, we usually don't add. Of course, in patients with severe MR, sometimes digoxin can be given. Ischemic heart disease, digoxin still works, but many of the EP guys don't like digoxin at the moment. If this doesn't work, or if in spite of optimum therapy, ejection fraction still remains low, you usually put ICD device. But because of cost, we don't put in all our patients. If patient is LBBB along with it, we can put patient on CRT-D device, which is also known as triple chamber pacemaker, which improves prognosis significantly. Those patients who have multivessel disease, viable myocardium, surgically corrected problems, we do correct it. As for example, patient with severe MR or severe aortic stenosis, the moment you remove the valve problems by surgical correction, or nowadays even with invasive, non-invasive tower-like procedures, it improves the LV function. So stepwise we go ahead and do what stages or what condition we are. And you must consider, I think there was a previous question, whether we should stop medicine or not. Except for viral myocarditis and peripartum cardiomyopathy, which is reversible, in all other conditions, we have to continue ARNI and other guideline directed medical therapy for lifelong. We have seen many patients where after 2 or 3 years of improvement or nearly normal LV function, the moment you stop, within 6 months, they come back with dilated cardiomyopathy. Means the LV dysfunction restarts over a period of time. So in majority of the patient, we have to continue this therapy forever. So we have to go with the guidelines if you want to do a proper assessment. And remember, the guidelines are for heart failure, but actually, if you do sub-analysis, then you can see that guideline is not only for patient with chronic heart failure or acute decompensated heart failure. There are many other conditions where guideline actually works, like patient who is hospitalized for the first time, hospitalized on second or third occasion, de novo heart failure patient coming to you for the first time with a heart failure, or diagnosed to a heart failure for the first times. Not only that, there are some group of patients where even after angioplasty or surgery, LV function doesn't improve. That is what you said. If patient has massive anterior MI, akinetic myocardium, non-viable myocardium, it may not improve after surgery. Of course, surgery still improves the prognosis with diffuse triple vessel disease because it improves pumping in other areas. The anterior akinetic wall never improves, but remodeling will definitely better after surgery. But even after surgery, we have to continue with the guideline directed medical therapy. That is very much important. I'll not go into detail because this is little industry sponsored, so I'll not go into all these things. But ARNI is now considered the first line of therapy if patient reduce ejection fraction. Those with normal or preserved ejection fraction, the role of ARNI is not as important as it is in those with reduced ejection fractions. So once patient is class 2 or 3 or more and LV ejection fraction less than 50%, is better to start with ARNI. As previously mentioned by Urmil, nowadays we don't start first ARBs or ACE inhibitors. If they fail, then only we start ARNI. No, nowadays we always start with ARNI first, unless patient has a cost issue. And the contraindications are same for all 3, so it doesn't matter actually. So first thing is to start with ARNI. And you always start with minimum dose, but depending upon the patient's tolerance, we change the dose. As for example, if patient is already on ARBs 50 milligram BD, or like us say Ramipril 5 milligram BD, then you can start with ARNI 100 milligram BD rather than starting at 50 milligram once a day and then gradually increasing. So depending upon whether he's a naive with this therapy or he's already on some other medicine, we decide what dose to be considered. European Society of Cardiology also gives exactly same. There is no difference between what American Society and European Society says. We have Indian Cardiology Association, which also follows more or less same thing. Only difference is Indian people do not tolerate as high as dose as the Western people do. As for example, I have seen many American people with 100 milligram BD of metoprolol, but Indian people usually do not tolerate more than 100 milligram total dose. So there is some difference between the two. So ARNI is recommended as the first line of therapy by both American College of Cardiology and ESC. The same is guideline for the hospitalized patient. In fact, many times we in acute stage give more stress to congestion and relieving the congestion. That is, diuretics plays the maximum role. You have to treat other comorbid condition in acute situation. But it is better to start ARNI before patients are discharged. In past, we used to treat patients, stabilize the patient, call on follow-up of 15-20 days and then start ARNI. But now the new concept is to start before they are discharged, because that is most important. That reduces mortality quite significantly, because half of the patient come back within few weeks with a heart failure. So again here, recommendation is consider before they are discharged, and it is important to prioritize guideline-directed medical therapy. As for example, after 2 or 3 days of heart failure with diuretics, patient's pressure has gone down, but he is improved clinically, you can reduce diuretics and then restart or actually start ARNI. Actually, as per the study, it is more economically viable to start costly medicine because it reduces hospitalization, it reduces further treatment, and so on long term, the costly therapy is actually turning out to be a cost beneficial and safer and cheaper medicines. Same is the guideline for European Society of Cardiologists. It is also recommended as the first therapy, this has been already said, recommended as the first therapy for de novo heart failure patient. De novo means patient who was never diagnosed with heart failure. He came for the first time and you diagnosed for the first time this heart failure. So if ejection fraction is low, you start them on same therapy that I have mentioned before. There are two types of heart failure patients. One, as you previously mentioned, young people, more female, who do not have ischemic heart disease, but they have cardiomyopathy, viral cardiomyopathy, post-peripartal cardiomyopathy, or idiopathic cardiomyopathy. In this patient, mortality is relatively less. On the other hand, those patients who are elderly, they have ischemic heart disease, or other associated comorbid like hypertension, diabetes, anemia, they have more chances of worse prognosis compared to this. But in both this group, both the de novo group, ARNI is the first line of treatment that we should do. But that doesn't mean you have to neglect about the comorbid factors. You have to control that factors as well. And not only that, those patients who come for the first time with de novo heart failure, but not bad heart failure, that means compensated heart failure, they obviously mortality is slightly less compared to acute decompensated heart failure. But if you follow them for year plus, then mortality is practically same. So even if patients do not have significant heart failure symptoms, they are in class 4 or 4, you have to still consider ARNI if you want to reduce the long-term prognosis and long-term mortality. So this is one of the most important things, that even after our successful angioplasty or bypass surgery, our attention to treat the heart failure medical treatment remains practically same. Of course, I have seen many patients in whom after bypass surgery or after angioplasty, ejection fraction improves significantly. But that does not mean you obviate the need for ARNI and other guideline-directed medical therapy. Here also, the death and heart failure hospitalization reduces significantly if you put this patient on ARNI and adequate doses. Now, what is dosing sequence? In past, we used to start therapy and increase very gradual 2 or 3 month interval, but now we call patient on 15 to 20 days interval. So we up-titrate doses much faster. And as I previously mentioned, if patient is already on AC because the ARB is on a higher dose, then we start with higher dose of ARNI when we switch over. So we don't start with 50 milligram HS and gradually increase. We start higher dose depending upon the clinical scenario. And study shows that if you increase dose adequately and fast, probably patient gets more advantage. Now this is just one example of 53-year-old female who do not have IHD or other conditions, but presented for the first time with shortness of a 2 weeks interval. And investigation shows LV ejection fraction only 32%. Creatinine fortunately normal, potassium normal. So this is example of de novo heart failure patient. And as I previously mentioned, hospital mortality even the first time is 5%. 6-month mortality is 15%, which can go up to 55% at the end of 5 years. The need for repeat hospitalization is also very high. So these are the patients where if you put them on certain guideline-directed medical prognosis can be reduced. But unfortunately, you can see that only 76% patients are AC inhibitors, only 50% on mineralocorticoid inhibitors, and only 60% on beta blocker. If you put all three together, the incidence is less than 40%. That indicates that in real life, guideline-directed medical therapy is not used as much as it should be used. So if you put this patient on proper adequate treatment, probably mortality can be reduced significantly. That is what we have to say. And nowadays, obviously, ARNI is the first choice. There is no question about it. So this patient being a first-time diagnosed, it's better that we should put de novo patient on sacubitril valsartan combination, also known as ARNI. There are many companies available which makes these medicines. And here also you can see if you put patient directly on this therapy, then the prognosis is significantly reduced compared to other therapies. So almost 30 to 40% reduction in mortality. NT-proBNP, which is one of the marker for diagnosis as well as affected to see the efficacy of the therapy, as well as prognosis is significantly reduced if you put patient on ARNI compared to other therapies. And early initiation is definitely better. Best thing is to start when patient is coming to you for the first time or is hospitalized for the first time with heart failure. It is preferable over AC inhibitors, ARBs, and that is what it is. Don't be happy, this is not conclusion. This is conclusion for this particular patient. So go with the guideline therapy. So in this patient, we will definitely start with ARNI, provided heart rate and blood pressure and clinical hemodynamic status allows. Now see, I will just ask you a question, why do we need guidelines? See, medical field is continuous evolving. Each day we see a lot of new medicine, new devices, new studies, and we cannot go after all these studies. So those who are expert, they analyze all these studies, they go for the RCT trials, and then they give guidelines. So it helps us, the practicing doctors, to use available medical knowledge in the best possible way to help the patient. So this is just summary of knowledge that we get it. But definitely there are some advantages of guidelines. The latest medical knowledge is applicable to us. Summary of all major medical trials and expert concession, real world experience. So many guidelines changes according to real world experience. It saves you for medical legal problems and issues. And of course, there are a lot of guidelines according to different countries and different ethnicities. So these are the advantage of guidelines. Of course, there are a lot of limitations. Right? As usual, limitations are always more than the advantages. That human body is unpredictable and it's variable. So guideline cannot fix to each and every individual. There are exceptions always. There are a lot of difference in pathophysiology according to age, sex, ethnicity, race, and many other factors. Guidelines are often made by non-clinical practice, people who are not actually into clinical practice, who do not often see the patient. They are expert in statistics, but they are not probably expert in clinical scenarios. And that is why a lot of senior people or a lot of old age people, they give proper medicines, even without following the guidelines. Many times guidelines show sheer lack of sense. Many times different person have different experience and you have to definitely use your experience. There are many things which does not need guidelines, as for example. And guidelines are often written in difficult languages, so difficult that it's like reading a court verdict. And it's often difficult to understand what to say. That's why I skip some slide very fast, because even I couldn't understand what they want to say. So that is what happens with the guidelines. I'll just give you some examples before I finish my lectures. Donkey analogy, which some of you again have seen. Some of you must have seen this before. That if you consider donkey as a heart, what is a failing heart when donkey is tired? He is no more able to carry the pulley. So what do you do in that situation? What are the ways you can improve the performance of a tired donkey? There are various ways, and this is how different medicines work actually, that I'll show. So digital is like showing a carrot. Donkey runs faster, and obviously the performance improves, but it lasts very short, so it does not change the prognosis. Donkey ultimately get tired and ultimately succumb to the problems that is. So what is second option? Diuretics, AC inhibitors, ARBs, ARNI, what they do, they reduces the preload and afterload, and that obviously improves the performance. So that is what they do it. The third medicine, beta blocker, they reduce the speed. So slow and steady wins the race. So you go much longer, prognosis definitely improves. On the other, SGLT2 blockers, they have pleiotropic actions. This is the action that SGLT2 blocker does, and that also improves the performance over a period of time. And what do the cardiac resynchronization therapy do? It improves like wheels on the tired donkey and improves the performance. So that is how different therapy has different impact on clinical outcomes. So best thing is to use them judiciously and proper dose, monitor them properly, and give maximum possible dose of maximally available medical treatment. I think that is what will change the prognosis. So in summary, pharmacological management of heart failure, ARNI, SG2, mineralocorticoids and beta blockers. These are the four mainstays of the therapy. You must use all four together. There is no need to start one, then second, then third. Depending upon clinical scenario, you can start all four together. ARNI has definitely become one of the established therapy for chronic heart failure, acute decompensated heart failure, de novo heart failure. It's a class 1 indication. Of course, if patient has severe renal dysfunction, bilateral renal artery stenosis, very high potassium levels, creatine more than 3.5, then obviously we should not start with it. SGLT2 is also associated with similar benefits. They are again given in whether patient is diabetic or non-diabetic. Unless they have urinary infection, you consider that also as a good therapy. The advantage of SGLT2 is it is preferred even in patient with preserved ejection fraction. So optimizing and up-titrating pharmacotherapy according to clinical profile, hemodynamics will definitely reduce morbidity and mortality in all heart failure patients. Still there is significant residual morbidity, and that's why we consider devices like CRTD, ECMO, IAPB. There are so many other things available, and last resort is obviously heart transplant. So I think I will end my lecture here and wait for questions or if there's any other things.
Sir, my question is choice of beta blocker, molecule and dose in a known case of COPD and bronchial asthma with the heart failure.
See, if it is COPD, then bisoprolol is a probably better choice, bisoprolol or carvedilol. Otherwise, beta blocker includes any of the 3 beta blockers. This is metoprolol, bisoprolol or carvedilol. Any 3 can be used. Even in patients with COPD, unlike asthma, they tolerate beta blocker much better than patients with asthma. Asthma people don't tolerate well. COPD patients usually tolerate well. Only thing is the dose required is much less compared to non-asthmatic or non-COPD patients. But COPD does not mean you don't start with beta blocker. You still start with beta blockers. I think because the previous lecture was exactly same, some questions were repeated and the same thing. So I'll just answer for some of the things that Dr. Urmil had answered. If creatine is more than 3.5, probably better not to start with ARNI AC because of the ARBs. When you start patient on ARNI or ARBs with creatinine less than 3.5, if it increases to more than 50% or again crosses more than 3.5, you stop them. If it increases to up to 3, you can reduce the dose to half. So these are the certain guidelines. Because you have to see cardiac failure, heart failure and kidney failure both into account. Don't pay attention only to cardiac failure. That is very important. And obviously you have to work in associate with nephrologists and their concept and criteria are different. They pay more attention to kidney failure, we pay more attention to heart failure, but best is combination.
Thank you, sir. Thank you so much for informative presentation, sir.
Thank you, Dr. V.C. Chauhan. Now I would like to call upon stage Dr. Hitanshu to felicitate Dr. V.C. Chauhan. Now I would like to request Dr. Avinash to felicitate our chairpersons for the session, Dr. Hitanshu and Dr. Danish. Now for our next session on arrhythmia and appropriate drugs, I would like to call on stage our chairpersons, Dr. Vishal Darji, Dr. Mitesh Chauhan and Dr. Ameen Jaria. And the speaker for our next session will be Dr. Chirag Sheth. I would request Dr. Ameen Jaria to please introduce Dr. Chirag Sheth.
Good afternoon, everyone. Dr. Chirag Sheth is a senior interventional cardiologist and founder director affiliated with Rhythm Heart Institute, Vadodara, having obtained MBBS and MD in internal medicine from Medical College and SSG Hospital, MS University, Vadodara. He attended the interventional cardiology program at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and pursued further certified training in interventional cardiology from King's George Medical University, Lucknow. He further pursued training in cardiac electrophysiology and pacing for arrhythmic disorders at Escort Heart Institute, New Delhi. He has vast clinical experience in treating patients with broad spectrum of complex cardiac ailments since 2004. We request sir to start his session.
So good afternoon, everyone. Thank you to Dr. Pragnesh Shah and entire team at IACC-Con for inviting me for this talk. And contrary to the Dr. V.C. Chauhan's address, I would like everyone to wake up rather than go to sleep. And I'm sure the base has been already prepared by the morning talk by Dr. Shomu about narrow and broad QRS tachycardia. my job is little easier. And maybe on way we would touch upon some of the basics also before we discuss this. We have all encountered various arrhythmias in our day-to-day clinical practice. So this is going to be like a recap. I'm not going to talk anything new. And there are no new evidences to share as of now. So it is just basically to recap what we are doing. Are we doing correctly? Are we missing the links? Are we missing the points? Okay. So what should we look for in a patient who presents with arrhythmia? So try to decipher what the mechanism of arrhythmia could be once you have established a diagnosis, and try to look for substrate of arrhythmia. Look for metabolic factors like hypoxia or acidosis in a given patient, and try to look for electrolyte imbalances. I think this is true for each and every kind of arrhythmia that you encounter, whether it is tachy or brady. Broadly, the arrhythmia approach to patient with arrhythmia should be that if you have a tachy, try to look for whether it is broad QRS or narrow. That exercise has already been done. In echo, try to look for ejection fraction, extent of LV hypertrophy, whether it is mild or severe, or whether there is associated coronary artery disease. Why important? Because severer degrees of LV hypertrophy means you are going to encounter more myocardial fibrosis. If you have valvular heart disease, again, rheumatic heart disease will have associated significant left atrial fibrosis. Similarly, ischemic heart disease, apart from acute ischemia, in chronic ischemic heart disease, you will have substantial degrees of scar, which also is a substrate for arrhythmia. And that also translates into risk of sudden cardiac death. So echo is absolutely important as far as long-term prognostication of this kind of patients is concerned. In acute situation, look for hemodynamic stability. From the ECG, try to look for whether that kind of arrhythmia is likely to be reentrant arrhythmia or a non-reentrant arrhythmia. And by XYZ means, once you have controlled that arrhythmia and achieved a sinus rhythm, try to look for QT intervals on the surface ECG, whether it is normal, prolonged, or short. So that also will guide what kind of drugs and what kind of therapy you should be giving. As far as Brady is concerned, look for, if you have AV nodal disease, from the surface ECG, try to look for whether you have suprahesian kind of AV conduction disturbance or infrahesian kind of Brady disturbance, broadly demarcated by extent of QRS widening. If you have narrowish QRS, more are the chances. Of course, it's not absolutely true on surface ECG, but if you have narrow QRS, then yeah, it is likely to be suprahesian. If you have broader QRS escape, it is likely to be infrahesian. And broad spectrum of patients who have a sick sinus syndrome. So broadly, antiarrhythmic drugs are of these 4 classes that everyone knows. Class 1 mainly affects sodium channels. They are sodium channel blockers and they prolong action potential duration. Class 2 is beta blockers. Class 3 is potassium channel blockers, which effectively cause prolongation of effective refractory period. Class 4 are calcium channel blockers, which affect calcium current during phase 4 diastolic depolarization. And others are digoxin and adenosine. We'll not go into a lot of details, but just to highlight one important part as far as EP characteristic of 2 different tissues are concerned. One is myocardial tissue and second is conduction tissue. That is sinus node and AV node versus myocardial tissue, that is atria and ventricle. If you pay attention to primary charge carrier for SA node and AV node, it is dominantly slow calcium current. Whereas if you have atrial and ventricular myocardial tissue and His-Purkinje system, the primary positive charge carrier is sodium. So this is one basic difference between myocardial tissue and conduction tissue. Myocardial tissues have sodium as a positive charge carrier versus conduction tissues, that is SA node as well as AV node, they have calcium as a positive charge carrier during their depolarization. And extent of action potential duration, if you see, the action potential duration at baseline is higher for myocardial tissue compared to conduction fiber tissue. And if you see that the resting membrane potential from which the depolarization starts, it is less negative for sinus and AV nodal tissue compared to others. And therefore, these are the tissues which are acting as a pacemaker. They are easily excitable compared to surrounding myocardium, and that's how they become a pacemaker. So I think this is one basic thing that we have to understand as far as EP characteristics are concerned, and this reflects into this kind of chart also. You can see the difference how the action potential, how the cardiac action potential duration looks in sinus nodal tissue versus atrial or ventricular myocardial tissue. Rate of rise is faster for myocardial tissue, and duration is longer as compared to sinus nodal or AV nodal tissue. So these differences lie in basic characteristics about which ion channels are involved in the depolarization and how they behave during the whole cardiac cycle. So whenever we want to treat a particular patient of arrhythmia, try to find out what the target vulnerable parameter in a given arrhythmia is. I know this is a very, very generic statement, and we will come to some of the examples in the later part of the talk, but you can have enhanced automaticity as a cause of arrhythmia, and here your target should be to decrease phase 4 depolarization. So if that enhanced automaticity is involving conduction tissue, then you should be treating with calcium or sodium channel blockers, calcium channel blockers and beta blockers. And if it involves myocardial tissue, then sodium channel blockers. Triggered activity is responsible in 2 different subsets, that is torsade and second is outflow VT. If you have torsades, your target is to shorten the action potential duration, and that is achieved by sympathomimetic drug like isoprenaline or rapid pacing. And there are several, we need to suppress even early after depolarization. That happens with magnesium and beta blockers. The outflow tract VTs, they again have delayed after depolarizations, which again can be controlled with beta and calcium channel blockers. One of the other important target of arrhythmias in tachyarrhythmias is re-entry. Now re-entry can involve 2 different channels. It can be sodium channel dependent or it can be calcium channel dependent. Examples are, if you have a sodium channel dependent re-entry, they are basically atrial arrhythmias and some form of ventricular arrhythmias. So you can have 2 different types. One, you can have long excitable gap and one can be short excitable gap. One would give example of typical atrial flutter. We know typical atrial flutter is what? It is a macro reentrant arrhythmia. The conduction goes across from below up, caudal to cranial across the septum and then comes down from the RA lateral wall. It's a macro reentry, and therefore you can see flutter waves to be broad, unlike atrial fibrillation, right? So typical atrial flutter has a long excitable gap, meaning thereby it's a conduction wave that passes across as a circus movement across the atria with a long excitable gap. There can be VTs which have long excitable gap, and you can have WPW syndrome if you have accessory pathways conducting to and fro from atrial to myocardial tissue. So in all those patients where, in all such patients, you have long excitable gap, and these patients can be treated with type 1 or A or C sodium channel blocker drugs. And there can be, on the contrary, you can have short excitable gaps, that is atrial fibrillation. You can see that you have atrial fibrosis and you have multiple foci generating rotors and drivers arising either from the atrial tissue or from the pulmonary vein, and that can lead to propagation across the atria and lead to atrial fibrillation. So in atrial fibrillation at the level of atrial tissue, you have a short excitable gap. Atypical atrial flutter, again you have short excitable gap. And you can have ventricular fibrillations, again having short excitable gap. In all such patients, potassium channel blockers are more going to be helpful because they are going to prolong the effective refractory period. And therefore, they become the drug of choice and not type 1A, less likely with a type 1A or 1C sodium channel blockers. And lastly, you can have re-entry because of calcium channel dependence, and that is typical examples are SVTs, that AV nodal re-entry, and the verapamil sensitive outflow tract VTs, where calcium channel blockers are drugs of choice. One would add here fascicular VT also. Fascicular VT is also a type of re-entrant VT. And here also, despite VT, that is a verapamil sensitive one, and that can be easily treated with calcium channel blockers. So I think this is in brief how we can target various mechanisms as far as antiarrhythmics are concerned. Antiarrhythmic drugs available to us are these many. Everyone knows this list. I will not go into each and every detail of this. So how many of us have used flecainide? Just a broad hand raise. Okay, so at least 4 or 5 have used flecainide. How many of us has used sotalol? Okay, so a little more frequent. Great, fine. And mexilatin? Okay, fine. So then I think probably we'll be able to talk it further. So let's say if you have this patient with fatigue and paroxysmal palpitation, spot diagnosis is? What is it? AF. How would you treat? Single answer? Flecainide. Why? So I think we should go back to basics. Whether it is acute or chronic, right? Less than 48 hours, you can cardiovert without looking for LA clot. right? So don't jump to medicine first. Try to look for what the duration of arrhythmia is, what is the chance of this patient developing cardioembolic stroke. Duration is less or more than 48 hours. If it is more than 48 hours, don't cardiovert. If you want to cardiovert because of XYZ reasons, look for LA clot, perform TE, and then cardiovert. Otherwise, just control the heart rate and provide anticoagulation for stroke prevention. Okay? Again, echo, you should see whether heart is structuring normal or not, right? Why it is important? In atrial fibrillation, if you have, in a younger patient, if you are structuring normal heart, these are the patients who have focus arising from pulmonary veins, and these are the ones who can easily be treated with ablation at a due course of time, rather than putting them on long-term antiarrhythmic therapy. And that is successful in almost 85 to 90% of cases, done in properly trained hands. It tends to give good outcome, right? And you are going to have a talk on atrial fibrillation, so we'll not go into the greater details of it. But if you have chronic AF, again, try to decide whether you have rate control or rhythm control strategy, and accordingly choose your drugs. What happens is, in commonest thing that one finds in cardiac ICU is the moment amiodarone is started, right? So that kind of practice should be curtailed, and this kind of exercise is important for preventing toxicity, which can be because of drugs also, and drugs can be counterproductive. Even if you start, let us say, amiodarone or something, it takes long time to build up the effect. So it's not, not something that we should consider in acute hemodynamic instability. If you have unstable patient, you can straightaway cardiovert and treat them, right? So if you have this patient who is a status post ASD closure, and you can see a tachy, right? And later part of the strip shows a sinus rhythm achieved. What do you think this arrhythmia is? A quick spotter. QRS morphology is same during sinus rhythm and tachy. So this arrhythmia is? It is atrial tachycardia, right? So how do you treat again? Post ASD closure, enlarged atria, likely to have fibrosis, right? So at the level of tissues, you have this kind of pathology. It involves atrial myocardium. So which drug should be useful? Type 1A or 1C. And here, yes, flecainide can be the drug of choice, because you are going to treat something arising at the level of atrial myocardial tissue, right? So flecainide is drug of choice for this kind of patient. The status post MVR comes with a refractory heart failure. What do you find in this ECG? May or may not be very clear, but can someone just, we'll spend not more than 10 seconds here. The heart rate is close to 120, right? So patient is in heart failure. I'll give you one more clue. This patient keeps on coming with heart failure, and every time if you see the pulse rate, it is 120. Pulse rate has not changed a bit. It's always 120. Again, it is atrial tachycardia. These waves are not sinus P waves. Look at lead 1, look at lead V1, right? And look at the extent of PR prolongation. Look at lead V3 showing how the atrial waves are looking with a prolonged PR interval, right? So this is atrial tachycardia. So not all arrhythmias, tachyarrhythmias will have 150, 160, 170 heart rate. You can have slower atrial arrhythmias also occurring at lesser heart rates. So whenever patient has refractory heart failure, try to look for chronic persistent arrhythmia also as a cause of problem. And if they may also be responsible for tachycardiomyopathies if they are persistent for long duration of time, and here the cardioversion can be the key with drugs like amiodarone. So this is a patient who has been noted to have bradycardia, right? A heart is structurally normal. Then how would you treat? Despite bradycardia, someone whispered beta blockers. So if you measure the pulse is 48, right? But on ECG, if you see heart rate, it is reasonably okay, because that will include PVCs also. So how would you treat? Would you still like to give the beta blocker or not? How many will say yes? Not immediately. So what will you do? Roll off? Load of VPC. Okay, so one would do a Holter to find out load of VVCs, right? Second, you should look for symptoms. Is the patient symptomatic for it or not, right? If there are no symptoms, unless the burden is low, probably those VPCs need reassurance, nothing more. And third thing what you should do is a treadmill. Make them walk, structuring normal heart, right? They are likely to be monomorphic outflow PVCs. Make them walk on a treadmill. Is exercise inducing further worsening of arrhythmia or not, right? And if you see that PVCs decrease as the patient exercises, they are benign. You don't need to treat them very aggressively. And if your arrhythmic burden is high, yes, you can put them on beta blockers. And even verapamil. This can be even verapamil sensitive also. And you can, if the patients are having significant arrhythmia burden, then yes, ablation can be the answer, right? Bradycardia again. Someone would start atropine. Someone would give isoprenaline. What does it look like? A sick sinus, right? Junctional rhythm, sinus arrest, right? Try to look for metabolic factors. Correct them if you find it. If there are none, then probably these are the ones who will need straightway pacemaker, right? This one. You can see two strips. One is given atropine, second, it has been labeled pre-atropine and post-atropine. And what do you find? There is hardly any benefit, right? Why so? Why did atropine did not improve the heart rate? Pardon? Okay, but why did ventricular rate not improve? Yeah, it's a complete heart block, right? In which complete heart block atropine will improve conduction? If it is supraHesian. So if you see on surface ECG QRS is narrow, there then can be some role of atropine that it can improve conduction. But otherwise, if you see broad QRS escape in the setting of heart block, you should never give atropine, right? It can worsen the extent of heart block. So our reflex that Brady means atropine, one should start going away from that kind of notion. See what you are treating and what is the likely cause, okay? So if you have broad QRS escape, patient is unstable, you can try even isoprenaline, short boluses of isoprenaline to improve AV conduction, and that might give you some time before you put up a temporary pacemaker, right? So in ICUs, beware of what kind of ECGs that you encounter. But what is happening at the level of atria? Why atrial rate is so high? That means there is atrial arrhythmia happening. Already patient is having atrial tachycardia at baseline, and now patient has heart block, right? Okay. So one would need to address this kind of arrhythmia as well in future course of treatment, and will need a pacing as well. Let us say this is one patient, rheumatic severe MS, class 3 dyspnea, no palpitation. It is pre-excitation, right? So you can have rare presentations even with structurally abnormal heart, okay? So asymptomatic patients, right now you do not need to do anything for this patient, and you can just treat severe MS the way you do, either BMV or any palliation, medicines, everything, right? If a patient is structurally normal heart, no palpitation, if you find this is a ECG, then the way forward should be, try to make them walk on a treadmill and see whether pre-excitation increases during treadmill or not, right? If QRS becomes narrow during exercise, that means this conduction tissue has got a long refractory period and is not likely to participate into atrial fibrillation should it occur later on in the course of disease, and they can be managed conservatively. And if you see that with exercise QRS tends to prolong, then yes, these are the substrates which will require ablation as a therapy, right? There's a standard, everyone knows, right? So how do you treat? Drug of choice will be adenosine. Anyone for beta blocker or a calcium blocker? No. I will be a strong proponent for diltiazem or a beta blocker because it is easily available, it is easy to give, it is cheaper, right? Rather than rushing for adenosine, for which you will need a central vein, larger vein, you have to give it in a particular way that it has to be given fast, someone has to monitor. You can have adenosine causing some problems, of course transient, not something big, right? Some atrial fibrillation happening or some bronchospasm happening. You don't have any such concerns with beta blocker or calcium blocker, right? So yeah, all answers are correct, but yeah, this is how one can choose any, but this would be our preference, okay? And this, I think ECGs are not very clear, but this ECG was showing narrow QRS ventricular tachycardia. AV dissociation is there in this kind of ECG, and this is a patient who had young male, normal heart, and this was arising from the upper septum. So it was a kind of fascicular VT only, but with a narrow QRS because it was involving the upper part of the septum. So these are the patients who can still benefit with verapamil, right? Of course, they will need ablation as a definitive treatment eventually. So everyone knows this will be fine, VT, right? And what is important is that these are the patients who will need, apart from antiarrhythmic drugs, ICDs as a definitive protection against sudden cardiac death. So towards, I'll skip some of the slides for the sake of time, and I will just show last 2 slides. What is happening here? So in the first strip, pacing is happening. In the second strip, later half, arrhythmia has started. And what is the morphology of that arrhythmia? It is polymorphic. Will someone call it torsade? When do you call it polymorphic? When do you call it torsade? Anyone? Anyone can volunteer for the answer? When you have long QT, you call it torsade. Very good. So it is a specific thing. It's a syndrome. If you have torsade, if you have polymorphic VT in the presence of long QT, then only you call it as torsade. If you have a normal QT, you don't call it torsade, right? Then they are labeled as a polymorphic VT. Why this differentiation is important? Because if you have a long QT, torsade, you don't give amiodarone. You don't give class 1A, class 1C agents, right? They will worsen the situation, right? And you treat with magnesium and you try to shorten the QT with the help of pacing or with isoprenaline and try to salvage the situation, right? And try to look for causes which has led to long QT. Whereas polymorphic VT, similar kind of morphology, if it is there with long QT, if the QT is normal, then you can use conventional drugs. That is, you can use amiodarone for treating the same patient if your QT is normal, right? And therefore, this differentiation is important, whether you are dealing with a polymorphic VT or you are dealing with a torsade, okay? So what is happening in here? Can anyone say why this arrhythmia occurred? Hitanshu is here. I see a sign of Hitanshu. Long back, this ECG was captured by Dr. Hitanshu. Yes, a pacing spike is falling on the T wave. So it is iatrogenic cause of inducing polymorphic VT, right? Because the pacing spike has fallen on T wave. And how you can prevent it? In all patients who are on temporary pacemaker, if you feel when you are checking in your daily rounds that patient has started having some inherent activity, it is not completely dependent, you should see to it that your sensitivity of the temporary pacing is programmed to 1.5 or 2, so that the temporary pacer should not give inappropriate spikes. Here probably that kind of programming was not done, and therefore this kind of arrhythmia happened. So this does not require a long-term management. This is iatrogenic and simple programming. Of course, you will require shock right now, but once that arrhythmia is converted back to sinus, you will have to looking into pacing parameters that needs to be adjusted. And drugs alone is not an answer. Okay? And this is the last ECG that I would like to show. What is happening here? It's a paced rhythm. What is pacing? Which chamber is being paced? RV is paced because LVPB morphology is there. What happens to the last beat of, and you can see that it is occurring at a fast heart rate, right? What is the heart rate? It is mentioned up, 135, right? So pacing happening at the rate of 135, and if you see what is happening, that fast heart rate suddenly drops. And it drops with what? Is it? What is this? This is different than all other complexes, which has led to termination. That morphology is not left bundle branch block. It is like a right bundle branch block. And you see a pacing spike also there. What has happened? Has it really perforated and gone into LV and has paced LV? Is it so? And then arrhythmia stops. And then you have a paced atrium and native sinus, native QRS. So what happened? This patient continued to have arrhythmia for 24 hours in ICU. Amiodarone was given. Arrhythmia did not terminate. 24 hours, amiodarone was given in one of the ICUs and arrhythmia did not terminate. And one fine day, it terminated with this. And luckily, this event was captured. So it terminated because of what? it terminated because of PVC. This is a PVC, which is timed exactly during the coinciding with the paste QRS complex. It is not actually RV paste complex, but it is a PVC which has terminated this tachycardia. Okay, so this is a typical example of pacemaker mediated tachycardia. Right, pacemakers are usually programmed at a rate between 60 and 130. So any patient who is receiving a pacemaker, and if you find that there is a pacing spike occurring at upper rate, that is 135 or 130, you should suspect pacemaker mediated tachycardia. Right? We'll not go into the details of it, what happens it, but these are the patients where you require to program the pacemaker and see to it that the atrial complexes, they fall beyond the refractory period. They should not be sensed within that refractory period, because it's a endless loop kind of tachycardia thing happening, and this will not respond to medication at all. Right? So pacemaker programming only will help this kind of patients. So I think with this, I'll end the talk here. I hope I have been able to sensitize every one of you about what to look for in possible broad terms, rather than going into specific details. I hope all of you are awake and alert. Thank you.
Thank you, sir. Thank you so much. We'll take up questions during the lunch session. We'll speedily first take the Samir sir's lecture. Thank you, sir. We'll facilitate, sir. Chirag, sir.
Thank you, Dr. Chirag. I would like to call upon stage Dr. Amin to felicitate Dr. Chirag.
We are running short of time and all are waiting to have a delicious lunch, which is waiting for them. So we'll request our esteemed sir to stick to the time.
For our next session on antiplatelet drugs and CAD, I would like to call upon Dr. Sameer Dani, and I would request Dr. Vishal Darji to introduce him.
Good afternoon, everyone. Dr. Sameer Dani is a honorary cardiologist of Government of Gujarat, Governor of Gujarat, has been Professor and Chief of Cardiology, UN Mehta Institute of Cardiology and Research Center, Director of Department of Cardiology, Apollo Hospital, Gandhinagar, Life Care Institute of Medical Science and Research Center. One more I have added, CVHF Apollo at SG Highway, Ahmedabad. Education is MBBS in 1981, 1986, NHN Municipality College, MD from the State KM School of PG Medicine and Research, DM Cardiology from BJ Medical College, recipient of prestigious Govind Fellowship for year of 1995.
Good afternoon, everyone. Thank you for kind introduction, and it's a privilege to be here. Let me tell you, I'm very pleased to be here, and after last couple of years of online lectures, it's always a pleasure to be looking at audience. In fact, when this in-person lectures and conferences started, still in last few months, when I went to a couple of conferences, I still felt as if I was online because there was no audience. But today I am very happy to see the audience and having interactive sessions. So after Dr. Chirag's talk, which was very stimulating, we are onto something which is very mundane, very simple, which all of us do all the time. We prescribe antiplatelets day in, day out, in the middle of the night. So there is nothing much to talk about antiplatelets as such, but we have wealth of information. We have number of molecules now available, and we have number of strategies. which were not so many a few years back, I would say. So you can have a lot of treatment options for your patients when you are treating him or her with antiplatelets. So what are the molecules which we have right now? We have clopidogrel, of course, prasugrel, ticagrelor, and aspirin, the age-old antiplatelet. The ticlopidine has gone out. Clopidogrel has thrown it off. But these four are very much there. And we thought for a while that ticagrelor and prasugrel will take clopidogrel out, but that has not happened completely. And there are many indications, many parts of the world where clopidogrel is still being used pretty frequently. So we are going to quickly overview the same picture with the footnote about the mechanism of action. We know this very well. I'm not going to bore you with how clopidogrel, prasugrel work. They are P2Y12 ADP receptor blockers, and clopidogrel and prasugrel are irreversible binders, while ticagrelor has reversible inhibition of the receptors. While aspirin, as you know, acts via different pathway, COX-1. So let's go quickly to the clinical part. And as I said, there is a wealth of information, lots of data which has happened in last 10 years on antiplatelets. And I'll just give you some major controlled clinical trials, list of them. I'm not go into great detail of every one of them, but I'll go about talking. Yeah, thank you. I'll talk about the clinical implications of these trials. So can we adjust this so that we can read this title? Can you move this little away, a little to the right? Because this is not very important, but if you can. Okay, this is monotherapy. So these are the trials. Can we see the names of these trials? One of the first earliest trials of clopidogrel was Capri. Can you? It's okay. If you could read the titles, it would have been like little more illuminating. But anyway, Capri, Euclid, Global Leaders is one of the latest ones, and the Twilight and the Tycho. These are the trials of monotherapy. Tycho and Twilight you must have heard about. They happened just before COVID. And these were the trials of ticagrelor monotherapy. Capri was a trial of clopidogrel monotherapy versus aspirin. Euclid was ticagrelor versus clopidogrel. Global Leaders was aspirin plus ticagrelor for 1 month, followed by ticagrelor monotherapy versus aspirin plus either ticagrelor or clopidogrel for 12 months, followed by aspirin monotherapy. And Global Leaders did not show any significant difference between all these strategies. While Twilight and Tycho did show some effect in that sense that it decreased the bleeding. Capri showed some trend that clopidogrel was probably better, but again, none of these trials had very significant or very robust effect. These are the trials of antiplatelets plus anticoagulant therapy. So this trial, COMPASS, is one of the most famous trial where aspirin and vascular doses of rivaroxaban were used, and that showed that CV death, MI, and stroke, where composite endpoint was reduced better with DPI or dual pathway inhibition. And this was one of the first trials where the antiplatelet strategy was shown to reduce mortality. And this reduction in mortality was driven primarily not by reduction in MI or cardiovascular death, but reduction in ischemic stroke. So this was a very, very important trial to come out in last few years. Then you have Atlas ACS, again a trial with rivaroxaban, either 2.5 milligram or 5 milligram twice a daily versus placebo. It did show reduction in the composite endpoint, but again this was a trial in acute coronary syndrome, while COMPASS was a trial in chronic stable angina or chronic coronary syndrome as we know now. And in acute coronary syndrome, we still do not have a trial between DPI versus DAPT. So I'll come to that. And this particular trial, the Voyager PAD, was a trial of peripheral artery disease, so it doesn't interest us right now because the topic is coronary artery disease. And these are the trials of DAPT, and I'll take you back to CURE, which was one of the earliest trials of dual antiplatelet therapy of aspirin and clopidogrel. Then comes Clarity, which was a dual antiplatelet therapy in patients with ST elevation MI. And then came COMET, and then came the famous trial of DAPT. All these trials showed that with DAPT, some of the benefits were there, but some of the benefits were offset by increased bleeding. And this has been the problem, or this has been the core issue of any antiplatelet therapy. You want ischemia to go away. You want reduction in thrombotic event, and that's why you search for more and more powerful antithrombotic regimen. But at the same time, more powerful antithrombotic regimen is more likely it is to cause bleed. So it's a kind of holy grail that you search for an antithrombotic therapy which reduces thrombus in the coronary tree, reduces thrombus in the cerebrovascular tree, but doesn't cause bleeding anywhere. It's a holy grail. We may not find it at all. Then these are the DAPT trials of the newer molecules, prasugrel and ticagrelor. You have Triton TME38, you have Plato, prasugrel and ticagrelor, then you have Pegasus TME54, you have Themis PCI, and you have the latest one that was Host Exam. Host Exam I will harp upon because this was a monotherapy with clopidogrel 75 milligram daily versus aspirin 100 milligram daily for 2 years, and this was one trial which showed that clopidogrel was probably better as a monotherapy in this subgroup of patients. Now, let's forget these trials. What are the clinical implications and what are the recommendations? So let's start with, since we are talking about coronary artery disease, let's start with primary prevention. And we do not have any other molecule which has been studied for primary prevention other than aspirin. Only aspirin has been studied for primary prevention in coronary artery disease, and the data is not very clear. There are trials which have shown benefits with aspirin, and there are a number of studies which have shown that that benefit which you get in ischemic endpoints is offset by increased bleeding, mainly GI and central nervous, cerebral bleeding, but mainly GI. And especially in old age, where it is supposed to give you maximum benefit, it causes maximum bleeding. So benefit risk ratio in primary prevention of aspirin is very unclear. In low and middle income countries, aspirin containing polypill strategies have been shown to give benefits. We know our own polypill trial, Polycap, has shown good results. But again, there aspirin was combined with many other drugs. So you can't say that aspirin itself was responsible for this benefit. Antithrombotic trial is collaboration from 2009. That was a very good meta-analysis. If you remember, US physician study showed that aspirin was beneficial for primary prevention. And the British study showed that it was not. And the controversy started from those days. That was long back, late 80s and early 90s. Then this meta-analysis questioned the net benefit of aspirin in primary prevention because we have now concept of net benefit. Net clinical benefit, or NCB, is a very, very important concept. What benefit you get and what is the risk. And the difference between the benefit and the risk is called your net clinical benefit. And if net clinical benefit is not large, then that therapy is not worth doing on a mass scale. So again, the recent trials which were conducted in primary prevention, I'll just name them as PRE, which was conducted in elderly subjects, ASCEND was conducted in patients with diabetes, and ARRIVE was conducted in patients with moderate risk of first cardiovascular event. All these trials were conducted with aspirin, and none of them showed that net benefit of aspirin was good enough to recommend it for primary prevention. So as of now, aspirin in primary prevention is not universally recommended. In very, very few selected cases, the experts would say that those patients who are diabetics with high risk profile, they may benefit with aspirin as a primary prevention. So let's go quickly to secondary prevention. Aspirin still the cornerstone of secondary prevention, is the first line option out of convention and out of convenience. It is recommended as a monotherapy for long-term treatment in all categories of patients in sinus rhythm. So the patient is acute coronary syndrome, ST elevation MI, chronic coronary syndrome. All these patients benefit with aspirin as a monotherapy provided the patient is in sinus rhythm. Patient in atrial fibrillation, it changes. You go to anticoagulants. In patients with coronary disease and concomitant atrial fibrillation who are at high bleeding risk, there where you cannot give anticoagulation or where you consider monotherapy to be desirable, the choice between antiplatelet and DOAC will depend on the relative risk of the coronary plaque rupture or stent thrombosis versus that of stroke. So you have to, suppose you have a 90-year-old who is having atrial fibrillation. There you have to assess what is the risk of thrombosis versus what is the risk of bleeding. So suppose that 90-year-old has a stent, a recent stent, then you may, and he is at a high bleeding risk, then you may go for antiplatelet. But if that 90-year-old has coronary artery disease but has not been treated with a stent, then you may think of anticoagulation because the risk of stroke is higher in that person. So you have to individualize in these patients. In patients with combined coronary disease and atrial fibrillation at low bleeding risk, you can combine antiplatelet and anticoagulant both, especially because there is low bleeding risk. And the use of clopidogrel and DOAC is probably the best because that has been shown in the data to have least bleeding risk, giving you maximum benefit. So net clinical benefit is best with clopidogrel and DOAC, not with aspirin and DOAC, not with aspirin and warfarin, not with clopidogrel and warfarin, but with clopidogrel and DOAC. The risk is low, benefit may be little less, but the net clinical benefit is better. So this includes the patients post-ACS or post-PCI. Remember that. So across all the spectrum, if you want to use in those patients with low bleeding risk, post-ACS, post-PCI, you want to use combine antiplatelet with anticoagulation because they have AF and has undergone PCI, then you use clopidogrel and DOAC. You can use triple therapy for first week or first 1 month if the patient is having low bleeding risk. CAPRI study showed that clopidogrel versus aspirin, as I said, the trend was there with clopidogrel, but not very confirmatory. So aspirin still is being most widely used. But as I told you, one trial, the recent trial, where they showed that clopidogrel probably is better than aspirin if you want to give monotherapy. And that is the host exam trial. In patients who had received DAPT for 6 to 18 months after PCI with DES, subsequent monotherapy with clopidogrel compared to aspirin was found to be better. Okay, so that is in general for secondary prevention in basic principles. Now let's go to ACS and chronic coronary syndromes specifically. So what kind of therapy we should give in patients of ACS? DAPT is universally approved. All the data points to superiority of DAPT over monotherapy in patients with ACS. So DAPT is universally approved. Now which DAPT? That is the question. Generally, clopidogrel is approved as an add-on therapy to aspirin because of CURE, CLARITY, COMMIT, all these trials. And a consistent finding across these trials was the beneficial effect of clopidogrel as an add-on therapy. Current guidelines, how long? 6 to 12 months, followed by aspirin monotherapy. Here, we do not have evidence of clopidogrel being superior to aspirin, so by convention, we use aspirin. A shorter duration of DAPT can be considered in those patients at high bleeding risk, and DAPT may be extended beyond 1 year in those patients who have a low bleeding risk and high thrombotic risk. Prasugrel and ticagrelor are still not recommended as monotherapy in post-ACS patients because we have a lack of data. But ticagrelor still has much better data than prasugrel as a monotherapy. But it is justified when the risk of CV events is deemed particularly high, and where especially prior antithrombotic therapies have failed, or elective stenting with unfavorable risk factors like severe diabetes or left main stenting, then you can choose to give prasugrel or ticagrelor as a monotherapy. And there are trials where they have, one Japanese trial where they have used prasugrel as a 5 milligram prasugrel as a monotherapy. Both prasugrel and ticagrelor are superior to clopidogrel for prevention of thrombotic events, especially post-PCI. Remember that. So Triton TIMI 38 and showed that prasugrel is better, but it also showed that prasugrel is to be used with little bit of kind of pinch of salt, because more than 75 years of age, less than 60 kg of weight, prasugrel increases bleeding significantly. ISAR React 5 was a very interesting trial where prasugrel was compared with ticagrelor. And in these patients of ACS, post-PCI, prasugrel seemed to give better benefit. And that's why there are many experts who use in non-STEMI patients prasugrel if they are undergoing PCI. If they are below 75, if they are over 60 kg, they use prasugrel over ticagrelor. This trial, again, one of the last trials to come out was ticagrelor given in combination with aspirin for 1 month, followed by 23 months of ticagrelor monotherapy. It did not show superiority of ticagrelor compared to 12 months of standard DAPT followed by 12 months of aspirin alone. So this strategy, where it was felt that there will be less bleeding and more clinical benefit, did not happen. So Global Leaders was a kind of negative trial. While Twilight ACS and TICO did show that ticagrelor monotherapy was little better. So we don't know exactly where we are as far as ticagrelor monotherapy is concerned. 3 months of DAPT followed by P2Y12 inhibitor monotherapy may have advantages over the standard DAPT followed by aspirin monotherapy. In patients with ACS, who are at higher bleeding risk. Remember that. Physician-guided discontinuation of DAPT. In all the trials, it has been found when physician decides, not because the trial mandates, when the physician decides that DAPT should be discontinued, and when physician decides that DAPT should be continued, those patients do better. So it is still individual decision that matters. Now, chronic coronary syndrome. Generally, chronic coronary syndromes are treated with monotherapy. Dual antiplatelet is not mandated because increase in the bleeding risk, not so much increase in the benefit. And the monotherapy is usually aspirin. Now, COMPASS trial has come, which has shown that dual pathway inhibition with combination of aspirin and rivaroxaban vascular dose is better than aspirin alone, especially in certain high-risk subgroups. And this benefit has come because of reduction in stroke. Another trial is Pegasus TB54, where low dose of 60 milligram twice daily compared to 90 milligram twice daily of ticagrelor on a background of aspirin in patients with history of MI. Both ticagrelor doses reduce the risk of CV death, MI or stroke, but as well as an increase in the major bleeding. And the increased bleeding risk was lower in the 60 milligram group, but not very significant. So the lower dose appeared to be associated with reduced side effects, especially dyspnea. So ticagrelor 60 milligram twice daily on top of aspirin in patients with chronic coronary syndrome, in those patients who have prior history of MI and who are now chronic stable angina, this is worth investigating. Now, special subgroups, kidney disease. Kidney disease patients are at very high thrombotic risk. So it makes sense that they be treated, even if they are chronic coronary syndrome, they be treated with dual antiplatelet therapy. But none of the trials have shown that DAPT is better than monotherapy in these kidney disease subgroup. Why? Because thrombotic benefit increases, but the bleeding risk also increases significantly. So we do not have final answer in that. Diabetics, again, it made more sense that diabetics be treated with DAPT even if they have chronic stable angina. Again, no such benefit has been found. So diabetics are to be treated as far as antiplatelets are concerned like non-diabetics, though they have higher risk. But treating them with DAPT or anticoagulation doesn't give you more benefit. Elderly, same thing. They have higher risk, but they have higher thrombotic risk, but they have higher bleeding risk also. So again, you have to individualize. Short course of DAPT and DES is better than long course of DAPT with BMS. Elderly patients with established atherosclerotic disease should receive antiplatelet monotherapy or DAPT in the same circumstances as younger patient, with the proviso that clopidogrel may be preferred in elderly patients compared to prasugrel or ticagrelor. What are the other approaches to strategize our antiplatelet therapy in coronary artery disease? Two approaches have been investigated and are being investigated and considered exciting, though they have not shown us light so far. One is genotyping, and there are these many studies on that you genotype the patient. You find out which genes he is having, and by that you find out he is likely to respond to which drug, and you give him that drug. All these trials did that, did not show any benefit either way. Another approach is platelet function testing. Some years back, we were given the machines, platelet aggregometers in the cath lab, to know whether antiplatelet is working or not in that patient. And if it is not working, if it is not, 80% platelets are not inhibited, you switch over to another drug. All these trials, again, failed. Did not find which is the most beneficial effect. So platelet aggregometers are gone. No cath lab you will find them. So summary of options you have DAPT, you have SAPT, single antiplatelet, you have dual pathway inhibition, or you have full-fledged anticoagulation. And the strategies could be DAPT initially in ACS or post-PCI, followed by SAPT, or you could start with DAPT and continue with DAPT long term, or you could start with DAPT and once the patient becomes stable, goes into chronic coronary syndrome, after a year or two you follow it up with DPI. Or you could have DAPT plus DOAC in atrial fibrillation with ACS patient, followed by either DOAC with SAPT, single antiplatelet, or only DOAC, depending on the patient's risk. Or you could have chronic coronary syndrome from the beginning and you could start him off on SAPT, only single antiplatelet. So all these strategies are valid, and you have to find your patient will have maximum net clinical benefit from which strategy. So all these strategies, AF with ACS with high bleeding risk, you go for DAPT DOAC followed by DOAC, or AF with ACS post PCI high thrombotic risk, you go for DAPT plus DOAC followed by DOAC plus SAPT, like that. So you have to kind of tailor your therapy as per the individual profile. And still, these are not easy answers because most of your patients will be high thrombotic risk and high bleeding risk. This is where you have a problem. So to conclude about antiplatelet therapy in today's era, intensive platelet inhibition is a must, but it carries the price of increased bleeding risk and the risk of serious life-threatening bleeding in predisposed patients. So we have to be very careful to avoid that feeling of iatrogenic complication. In all patients, a careful assessment of thrombotic versus bleeding risk must be made, and then the therapy should be individualized or tailored. And we must recognize that certain patient populations will require specific consideration for specific antiplatelet therapy. Genotyping and platelet function testing, though they have failed so far, they remain the most exciting approaches to determine for our patients which antiplatelet therapy would be most suited. Thank you.
Thank you so much, sir.
Sir, when patient is on DAPT and want to go for dental procedure or GI surgeries or bypass, we should stop both aspirin and clopidogrel, or only clopidogrel will enough? Because we are getting different answers for this.
Yeah, so there are 2-3 aspects to this. One, the patient has a stent or not, and patient has undergone PCI with stent, I believe. How long back? So how far removed are we from the index procedures or the last PCI procedure? That is number one. Number two, what is the thrombotic risk otherwise? Like patient has 3 or 4 long stents, or patient has a 1 discrete stent. What are the other risk factors? Uncontrolled diabetes, smoker. These are the other additional risk factors. Third thing, how long your surgeon wants the antiplatelets to be stopped. Fourth, what kind of surgery you are going to perform. These 4 are the major issues on which you make your decision. So if your surgeon is doing genitourinary surgery or he is doing a spinal surgery, you know where the bleeding, if it happens in enclosed space, you can't control it. Then, and if the patient has had stent more than 3 months back, then you may agree to stop both the antiplatelets. And if your patient is high thrombotic risk, you may switch him to LMWH. Though again, this strategy has never been tested in a trial. This is expert consensus that you put the patient on LMWH. Whether that helps or not, we do not know exactly. But logically, maybe. So this is what we do as a protocol. If, on the other hand, patient is undergoing a TKR, then we do not stop both antiplatelets. We may stop one antiplatelet, but otherwise our patients continue.
Or aspirin, sir?
Either. I remember that one of our orthopedic surgeon likes to stop both. There is one who doesn't want to stop on any, and there is one who always stops clopidogrel. My GI surgeons always want to stop clopidogrel. So it depends on their perception. But basically, stopping clopidogrel aspirin for 3 days in a patient who is not very high thrombotic risk, who has had stenting more than 3 months back, who had not many long stents, we don't give even heparin as a bridge. 3 days is fine. So dental procedures, etc., there is no problem at all. Ophthalmic surgeons like cataract, they don't stop antiplatelets at all because they are going through bloodless field. So basically it is like that. Generally, as I said, we stop clopidogrel first because most of the surgeons believe that clopidogrel has a longer duration of action, and that causes more bleeding.
Thank you so much, sir.
Thank you, Dr. Sameer. I would like to request Dr. Vishal Darji to please felicitate Dr. Sameer.
सर 2 મિનિટ में મોકલાઈ દો.
And now for the last session, before we take a break for lunch, on approach to normal and abnormal anatomy of heart, on 2D echocardiography, I would like to invite on stage Dr. Ritesh Sukharamwala, and I will request Dr. Mitesh Chauhan to introduce him.
Dr. Ritesh sir doesn't require much introduction. He's a very well-known pediatric interventional cardiologist practicing in Surat for more than 10 years. He has numerous publications in international and national journals. He has been faculty to invited to national pediatric conferences, and he is very much eager to listen from Dr. Ritesh Sukharamwala sir. And my interesting topic as well, echo. So definitely our delegates will definitely learn something out of this talk. Thank you.
Thank you so much, Dr. Mitesh, for the warm introduction. I would like to thank Dr. Pragnesh, Dr. Mitesh, and all the members of IACC team for inviting me for such a wonderful program. What I am going to discuss is purely our bread and butter. Like being a clinical cardiologist, the echocardiography has been our bread and butter, and we need to do it very well. So what will be the scope of the talk? We will be identifying the cardiac structures, we will be learning the cardiac nomenclature and differentiate between the normal and the abnormal structures that we see inside the heart. And the way of doing it, what we call it as a segmental analysis. Why do we need to do it in a segmental way? Why can we directly jump on the atria, on the ventricle or on the valve? There has been a analysis technique which has been developed where first we need to start with the veins, then with the atria, then with the ventricles, the chambers, the outflow tracts, so that we completely analyze the heart before giving our proper diagnosis. If you have a child and you jump on the VSD, you see the VSD, you are very excited that you have seen the VSD and you give the diagnosis of VSD, but on the back side you have missed the coarctation of aorta. So that is the most dreadful thing that we have done, and because the VSD is a diagnosis which is not life threatening. Similarly, in an adult patient, when you are a young patient with left ventricular hypertrophy, one should always do the segmental analysis, always try to rule out coarctation of aorta. If you don't rule out coarctation of aorta in left ventricular hypertrophy young adult patient, then there is no point, because that patient is going to be asymptomatic. Even with coarctation of aorta, the patient is going to live for a long. Similarly, there are various examples like the patient diagnosed as having mitral regurgitation, patient planned for surgery, ultimately diagnosed to have a restrictive cardiomyopathy. So what I mean to say is we should always try to analyze the heart in a segmental way, look at all the parameters of the heart so that we do not miss anything. And how are we going to do? We are going to do based on the anatomical landmarks. The cardiac chambers is largely defined by the anatomical landmarks present on its internal surfaces. So we are going to learn the various morphological characteristics of the right atrium, the left atrium, the right ventricle, left ventricle, the great vessels and the relationship. Straight away coming to the morphological characteristics of the right atrium. What we can see over here is the subcostal view. Why subcostal view? Because we can see the liver. So when you see a liver in any sectorogram, the view is always a subcostal view. This is a bicaval subcostal view, and what we can see over here is the fibrillary structure arising from the lower surface of the inferior vena cava. This fibrillary structure is the Eustachian valve. This fibrillary structure, what we can see over here, Eustachian valve, is the fetal remnant of the sinus venosus. The sinus venosus is a fetal anatomy where the inferior vena cava, the oxygenated blood, is diverted from inferior vena cava into the left atrium, and because this valve is present, will not allow the blood to go into the right ventricle, but will allow the blood to go into the left atrium so that the brain reaches the oxygenated blood. So this Eustachian valve is a determinant that this particular chamber is the morphologically right atrium. Sometimes what we have seen is, we have seen multiple small meshwork of the things moving here and there in the right atrium. That meshwork sort of a thing, or the network sort of a thing, what we call it as a Sherry malformation. So when this Eustachian valve is very large, it gives like a network sort of a thing, and sometimes it is misdiagnosed as infective endocarditis. So we should always try to analyze the structures based on the clinical symptoms. So whether it's a vegetation or the Sherry malformation. So the first characteristic feature is the Eustachian valve. The second characteristic feature is the limbus of the fossa ovalis. So if you see the interatrial septum, it is formed by the septum secundum and the septum primum. The grooved sort of thing is called the limbus of the fossa ovalis. The groove facing to the chamber is always the right atrium. What we can see over here is the septum primum, septum secundum, septum primum, and what we can see is the groove. Here the groove is the limbus of the fossa ovalis facing on this side, so this chamber is the right atrium. any chamber which is receiving the inferior vena cava has to be the right atrium and the shape of the right atrial appendage. The shape of the right atrial appendage is that of the Snoopy's nose, where the base is broad and the diameter of the nose is narrow. So what we can see over here is the broader base, and this particular appendage is the right atrial appendage because the base is broad. The another structure which defines presence of this chamber as right atrium is the coronary sinus. What is coronary sinus? Coronary sinus is basically the coronary arteries blood which get deoxygenated comes into the coronary sinus. So this coronary sinus is the posterior most structure in the posterior left AV groove, and that we see as a slit like thing in the forechamber. Sometimes the coronary sinus get dilated because the left sided SVC drains into it. So the hepatic vein, coming to the hepatic veins. The hepatic veins either drain directly or can drain into the inferior vena cava before opening into the right atrium. So these are the characteristic feature of the morphological right atrium: the Eustachian valve, the IVC drainage, the right atrial appendage, the limbus of the fossa ovalis, the coronary sinus, and the hepatic veins. Now coming to the morphological characteristics of the left atrium. What we have seen is the limbus on the right side. So we see the flap. The flap of the fossa ovalis facing the chamber is the left atrium. And we see at least 3 pulmonary veins. As the IVC is defining the right atrium, the pulmonary veins will define the left atrium. So when you have at least 3 pulmonary veins draining into that particular chamber is likely to be the left atrium. Similarly, the right atrial appendage, you have the left atrial appendage. The left atrial appendage difference is it's like the Snoopy's ear. The base is narrow. The tricuspid valve, if you view and try to see the insertion on the interventricular septum, the septal tricuspid leaflet is slightly placed below than the mitral leaflet on the interventricular septum. So this particular thing is called offsetting. The tricuspid valve is more closer to the apex compared to the mitral valve. Be able to define the structures like this. So what we are seeing over here, we cannot define which chamber is particular chamber. There is no interatrial septum. We can see the pulmonary veins draining. We can see the IVC draining. So these things are all ill-defined, and what we call as a complex heart disease. We will come to this also in the later part of the talk. So after looking at the anatomy and the detail, we need to learn the orientation, what we call a special relationship, orientation of the various intracardiac structures with the surrounding extracardiac structures, what we call it as the abdominal situs, the atrial situs, the looping of the ventricles, the AV connections, the VA connections, and the great vessel relationship. So what we need to know is whether the RA goes into the RV opens into the pulmonary artery, the LA opens into the LV opens into the, what is the interrelationship, whether the RA is on the right side, LA is on the left side or the right side, those all things are to be also studied. So what the nomenclature says, so what is meant by abdominal or the atrial situs, means what is the relationship of the various abdominal structures to each other or the atrial structures to each other. So when the right atrium is on the right side of the left atrium, means right atrium is on the right side and left atrium is on left side, it is called atrial situs soleus. And when you see the subcostal sagittal view, what you see four structures, the liver, the inferior vena cava, the aorta, and the stomach shadow. So when you see the stomach shadow and the aorta onto the left side, and you see the IVC and the liver onto the right side, it means that it is abdominal situs soleus. But if you see inverse, like the liver is on the left side, the IVC is on the left side, but the aorta and stomach on the right side, this is known as situs inversus. Sometimes, like in this particular thing, what we can see is the whole thing is liver, the stomach is also center, both the IVC as well as the aorta are on one side of the spine. So what we cannot define as soleus also, we cannot define it as inversus also, so we label it as ambiguous. So when we are not able to define it as per the normal anatomy, we label it as ambiguous. So in case of ambiguous, the atria cannot be differentiated. You cannot feel that this atria is right atrium or left atrium, so you need to label it as atrial situs ambiguous. So there are two types of ambiguity, the one namely the right isomerism or the left isomerism. Right isomerism means everybody wants to become like a right side. So the right atrium is also want to become right side and the left atrium also wants to become right side. So nobody wants pulmonary veins. So this child is likely to have, patient is likely to have a TAPVC. Both of them wants superior vena cava. So the patient is likely to have bilateral SVC. Similarly, in case of left isomerism, nobody wants inferior vena cava. So it will have interrupted IVC and both of them wants pulmonary vein. So we will have PAPVC, partial anomalous pulmonary venous connection. So coming to the bulboventricular looping. Bulboventricular looping is an embryological event that happens during the formation of the heart, where it happens in such a way that if it dextroloops, the right ventricle will be on the right side and the left ventricle will be on the left side. Sorry, I cannot play this one. But what we can see over here is the morphological characteristic, right ventricle is on right side, morphological characteristic left ventricle is on left side. You see the moderator band, the tricuspidal offsetting, so this is morphologically right ventricle which is on the right side. So this type of configuration is called de-looping of the ventricles, but in this particular case what we can see is the moderator band is on the ventricle which is on the left side of the ventricle, and there is offsetting of the valve, the left AV valve is offset on the left side. So this, though it is on the left side, this ventricle is the morphologically right ventricle. So this type of looping is known as L looping, which is seen in corrected transposition. Bulboventricular looping is regardless of the atrial situs. What I mean to say that if the morphological left ventricle is on right side and morphological right ventricle is on left side, it doesn't mean that the same should replicate on the atria also. The right atrium will be on right side, left atrium on left side, still the left ventricle will be on the right side. But the AV valve always goes with the ventricle, means that if you have morphological right ventricle, always the tricuspid valve will be sitting on the right ventricle. You cannot have a mitral valve sitting on the left ventricle. Am I clear? So if you have a morphologically left ventricle, you will always have mitral valve sitting on it. So in this particular case, there is a left AV valve regurgitation, so it is the tricuspid regurgitation, not the mitral regurgitation.
So coming to the terminology, what we call is atrioventricular concordance and discordance. The name suggests like atrioventricular. What is the relationship of between the atrio and the ventricle? When the right atrium opens into the right ventricle and the left ventricle opens into the left ventricle, it is known as atrioventricular concordance. But if it is inverse, the right atrium opens into the left ventricle and the left atrium opens into the right ventricle, then it is known as atrioventricular discordance. Coming to the relationship of the great arteries. The relationship of the great artery is different from the ventricular-arterial connection. Like for example, the ventricular-arterial connection cannot be same as, what does it mean? In transposition, the aorta arises from right ventricle and the pulmonary artery arises from the left ventricle. But the relationship of the great vessel could be different. It means that. So how are you going to decide what artery is what, whether it is aorta or whether it is pulmonary artery? Based on the pulmonary artery branching pattern and the coronary artery. The vessel from which the coronary artery arises is likely to be aorta, and the vessel which is branching is likely to be pulmonary artery. Based on that, we can have different 4 types of relationship of the great vessels. The first is the normally related great vessels, where the aorta is right and posterior, and the pulmonary artery which is branching is left and anterior. These are normally related great vessels. In this particular case, what we can see is that aorta is posterior and to the left. The pulmonary artery is anterior and to the right side. The branching vessel is the anterior and the right-sided vessel. So it is I malpose great vessels, which all the inverses, what we see in situs inverses. In D malpose great vessels, the aorta is anterior and to the left, and the pulmonary artery is posterior and to the anterior and to the right, and the pulmonary artery is posterior and to the left, which is seen in transposition. And in L malpose great vessels, the aorta is left and anterior, which is seen in corrected TGA. So now coming to the dextrocardia, there are 3 types of dextrocardia. One is true dextrocardia, that is situs inversus dextrocardia. The other terminology is dextroposition, and the third terminology is dextroversion. So rather than understanding the details, we will see the photograph that will give us a very clear picture. What we can see here, the first picture is the normal anatomy of the heart. So this is the right atrium, right ventricle, and this is the normal heart. Apex is facing towards the left in the left hemithorax, and the RV is on right side and LV is on left side. But what is a true dextrocardia? It will be exactly the mirror image of the normal. So what we can see over here is the left sided structure are on right side and the right sided structure are on the left side, and the apex is facing the right. But in case of dextroposition is nothing. Somebody has lifted the heart and put it into the right hemithorax, but the orientation of the heart has not been changed at all. So you will have the same thing, the RA, RV on right side, the LA, LV on the left side, the apex is also on the left side, but the whole structure has been lifted and put into the left hemithorax, as if somebody has pushed the heart from right side to the left side to right side. But in case of dextroversion, what is the scenario? It is not the lifting of the heart and putting in the different place, but it is the rotation. There is a rotation along the axis. Along the long axis of the heart, somebody has hold the apex of the heart and rotate it in such a way that the apex is now facing the right side. So what will happen? That the right sided structure still will be on the right side and the left sided structure still will be on the left side, but the left sided structure will become anterior and the right sided structure will become posterior. So the normal, dextroposition and dextroversion, all the 3 will have a normal morphology heart, whereas in true image dextrocardia, the heart will be inverted. The right sided structure will be on the left side and the left sided structure will be on the right side. But in these 3 cases, when you see the 4-chamber view or any view, you will have the similar picture. So this is the normal placements of the probe when you do the normal echo in a normal heart. This is the subcostal view, the apical 4-chamber view, the long axis view, the short axis view, and the suprasternal view. It will exactly be the same for the dextro position, and it will be exactly the mirror image for the true dextrocardia. Similarly, when we have when we have a dextro version, you try to do it in this fashion, but if you see the normal morphology heart, then it is dextro version. But if you see the right-sided structures on the left side and left-sided structure on the right side, then it is a true image dextrocardia. So when you do the echo in a mirror image or a true dextrocardia, the subcostal view will be the similar one, but the apex will be facing towards the right side instead of left side. And this is the 4-chamber view. In 4-chamber view, the RA-RV, morphologically RA-RV are on the left side and the LA-LV are on the right side. What this is the LV which giving to the LVOT, and this is the mitral valve with no septal insertion. And this chamber is the right ventricle which is giving rise to the pulmonary artery. This is the long axis view. The long axis will be similar, but the probe will be in this particular plane. And this is the short axis view where the pulmonary artery is anterior and to the right side instead of being on the left side. Similarly, for dextro position, it will be exactly the similar what we see in the normal, but the probe position will be more toward in normal view. The long axis, it will be little bit on this side, but the whole thing has been shifted on this side. This is a long axis view. So coming to the nomenclature, before reporting the ECG, we use these types of nomenclature S, D, S, D, D. So what are these things? So the first letter is suggestive of atrial or the abdominal situs. It can be of 3 types: normal, inversus or ambiguous, that we have already seen. The second letter stands for looping of the ventricle, whether the right ventricle is on the right side or the right ventricle is on the left side. So when you have right ventricle on the right side of the left ventricle, it is D looping, which is normal, and L looping is seen in corrected TGA. And similarly, the relationship of the great vessels. The relations of the great vessels are of 4 types: the normally related great vessels, the D malpose great vessels where the aorta is right and anterior is seen in TGA, I malpose great vessel is seen in corrected TGA, and L malpose great vessel is seen in dextrocardia. Summarizing the whole event, so this is a 4-chamber view where what are the things that we can make out. This is morphological right ventricle, this is morphological left ventricle, RA, RV, LA, LV. So AV concordance is defined, D loop ventricle is defined, and in further 4-chamber view, 5-chamber view, we are able to see that the RV gives rise to the pulmonary artery and the LV gives rise to aorta. So VA concordance is also defined. So AV concordance, VA concordance, and D loop ventricles. Further, we are seeing the relationship of the great vessel. So this is the aorta and this is the pulmonary artery. Why pulmonary artery? Because this is branching. So this is a normally related great vessel. We see the aortic arch, so there is no coarctation. And we see the 3 neck vessels. When we see 3 neck vessels, we rule out double aortic arch. So when we are able to see 3 neck vessels, double aortic arch is ruled out. Here what we can see over here is the subcostal view where we are seeing the liver on the right side, the IVC on the right side, the aorta and stomach on the left side. So abdominal situs solitus. So how do you report so when you have a normal related great vessels, normal looping and normal atrial solitus, it is called SDS. So when you have SDD, means it is solitus, D looping, but the relationship is D malpose. So that is seen in transposition. ILI is inversus, so that is seen in dextrocardia. And ADD, A means ambiguous, you are not able to define. So it is seen in heterotaxis syndrome that we have learned in right isomerism and left isomerism. Thank you so much.
Thank you so much, Ritesh sir. Thank you so much.
see, we need to practice a little bit because we need to understand this talk is mainly for those where the time taken by the patient to move onto the table and off the table is more than the total echo time. So with this talk, your time for doing echo has to increase so that you see all the parameters on the echo before the getting patient down from the table. And this is going to help you a lot in terms of missing various things. Thank you so much.
Thank you, Dr. Ritesh. I would like to call on stage Dr. Mitesh Chauhan to felicitate Dr. Ritesh. I would request Dr. Vismay to felicitate our chairpersons for the session, Dr. Vishal Darji, Dr. Mitesh Chauhan and Dr. Amin. Now we'll be taking a lunch break for 1 hour and we shall gather soon to resume our scientific sessions. Thank you. As we are running short of time, the lunch break will be only for half an hour. So kindly gather after half an hour. Thank you.
Hello, 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 hello.
नीरज भाई चेक करो ना आएगी आएगी ओके ओके बस स्विच कर दो कम ऑन कर दो हाँ
शेखर नाम से आएगा हमारा
Hello. 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 Hello.
Hello.
Hello. Hello.
Yes, very good afternoon, friends. I know it is post-lunch session, so that's why we are trying to make it some interesting about finance. We all are interested in, I think, finance. So the next topic is financial and tax planning for doctors, and for that, I would like to invite Dr. Mitesh Chauhan to chair the session, and I myself, Pragnesh sir, will chair the session with Dr. Mitesh Chauhan. For today's that topic, we have two speakers. Mr. Nimesh Shah, he is a CA, Chartered Accountant from the Ahmedabad, and doing practices since 15 years, and also having a vast experience for audit and tax planning for national and international plus bank sectors. Our today's speaker is Mr. Piyush Shah. He is also Chartered Accountant. He is a BCom and fellow member of Institute of CA of India and Information System Auditor by qualification. He is a qualified peer reviewer on panel of Peer Review Board, Delhi. He has authored book on FFMC published by ICAI, New Delhi. He has written articles published in ICAI Journal. He is associated with hospitals such as CSC, Savita Hospital, KMCRI, and Bharuch Civil Hospital. He is also associated with the Medical College at Bharuch and all the medical institute with Dr. Kiran Patel. So now I invite both the speaker, Mr. Piyush Patel and Mr. Nimesh Shah. Please take your seat. Podium mic up. I got after announcing this topic, I get some questions from our doctors friends. So I would like to ask some question related finance, whatever the sent me by my colleague. So the first question is, according to you, what are legal requirements under various law for professionals like doctors that we have to keep in mind? Yeah, Mr. Piyush bhai, please.
Yes. Actually, if we see the legal requirements that required to be followed by medical professionals are, there are a number of laws like professional tax, secondly, Provident Fund Act is also applicable to every clinical establishment. Then you must be aware that GST is also introduced in little bit manner to the clinical establishments, hospitals, and other ESIC Act is also applicable. So there are these kind of acts are in normal way it is applicable to all the medical professionals, and in addition to that, everybody is knowing income tax and basic tax laws are always applicable. Yeah.
Hello. Let me suggest, looking to the time schedule that you are running short, I feel we should touch upon a few important things, if you permit so. हाँ? So दिल के डॉक्टरों को हमारा सलाम. Very good afternoon. Post-lunch session, as said, rightly said, Pragnesh bhai, is very difficult for all of professionals. But since we are professional and accustomed with this kind of things, and particularly, especially in international and national conferences like this, I am very much happy to see the galaxy of clinical cardiologists in our Sanskari Nagari Vadodara. I and Nimesh Bhai both are very much happy today that we are the part of this 11th national conference on clinical cardiology. I see the whole schedule. It is very technical. I think this is the only thing or the session which is away from your own life. I personally believe that doctors are blessed with the magical power to treat a life and to bring health in our lives. They always stand by us in whenever we have lost our hope. And एक शायरी में कहूँ तो ये और बात है कि आप इंसान बन के आए हो, ये और बात है कि आप इंसान बन के आए हो, मगर आप सब जमीन पर खुदा के साया हो. Friends, there is a great similarity. 1st July is a Doctor's Day. 1st July is a CA Day. Doctors are taking care of the national health, and we people are trying to take the economic health of the nation and the citizens of this country. Generally, I have observed that most of the doctors start earning late in the, around 28 to 30. And generally, probably 40 to 50 is a peak. Financial planning is a very important aspect for any professionals. I think we should divide our, today's session into very important things like the maintenance of books of account as prescribed under Section 44A of Income Tax Act. Then professionals, presumptive taxation, 44 ADA. Then thereafter, few important things from our perspective that a professional or a doctor should keep in mind in their financial planning. And then we will have an open session, open forum for any questions from your side. Is it okay?
So friends, as Piyush Bhai has told, the requirement of books of accounts that the medical professional has to carry out is prescribed in the Income Tax Act. I am not going to discuss the exact provisions because it will be, very much confusing. So I will give you a brief idea that every medical professional, which kind of books has to keep. The law says every medical professional has to maintain his cash book. One is a case register. There is a prescribed form that government has introduced. Every medical professional has to keep the records of the patients that he is treating in particular format. It is there, and I think everyone is following it. The section also provides that we have to keep bank account and receipts, the receipts that you are issuing to the patients. These are the 3 or 4 main requirements that every medical professional has to follow this.
Doctors have a unique feature, and the books are prescribed specifically in the Act. For other professionals, it is not so. But since every doctor is now using the ready-made software, I don't think they must be, maintaining all such. Software must be maintained as per the parameters. The second important aspect that is the offering of taxation to the income tax department. Now, for the ease of our all professionals who have qualified from the institutes, like chartered accountants, lawyers, doctors, architects, who are qualified professionals, they are very busy. And for that requirement, Vaidyanathan committee recommended the presumptive taxation in case of professional. In case of businesses, it is already there in a place, 44 AD, 8% and 6%. But in case of professionals, you all are aware, 50% up to 50 lakh. So in our parlance, tax audit limit for a professional is 50 lakh receipt. And if you cross 50 lakh, you have to undergo tax audit under section 44 AB of the Income Tax Act. Yeah. And today, I mean, this 30th September is the last day. So you all have to appreciate that we both professionals are there with you rather than in our office. If you are falling below 50 lakh, means the gross receipts is below 50 lakh, then you have an option to offer 50% of a gross receipt as your taxable income, and accordingly you can file your tax return. If you are falling below 50 lakh and still your profit is much, much lower than 50%, either you have purchased some machineries, I mean medical equipments, or you have purchased Mercedes-Benz, then naturally the depreciation will be more, and then the percentage will be of a net profit will be much, much lower. And under the circumstances, you again have to undergo tax audit because you are, I mean, showing lesser profit than the minimum prescribed. Right?
And one more thing, as Piyush Bhai is saying, there is again one more provision in this kind of presumptive taxation that you do not have to maintain any kind of books of accounts. Government will not ask you anything. So again, this is a, I mean, good provision for professionals. We can offer our tax on a presumptive basis to the government. Government will not ask a single document. There will not be any, you know, in a common parlance we can say scrutiny. So it is, I mean, advisable to take the benefit of this section. Yeah. One more recent development in economy is which affects medical professionals is in a GST. From July onwards, the council, GST council has introduced GST on certain, I mean, certain hospitals who are charging room rent more than 5,000. That will not include the ICUs, but those hospitals, those medical establishments who are charging more than 5,000 as a room rent, they will have to collect 5% GST from their patients and have to deposit to the government. All other activities like surgery, pathology, everything is out of GST ambit. But only this room rent is now within the GST net. So we should also keep in our mind all, I mean, those medical professionals who are having a hospitals and have a room, their room rent is more than 5,000. I think this provision should be taken care of.
Yeah. Can you throw light on hospitals running pharmacy store?
Yeah, definitely.
What will be the position?
Yeah, definitely. Pharmacy is always, I mean, within the net of GST. So any hospital having a pharmacy, turnover is for 40 lakhs only. So any hospitals having a pharmacy in house or outside the hospital campus, they will have to get registered themselves with GST authority and have to pay tax on the pharmacy revenue. Hospitals revenue, ambulance revenue, all are out of tax ambit, but pharmacy is always chargeable to tax. Yeah, total turnover, technically we are saying it's an aggregate turnover. Aggregate turnover cap is 40 lakhs. No, per annum. Per annum 40 lakh.
But I think healthcare services are exempt, so it will be considered under aggregate turnover?
Yes, absolutely. Aggregate turnover, the definition of aggregate turnover is a very wide. So aggregate turnover includes exempted turnover also, exempted supply also. So while deciding this limit of 40 lakh, we have to taken care of that exempted service also.
Say for instance, your healthcare service turnover is 30 lakh and your pharmacy is 20 lakh. Then I think it will be covered.
Absolutely.
And you have to pay GST on 20.
GST on 20 lakhs, yeah. 30 plus 20, we have to take, we have to check only for the purpose of that limit. Once you cross 40 lakh, then you will have to charge GST on the taxable supply only. Taxable supply is that pharmacy only. So hospital services is out of ambit of net, but pharmacy is liable to tax. All clinical establishments and all branches of medical as well. So this applies to allopathy, this applies to Unani, homeopathy, everybody. Yeah, one more important thing in GST is, as we understand, all medical services are out of the GST net. It is not like that. Certain fields in medical, like a cosmetic surgery, hair transplant, is liable to GST. Yeah. So those medical professionals who are in this field, they have to charge GST from their patients as well.
The recent judgment, recent development which has taken place, the introduction of section 194R, I mean it relates to the perquisites. If some company is giving perquisite to somebody and it is exceeding 20,000 per annum, then they are supposed to deduct TDS, tax at source, while giving these perquisites. Now, it is a very stringent provision, but I think it will be applicable to the individual doctors, because sometimes it happens that pharmaceutical companies do launch a system wherein if you prescribe medicine of some amount, some X amount, then they offer some Malaysia tour or some Dubai tour, and I think it will be covered as perquisite. And nowadays, you all are aware, the Income Tax Department is maintaining the Annual Information Statement AIS and Total Income Summary, technically called TIS. And based on your PAN number, Aadhaar number, every single financial transaction is reflected there. You must have seen while filing this year return also that off-market transaction, if you have transferred some shares to your son or daughter, it is there reflected in a AIS, TIS statement. And it will be difficult at the later stage, because at that point of time, if 194R as TDS has been made under that particular section, and if it is reflected there in your AIS, TIS statement, naturally you have to offer it as a taxation under income from other sources, and you have to pay tax accordingly. So this is a very recent provision and development that you must be aware of. I'm sure aware of.
Thank you, Mr. Piyush and Mr. Nimesh. Most of the questions have been answered. There is one last question.
Please.
On investment planning. So the doctors want to know what is the best time to start investment, what are the investment options that are available to them, and which according to you is good in terms of returns. And also if you could throw a little light on cryptocurrency and its tax impact.
Question is very big. We will give you all the answers of question in a very single line. First, when to start the investment? In my opinion, everybody has to start investing from his first earning. First earning. When I earn first rupee, I have to park something for my rainy days.
See, basically, it's I tell you, people always like to have ice cream on a cone, then a topping, and then one cherry. So this is like that. But see, as an Indian society, I must tell you that we have formed a habit to invest. And this is a good thing that we have learned from our predecessors. See, basically, it helps lot us in, casualties like COVID, we have all seen. So investment is always a good habit. But as I understand that doctors invest much more in a career, MBBS, MD, and then super specialists. So they invest more in career, but then I'd advise them to invest wisely, taking help of us, chartered accountant, so that, see, the burden starts from the education loan in most of the cases. For a medical student, the fees are very much higher because I know I'm associated with some medical colleges and hospitals. So it is exorbitant. And at that, I think the income part comes at a very later stage. But then if you invest wisely, see, nowadays, from my perspective, I can advise you, first of all, we have to take the insurance. See, I have seen and I have established some practice in our client. So if you are, starting hospital and taking loan for a hospital building and equipment, my advice, all of you, take a term loan, term insurance to the extent of your loan amount. So in case of any mishappening, that you will, or your family will not be the sufferer. Professional indemnity is again today's challenge for all of us, and we must ensure adequately. I think most of the hospitals and the renowned doctors are taking care of it, but all clauses sometimes at the actual
legal cases के अंदर बहुत ये helpful होता है.
At the time of actual claim, we should not be in a problematic situation, and for that we have to understand that. Another thing which I would like to suggest, that how many of you are aware about the Married Women Protection Act?
It is again a very important thing. Married Women Protection Act is there. So when anything, any liability that arises to husband, it can be recovered from the husband in any manner. So when there is a big loan that anybody has taken, and if he can't pay, then the banker can take the amount from all the properties that belongs to him or his wife also. So as Piyush Bhai is saying, Married Women Property Act is there. So again, Piyush Bhai, I request Piyush Bhai to throw some light on it.
I think it is a very old act, if I am not wrong, 1847 or something.
Yeah, but majority are not aware about it.
And people, most of the professionals are not aware about it. See, you have to take an insurance cover, and under Section 6 of the Married Women Protection Act, it is unattachable security, or it is an unattachable investment. So it is like PPF. You must be aware of. The PPF we are all investing and aware about. But I humbly request all of you to take insurance cover under MWPA Act. Each policy is considered under MWPA Act, and it will be a creation of a separate trust of you, your family members, and your own beneficiaries. And at the time of proposal, the proposer is expected to mention the trustees also, to whom he wants to delegate in case of mishappening. A policy under MWP Act simply means your insurance claim amount directly reaches to your wife, children, beneficiary, and insulating her or them from loans and liabilities that you owe, and thus an amount cannot be attached or taken away from repayment of debts by any statutory authority. That is
so in simple
the kick
term.
of it.
So in simple term, your liability are not extending to your wife. Your liability will remain always yours only. It will not be extended to your wife or a other family member.
It is a sum insurance.
It is a sum insurance. Yeah. Yeah.
10 lakh only. 10 lakh. To the extent of the cover only, insurance
So
cover only.
you can take a plan of, let's say, 5 crore if you have built up a building, and take a plan of 5 crore. So if unfortunate event happens or any eventuality happens and you could not make it possible to repay it, then the bank cannot attach that policy as a security amount that you have given to him.
It can be anything.
It can be anything.
It can be investment plan, it can be ULIP, it can be term insurance, it can be anything. Yes. You can have a combination of it.
You can have a combination.
Investment, term insurance, and ULIP. You can have a combination of it.
No. Only at the
At the time of proposal.
at the inception of the policy only. No. Because it has to be underwritten by the actuaries. That's why. Majority are not knowing about this. Na? So we request all the doctors, you consult your insurance advisor and ask them this question: ki, what are the possibilities of taking care of this? No, doctors never make some blunders. No. Actually, doctors, we feel doctors have a very busy schedule. I do have a number of clients as a doctor. The most important thing that doctors have to keep in mind that to maintain the records of the transactions that you are doing. In majority cases, we feel हम तो भूल गए, मुझे तो कुछ याद नहीं है. निमेश भाई, आप अपने तरीके से देख लो ना. नहीं, you can keep a record of it. You can now there is a lot of mobile application is there. You just write down कि भैया ये 2 लाख रुपए इसको दिए, 1 लाख रुपए यहाँ invest किए थे, ये 2 लाख रुपए यहाँ से आए थे. So this is the most important thing that we feel doctors are not taking care of.
See, my experience is altogether different. I had occasion to have many doctors who are very rich, and they are always faced with such Caesar survey at least 3 times in their lifespan, and they are so smarter than even a chartered accountant because they know each and every limb of the Income Tax Act. I tell you, I know even few doctors in Baroda also, they are so smart. So I don't agree with that contention. Only thing is doctors have more focus on their patients and their duty rather than their own family and own self. My humble request to all of you, see, professional as a EV professional always fail in planning our own investment and all. We should also give some time for that.
Share one book that we made available for our clients. That's a RED book. We named it as a RED book. REDBOOK. I will share to Pragnesh Bhai. They will. If there is some possibility to circulate the members of Iaccon, it will be very much helpful to you.
On MWPA, even if you have any, I will give my number. And if you have your own session, we can go for that.
रेड बुक का सॉफ्ट कॉपी तो अवेलेबल नहीं है. I will try my best. अगर मुझे मिल जाता है तो. Yeah.
We'll have to conclude this session as we are running short of time.
Thank you, Mr. Piyush and Mr. Nimesh.
Thank you.
For sparing
Thank you.
your
Thank you.
valuable time and sharing your expertise on finance and investment with all of us. It was a pleasure having you with us here today. Now I would like to request Dr. Pragnesh Shah to please come on stage and felicitate Mr. Piyush and Mr. Nimesh. And now I would request Dr. Tanvi to felicitate Dr. Pragnesh and Dr. Mitesh.
There is small changes in the program. We will take Dr. Vijay Raghavan sir's orations after Dr. Kamal Sharma's talk. Due to some technical issues, the link is expired due to some time difference. Now it's my privilege to અને કરો ને એક જ મિનિટ માટે સ્વિચ કરો એક મિનિટ માટે. Yeah, it's my privilege to introduce Dr. Kamal Sharma sir. Dr. Kamal Sharma is a senior interventional cardiologist with vast experience of coronary angioplasty, stenting, valvuloplasty, pacemaker and pediatric intervention. He has a rare combination of DNB degree with both medicine as well as cardiology. Apart from practicing in Sal Hospital, UN Mehta Institute of Cardiology of Ahmedabad, Dr. Sharma has also been teaching the subject of cardiology at the BJ Medical College. Awarded 22 gold medals for academic excellence during medical studies. Did world's first vagal nerve stimulation device implant as a part of Anthem study in refractory heart failure. Discovered a winking coronary sign of VSR on angiography, also called Kamal Sharma sign of VSR. He is the rare cardiologist from India. On his name, there are few signs in the field of cardiology. Principal investigator in trial like heart failure trial, TIMI, Atlas TIMI trial, TIPS trial, and there are multiple trials conducted under his guidance. There are more than 200 publications and more than 8,500 Google Scholar citations. Awarded Excellence Teacher Award in Gujarat by the Gujarat University. Only cardiologist to have cleared civil service in first attempt. This is I think something we all should appreciate. And author of 8 books and many chapters. In short, Dr. Kamal Sharma is an institute in himself. Dr. Kamal Sharma, please.
And to chair this session, I would like to call upon stage Dr. Avinash and Dr. Sagar Solanki.
Thank you, Pragnesh Bhai Association, for calling me. Good afternoon, Baroda. Good afternoon, everyone. So it's a pleasure to be here. So before I start my talk, let me start with a question. So all inclusive, jetla bhi tame patient jo cho, ema ketla percentage ke majority patients ne, because you see cardiac patients. So I believe you all are treating predominantly cardiac practice. And so in cardiac patients, if you see how many of you is more likely to prescribe diuretics versus SGLT2 inhibitor? That is my question. So how many of you give diuretics? It's more likely that your prescription will have a diuretic and not SGLT2. Please raise your hand. અત્યારના prescription patterns માં અત્યારે જે થાય આપણું prescription હોય કાં એને Frusilec કે Diator કે XYZ. And how many of you will not have a diuretic but have an SGLT2 and is a cardiac patient? I'm sure and I feel that after the lecture the numbers would change. So we all understand what is heart failure. It poses a global problem, more than 60 million people worldwide, and in India it's almost 1% of adult population, which is like almost 1 crore of population which is living and is diagnosed as having heart failure. And it's the number one reason why a patient gets admitted in your hospital. If he's more than 65, 24% are again readmitted within first 30 days. And 50% of these who you diagnose and discharge, they will die within 5 years. So this is the problem that we have. And when you look at the kind of patients who are undiagnosed, this number can be huge. Also, now we have various stages of heart failure. I thought in my lecture, I'll also touch upon the stages and some pathophysiological backgrounds. Stage A is anybody who's at risk. So practically in your chamber, કાં એ ડાયાબિટીસ માટે આવે, કાં હાઇપરટેન્શન માટે આવે, કાં ઇસ્ચેમિક હાર્ટ ડિઝીઝ માટે આવે, કાં ખરેખર હાર્ટ ફેલિયર માટે જ આવે. So practically all your patients are stage A heart failure. Now let's make this clear. So anybody who's got a risk factor, no symptoms, no damage to the heart. So any patient who's got diabetes, hypertension, obesity, family history, IHD, angioplasty, whatever, even if ejection fraction is 55%, no Q wave in ECG, echo fantastically normal, fantastic PAMI done by myself or your cardiologist or whosoever, maybe yourself, and still he is stage A heart failure. Stage B is somebody who's got an LV dysfunction but does not have overt symptoms. So if now you have done a PTCA, ejection fraction is 48%, then next echo you do 52% and then 50%. Still he is stage B heart failure. Stage C is anybody who's got now symptoms with it, and D is of course refractory beyond the guideline directed therapy if the patient is symptomatic. Now almost 75% they will have additional one risk factor. That's what I meant. So you have either diabetes or hypertension or valvular heart disease or obesity or age or hypertrophy, or so 75% of your patients have an underlying modifiable risk factor, of which type 2 diabetes is common problem. So I tell in diabetology forum કે it's criminal કે તમારું ડાયાબિટીસનું પેશન્ટ હોય અને તમે SGLT2 ના આપી હોય unless you have a complete contraindication, like you have a acute ongoing pyelonephritis. ઠીક છે, ના આપો. But it's criminal not to give. And same I would say has to extend into cardiology forum. I used to remember when I used to go to Iaccon diabetes conference that you know of, I would be the only cardiologist sitting there, and there will be a lot of forum of all diabetologists, and they would wonder કે આ cardiologist અહીંયા SGLT2 માટે કેમ બોલવા આવ્યો છે. And then after a couple of years they started pitching me કે હવે તમે બોલો કે આ cardiac molecule છે, and they will ask Professor A.K. Singh to debate against me and say, of course આ cardiology નું molecule નથી, આ diabetology molecule છે. Today with the science that we have, like DAPA-HF, like DELIVER, like Emperor reduced, Emperor preserved, now it's time to turn the table back to them. Okay, it's our molecule, you hijacked it earlier. જેમ statins માં થયું, અત્યારે કોઈ diabetologist આઈને કહે તમને કે મારે લખવી, તમે ના લખી શકો. You are the first prescribers of statins. I think that science is now happening into the SGLT2 with a due risk and caution associated with it. So you can have ASCVD, hypertension will lead to ischemic heart disease, metabolic structural derangement, and all together will transmute into heart failure. And heart failure and LV dysfunction are early and often undetected complication because it need not be. Because undiagnosed heart failure patients are detected in 28% of diabetes during cardiac screening, and this is Western number. I was doing a study with Dr. Bansi, and he was looking at his patients and I was looking at mine. કે જેટલા diabetic patient આવે, let's set an anti-pro BNP and look at for their age control with a normal EGFR. In his practice, I thought ke mara ma vadare avse, I'm a cardiologist. In my patients, I got it in 60% that NT-proBNP in diabetic patients were high. In his patient, he said, Kamal, marte machine kharab lage, 90% are positive. I said, it's not a problem of machine, how bad we Indians are and how much we are undiagnosed and unscreened. That is the problem. So 68% have asymptomatic LV dysfunction at 5 years after diagnosis of diabetes. This is another number. 5 years of diabetes, 68%. And what is the risk of CAD? CAD is 60% at 10 years. So heart failure precedes development of acute MI. I was talking in one of the lectures today on the way from Ahmedabad to Baroda online, and I have another lecture when I'm going back. So I'm utilizing time my optimally as I was listening to money management. Here is no money, but I probably am managing knowledge. But with the due disclosure. But I think the slide that was appealing is ke MI ketla diabetics ne thai. How do diabetics present to you? They present with MI in 8 to 10%. But how many of them present to you with heart failure without ACS or MI? 18%. Commonest presentation is either PVD or heart failure, not an acute MI or stroke. And it's the most common first manifestation, as I said, in 24% of patients, PAD, 10%, MI is just 14%. So there is a big interplay. If you remember, there is a trial called Accord. Accord trial in diabetes was the first trial. Jetlu tight HbA1c karishu, etlu saru outcome avu જોઈએ. શું થયું એમાં? ઊંધું. Tighter the diabetes control, there was higher acute coronary events. And then people said, why could this happen? How would this happen? It happened because the tighter control group had more episodes of hypoglycemia. And hypoglycemia triggers sympathetic activation. So these diabetics who had a stable plaque, their plaques became unstable, presented with an ACS. So the tighter control then was further analyzed, and the drugs that cause hypoglycemia, sulfonylurea, SGLT2, insulin, these were supposed to be the culprits, and that's why hypoglycemia, apart from hyperglycemia, is also a problem. So you can add to this the other problem in pathogenesis, but the risk of transient hypoglycemia, especially if severe, can also be a big interplay and responsible factor for development of acute events. Heart failure, if the patient does not have, versus those who have, the 5-year Kaplan curve will tell you that the mortality is very, very high as compared to those who did not have heart failure. This is a meta-analysis, and this is a big forum of echocardiographers. Meta-analysis of 27 echocardiographic based studies, LV diastolic dysfunction. So what Dr. Bansi Sabu and I were looking at was a lot of these patients who did not have so-called echo of normal and so-called grade 1 or 2 of diastolic, which we think is okay to have, actually have big amount of diastolic heart failure. 46% of patients with type 2 diabetes have diastolic heart failure. SGLT2 and heart failure benefits, when you now look at, SGLT2s have been proposed by various mechanisms, including Subodh Verma now proposes Ang1-2 receptor modulation. And I also strongly believe that ultimately everything comes at the center of the cell, which is the mitochondria, which is responsible for energy modulation. So SGLT2s probably act and modulate through their mechanisms, probably in the mitochondrial pathways of how you happen to utilize the substrates. So it causes increased natriuresis, diuresis, glycosuria apart, reducing the preload, but there is metabolic efficiency that comes in when you give SGLT2 like dapagliflozin, reduces oxidative stress, fibrosis, epicardial fat, and neurohormonal stimulation. And this on top of with improvement in endothelial dysfunction and fall in vascular resistance will decrease the afterload. And that's the reason pancreas nathi, that people like us and you should claim this as a cardiac molecule. Its additional benefit is it also lowers glucose. Jokingly, I say that. So there have been various trials now. It all started with the EMPA-REG outcome, the first trial. And it showed that in these patients, 100% of patients had MI, angioplasty, bypass, or something done. And then they were diabetic also. All of them were diabetic. All of them had some coronary event. And then as a treatment of diabetes, they were given SGLT2 inhibitor. Compare this with the other trials. Now we have a trial called Vertis. Similar trial design. Absolutely class copycat. All patients had same. Results were different. So આપણે જે વિચારીએ છીએ કે class effect, I always used to say this for ACE inhibitors also. For beta blockers also. Beta blockers, do you use atenolol? You don't use as an heart failure therapy. Because one beta blocker may not work like the other. This is the case all across the spectrum. SGLT2 1 upon SGLT2 ratio may also be an important determinant factor how the molecules differ. Vertis CV ની same trial design હોવા છતાં બી mortality difference ના આવ્યો, પણ EMPA-REG માં mortality difference આવ્યો. And people were shocked. I mean, આ બધું થયું તો કેમ? Pioglitazone causes, rosiglitazone causes more problem, and pioglitazone causes heart failure. And US FDA say, na, diabetes na patient ne, cardiac patient hoy, so you have to show it that it is safe. It is not worsening the heart failure. The worsening prove karta jata superiority prove thayegi. And then people realize, oh, this is a different ball game. I mean, we need to think of reducing heart failure. And then of course declared-TIMI came, which had 40% only patients who were established heart disease, 10% had heart failure history, and EGFR also less than 7%, and then declared-TIMI established this therapy. So when you look at the various subgroups, EMPA-REG at 100% secondary prevention, Canvas has 1/3, 2/3, declared-TIMI, which is dapagliflozin at 60-40, and then there are risk factors without ASCVD when some other molecules like PVD have been evaluated, which is beyond the topic, and I believe the subsequent speakers will take care of that. So heart failure, hospitalization in presence of ASCVD is an important predictor. You don't want your patients of diabetes to get admitted with heart failure. And that was reduced across the class. So heart failure prevention is probably a class effect. You have that even with Vertis CV. But what do you want only to prevent heart failure and let him die of something else? No, I don't want my patients to die. And any therapy that will prevent death cannot be challenged. You know, if you do something and what it does, sir, it saves your life, I think that therapy has to come in your line of therapy. So that's the reason. Tame torsemide ke furosemide apo cho, does it prevent death? No. It just relieves symptoms. So when you want to prevent not only symptoms and reduce mortality, you'll have to choose a therapy like an SGLT2 inhibitor. And when you compare further the risk reduction of CVOT, which shows significant consistent improvement across the spectrum, whether you have ASCVD, and now there have been evidences emerging that patient did not have established ASCVD, only diabetic, without coronary artery disease, even in them, occurrence of heart failure is prevented, and the major adverse events are also reduced. Even whether you had previous heart failure or you did not have the patient having heart failure. એટલે એવું જરૂરી નથી કે heart failure થાય એટલે જ ચાલુ કરું. When you give this therapy before the patient has developed heart failure, you prevent still the new onset of heart failure. So irrespective of that, the therapy works. And the very important trial then was designed was called DAPA-HF. હવે એમણે લાગ્યું કે આ તો ભાઈ હાર્ટ ફેલિયરનું કામ કરે છે, ડાયાબિટિકમાં કરે, નોન ડાયાબિટિકમાં કરશે કે નહીં. So 50% patients, actually more than 50% patients in this trial were non-diabetic patients. No diabetes, only heart failure, put them on dapagliflozin. And compare with the standard subgroup. And ARNI bhi chalti hoy, beta blocker, ACE, ARB, whatever they want to give, all therapies are allowed, and on top of that, you give dapagliflozin. What was the outcome? There is 25% reduction of CV death and heart failure hospitalization as a combined endpoint. Again, EMPA-REG and DAPA, any comparison ni kyarek baat nahi kar sakta. Guys, one or the other therapy has some differences in the trial designs and hence the outcomes. But barring these two, other molecules don't have an effect. Heart failure ma, I say DAPA turned the tables on empagliflozin because it not only came first, but also showed mortality difference as an individual combined endpoint, not just as a combined endpoint, which was not showed in EMPEROR reduced. So worsening of heart failure prevented by 30%, and this is important, which I say, cardiovascular death by 18%, and whether you had diabetes or no diabetes, when you give dapagliflozin, irrespective of that, there is important reduction in primary endpoint, which was statistically significant, which is a combined of death, heart failure, hospitalization, or urgent heart failure need. So actually, diabetes was 25% reduction, but no diabetes to 27% reduction. This is a number difference, but both it means that diabetes or no diabetes, it works across the spectrum. And secondary prevention of CV death or heart failure hospitalization also reduced, including death, by 25%. Again, the other trial, as I said, was EMPEROR reduced, which is looking at the empagliflozin. Again, they compared the two, and in that subgroup also, the composite endpoint was reduced by 25%, but death was not reduced significantly. So death is not reduced in EMPEROR. You can debate about the trial designs between the two groups, and the significant and meaningful CV benefits in patients across heart failure continuum, hence was again established. Whether you have type 2 diabetes with low CV medium risk, or you have ASCVD, or you have ASCVD prior MI or reduced ejection fraction or preserved ejection fraction across it. So there are 3 trials of heart failure. One is soloist HF, sotagliflozin, not available in our country. DAPA HF, which is phase 3 trial again, which showed important reduction, including 18% reduction in CV death, and 8% reduction only was found, which was not statistically significant with empagliflozin and emperor reduced. So there is a large phase 3 morbidity mortality trials that have been there now. Ambulated patients, hospitalized patients, acute patients. There is a trial called Impulse where they have now started empagliflozin at the time of discharge in acute LVF. Indoor patient, the ongoing trials are there, DAPA-ACT HF. So the guidelines, including the American Diabetes Association, now talks about that in patients with heart failure is predominant, you should prefer SGLT2, which is ahead of metformin also. You can choose before metformin. Nobody has challenged metformin like this ever before. And ACE guidelines also talk about in entry point, if the A1C levels are high, you can go to dual therapy. If it's more than 7.5, less than 7.5, you can choose monotherapy. So 2019 ESC guidelines also tell us the same, that SGLT2 inhibitors in type 2 diabetes patients who are either on metformin or not on metformin, you can choose SGLT2 or GLP-1 analogs in patients who are having ASCVD. 2020 expert consensus guidelines or 21 update to ACC expert guideline, all are now suggesting that heart failure ejection fraction less than 40% with or without diabetes, class 1 to 2 heart failure also should be given on top of standard care and SGLT2 therapy. It not only improves heart failure hospitalization, but causes reduction in even worsening of kidney failure prevention. You know, most of our diabetic patients creatinine vadhu. When you give SGLT2, slightly creatinine rises initially, but then it improves subsequently. What I do is I take off their diuretics. Don't give diuretics, it's a substitution. You can reduce if the patient is not much congested, don't give diuretic. You can give MRA, there is spironolactone or eplerenone, but you can opt out for other diuretics. And there is secondary composite endpoint again reduced by 29%. So why SGLT2? Proven benefit across heart failure, early onset CV reduction, lesser safety concern. What you need to monitor? Best thing was કે genitourinary urinary infection જે થતા હતા diabetics માં, આમાં diabetes છે જ નહીં તો urine કે આમાં sugar જવાનો બહુ સવાલ જ નથી થતો. So UTIs don't happen. Actually in these trials, incidence of UTI was as bad as placebo. Placebo માં જેટલું UTI એટલું જ heart failure. So that risk is out. I mean, only in uncontrolled diabetes you get a lot of UTIs because of high amount of glycosuria. And it works through multiple salutary effects, volume pressure offloading, beneficial effect on renocardiac axis, improved cellular metabolism. That's a foundational therapy in reduced ejection fraction. Now you have data from DELIVER, which also establishes it in preserved ejection fraction. So patient je tamari jode ave શ્વાસ ચડે છે, blood pressure control છે, and you see good amount of LVH, grade 2 diastolic dysfunction, elevated NT-proBNP, don't give diuretics because they have again volume dependence. Give them SGLT2 inhibitor. So at hospital discharge, if stable with EGFR more than 20 to 30, you should put this. So this is a comparison between the two trials, but very important thing is functional class 3-4, diabetes or no diabetes, even if the patient is on ARNI, 11%, 19% patients were on ARNI in these trials. Still, even at 1 year. And how early does this prevent? There is an analysis. તમે આ દવા ચાલુ કરો, what is you expected કે first mortality ક્યારે prevent થશે? When you get a net number to treat. So what do you mean by it? 21 patient ને તમે dapagliflozin આપી, તો પહેલું hospitalization within 2 weeks prevent થશે. અને પહેલી death 1 મહિનામાં. There is no other therapy that has shown things like this, barring maybe ICD. That too in secondary prevention. But એમાં બી ઝાટકા વાગે છે. અહીંયા નથી વાગતા. So beyond that, there are not any other therapy that you can tell you such a rapid, and the results of course in DAPA HF, when you compare with emperor reduced, the significant benefit of course all cause mortality is one thing that is in favor of dapagliflozin as compared to empagliflozin. Heart failure, as I said, is probably a class effect. So it's a very exciting time with SGLT2. And now tirzepatide is going to come, maybe another therapy which will come as an injectable, which is people are talking as the therapy of weight loss in future and good diabetes control because of its an injectable nature of GLP-1 apart from GIP activation inhibition. So overwhelming evidence of SGLT2 reduce the risk of hospitalization and need to treat and prevent heart failure with reduced preserved ejection fraction. It reduces death and heart failure hospitalization. Thank you very much. Over to Chair for the question.
Hello. Very well summarized lecture taken. When you listen to him talking, you have a question in your mind, is this a cardiologist speaking or an endocrinologist speaking? Because when he says, and everybody prescribes dapagliflozin. Now, not maybe with the passion that he has and the conviction that he has and belief in the molecule. So people might think a very, very well apt and precise talk to the point.
Thank you.
Thank you, sir.
Because this DAPA, we label that it causes urinary tract infection, and particularly female patient. Now, how in practice we can decide whether it is culprit is DAPA or is diabetic female patient prone to urinary tract infection?
Fantastic
so
question.
sometimes what we think that and we stop the important molecule because of patient is getting recurrent infections, means every 2 months, 3 months with the same complaint we stop. So how to decide? This
Very
is
good
one.
question.
Second, what should be the maximum dose of DAPA we should give to Indian population? EMPA and DAPA, which molecule is better? Because you one line escape means you have not said particularly on that because only one line.
હું બંને માટે બોલતો હોઉં છું ક્યારેક એમ્પાનું બોલવાનું
એટલે મારે EMPA અને DAPA માં which molecule is better? Only one or two
I'll cover that.
practical tips.
Yeah.
And for non-diabetic patients and heart failure patient, what should be the maximum dose we can give to the patients?
Good question. So first is UTI. આ પેલા જેવું છે ઇરેક્ટાઇલ ડિસ્ફંક્શન વિથ બીટા બ્લોકર જેવું. પેલાને કહી દીધો તો એટલે પેલામાં પેશન્ટને ફીલ થતું હતું. અહીંયા ડોક્ટરને ખબર પડી ગઈ કે યુટીઆઈ થાય છે એટલે ડોક્ટર શોધ કરે. પેશાબમાં બળતરા નથી ને બેન નથી કે હા આજે થઈ હતી થોડી એટલે તરત ડાપા ચેકડો. એટલે that's a problem, I know. So it's like erectile dysfunction on beta blocker. A lot of it has got a placebo effect, sometimes on physicians. But I think it's more of fungal infections, which is more characterized by itching. That is more likely to happen rather than UTI per se, full-blown UTI. Even when you look at the data of the EMPA-REG outcome, or even for that matter in DECLARE TV, incidence of UTI urinary symptoms was 11%, but UTI was only 1%. So you are very right, it's 10 times the difference between a full-blown genitourinary tract infection versus fungal infection, which is more common, or melanoposthitis in males is usually fungal. And the best way to it is genital hygiene. So what I tell, only thing that I tell my patient is, દરેક વાર bathroom ગયા પછી local parts ધોવાના. This is common problem that we as a habit don't inculcate, even in our children. So that's how we all grow up. You go to the loo and come out, ખાલી હાથ ધોવાના. So that ખાલી હાથ ધોવાના will not do. So that is number one. Number two is what I do when the patients are diabetic. I try to give them some other agents that try to bring down their sugar levels quickly down and then add a DAPA, maybe in a couple of days. Not delay it much. Reason is your glycosuria is often proportionate to your serum glucose levels. Tamaru glucose jo 150 hate to amount of glycosuria is going to be less. And third instruction that I give them is plenty of water. Because the more you dilute your urine, the lesser glycosuria is going to be there and lesser is the likelihood of nidus of getting a UTI. Fourth point that a lot of my physician friends practice, which I don't endorse, is once a week dose of fluconazole. Now this you can think of in some patient who's got recurrent melanoposthitis and you are as passionate about SGLT2 as I was. And then you can stick to it. But about a patient who's got a UTI, will you re-challenge? I often do. I treat it, correct it, get in back with all the guidelines that have been talked about, ask the patient to take care of it, bring down the sugar levels as rapidly as I can, and again re-challenge with SGLT2. So I often give them SGLT2. Only place where I don't give is pyelonephritis, upper urinary tract infections. That's one place where I don't give. With even CKD up to eGFR of 20, empagliflozin has been studied. DAPA has been studied up to 30 eGFR. So તમે બેમાં ક્યાં કરશો તો એક આ કારણ આપ્યું કે this is evidence. Emperor reduced 20 eGFR, DAPA HF, eGFR inclusion criteria was 30. Now, સાહેબ ચલો there is no EGFR આવે તો એટલું થાય ત્યાં તો diabetolnephrologist, then we are out of the picture, એવું થઈ જતું હોય. In that case, what I follow, patient has got established ASCVD. If I have done an angioplasty, if I have put a stent, I have done a bypass, patient is post-MI, my preferred agent then is empagliflozin. The reason is that it is EMPA-REG outcome, which is the only trial in secondary prevention to show individual mortality reduction. કોઈ બી દવા જો એમ કે ભાઈ all cause mortality ઘટાડી દઈશ, તું સુસાઇડ કરીશ કે પંખાથી લટકીશ કે ગોળીબારમાં મરી જઈશ, બધું ઘટી જશે. All cause mortality, you know, not CV death. If any therapy does it, that therapy has to be frontline. Declare-TIMI did not show it. But in heart failure, I say, DAPA people got smarter. They realized how to choose patients. You know what they did? EMPA-REG, why it was so? Because they choose the sickest of the sick patient. જેનો LV dysfunction હતું, diabetes હતું, 10 વર્ષની IHD હતું. So these were sick patients. So when you follow these sick patients, mortalities is going to be high. And so mortality benefits will be reflected. So DAPA people, I believe, the steering committee learned how to design a trial. So in DAPA-HF, they designed a trial to choose again similar subgroup of patients, even though empagliflozin people tried to act smart in terms of including inclusion criteria of atla GFR, atlu EF, atlu GFR, atlu EF kind of criteria, which again has a fallacy because એ લોકોના બે જે ટ્રાયલ થયા એમ્પેરર પ્રિઝર્વડ અને એમ્પેરર રિડ્યુસ્ડ, I brought this out to their steering committee chairman, એમાં એક ગ્રુપ એવો છે EF of 40 to 50%, જેનું એન્ટીપ્રોબીએનપી જો થોડુંક જે 3 ગણું રાખ્યું હતું એની વચ્ચે હોય તો એ બંનેથી એક ગ્રુપમાં સ્ટડી જ નથી થયું. એટલે મેં એમને પૂછ્યું આના પ્રમાણે તો તમે બંનેમાં આ પેશન્ટ તો આપી જ ના શકો. So that's the overlook that they had. But even though designing that trial, they could not establish death reduced in emperor reduced. So heart failure without evidence of ASCVD means you don't have angioplasty, bypass or acute MI done in past, I would prefer dapagliflozin. Third reason is the cost. Now the cost of DAPA has come down, your patient is already on top of your head, કે સાહેબ આરની બી ચાલે છે, આના 200 રૂપિયા, આના 300 રૂપિયા, આના 200 રૂપિયા, આની 100 રૂપિયા. Of course, Jardiance is still not off patent, but I feel કે the reason why I would stick to post-bypass patients to go with Jardiance is, or the empagliflozin is, because if he can spend 2 lakh rupees with me for angioplasty, he will surely spend 100 rupees for the tablet that will prevent death. And DAPA, of course, the dose has been studied 5 and 10 in heart failure, not in diabetes, in secondary prevention, in Declare-TIMI. The dose has to be 10 milligram. Unless you have some problem like heart failure where you can step it down, but starting dose should not be 5. આપણા દેશમાં શું છે? 2.5 મિલીગ્રામની બી મેટોપ્રોલોલ કાર્બિડિલોલ 3.125 આખી જિંદગી કાશે. ભલે સ્ટડી ડોઝ 25 બીડી છે, જેનો કોઈ એવિડન્સ નથી. એ ભારતમાંથી જ મળશે એવિડન્સ કે 3.25 મિલીગ્રામમાં કાર્બિડિલોલથી શું થાય છે. એન્ડ સ્ટેટિન, એટોરવાસ્ટેટિન 5 મિલીગ્રામ બી આપણા દેશમાં જ બને છે, આપણા દેશમાં જ વેચાય છે અને આપણા દેશમાં જ ખવાય છે, બાકી એવિડન્સ એનો બી ક્યાંય નથી. આવું તમને બધી થેરાપીમાં મળશે, એટલે આઈ વિલ નોટ બી સરપ્રાઇઝ કે કોઈ 2.5 મિલીગ્રામ ડાપા લઈને બી આવી જાય. So I don't stick to the lower dosages because higher does not have any higher side effects, you know. You go 10 with DAPA, yes with EMPA 25 or 10, both have been shown to reduce event rates in secondary prevention. એટલે 10 મિલીગ્રામની 25 મિલીગ્રામના પાછું એનો બી ઇન્ડિયન જુગાડ છે, જે આપને ખ્યાલ હશે કે 25 નથી થતી તો અડધી કરવાની, એટલે 12.5 થાય એટલે કિંમત અડધી થઈ જાય. એટલે આપણે બી આ ફાર્માવાળાને શીખવાડ્યું છે, હવે એ બી જઈને બધાને એ રીતે જ શીખવાડતો હશે કે ભાઈ અડધી આપવાની એટલે કિંમત સસ્તી થઈ જાય, પેલી 70 રૂપિયાની, પેલી 75 રૂપિયાની, તો 5 રૂપિયાના ફરકમાં તમે અડધી કરો એટલે 37 થઈ જાય, એટલે પેલાને સસ્તી પડે. સો દેટ ઇઝ ધી, સો 10 milligrams works. I cannot say 12.5 આપો, they're not studied. 10 or 25 for empagliflozin, but 10 milligrams preferably for DAPA. You can go with 5. There is no evidence of stepping up and making it 20. So don't step it up. I don't go to 20. I can combine it with sitagliptin, linagliptin, metformin. So cardiologist તરીકે આપણા બધાને તમને બી એ જ કહું છું, ડાયાબિટોલોજીસ્ટથી બહુ બીવાની જરૂર નથી, as long as તમે હાઇપોગ્લાયસેમિક એજન્ટ ના આપતા હો. હું એમને એમ જ કહેતો હોઉં છું કે તમને જેમ એમઆઈથી બીક લાગે છે, અમને હાઇપોગ્લાયસેમિયાથી બીક લાગે છે. એટલે થોડા સલ્ફોનાઇલ યુરિયાથી દૂર રહેવું, થોડા ઇન્સ્યુલિનથી દૂર રહેવું, અને એના પહેલાની બધી થેરાપીઓ વાપરી કાઢવાની. એમાં કોઈ બહુ મોટો વાંધો છે જ નહીં. As long as you don't trigger hypoglycemia, you don't create acute events. So that's the problem in Accord, as I say. But મને ખબર છે કે આ બધાએ જેટલી સલ્ફોનાઇલ યુરિયા લખી છે એટલી SGLT2 નથી લખી. એટલે પછી SGLT2 તો બિલકુલ પીવાની જરૂર નથી. તો અમે સૌથી વધારે પહેલા ન્યુક્લિયર બોમ્બ જ ફોડ્યા છે અને અત્યાર સુધી ખમી ગયા છો. તો I don't think SGLT2 should be a problem. Yes, I would stick to 10 because those 10 and 5 have been studied. I would stick to 10 because the most average dosing used was 10 milligrams. Average, most of the patients.
Maybe we'll take the last question.
Sorry? Very good question. It does not cause hypoglycemia. Yeah, very good question. So, does it cause hypoglycemia per se? No. Why? Because of the renal threshold. If you remember Clemenstel-Wilson kidney in nephrology, physiology, Guyton's textbook, kidney નું એક threshold છે. Sugar આટલું હશે તો જ યુરિનમાં જશે. જ્યારે diabetic kidney થશે thresholdના લોચા થઈ જતા હોય છે. Physiologically speaking, between 70 to 90, depending on how healthy, young, BMI, functional status of kidney, other comorbidities, based on that, at that cutoff, kidney will shut down, throwing more glucose out of the body. As soon as your sugar comes to 90, kidney is not throwing glucose out, your sugar cannot drop below 90, it will stay 90. So that's the reason you will never get severe or even moderate hypoglycemia. All the trials have shown, including DAPA-HF, incidence of hypoglycemia is equal to that of placebo. No risk of hypoglycemia. And that's the reason for a cardiologist to choose SGLT2, metformin, DPP4, especially CV neutral. કોઈ દિવસ એના પર બી subgroup analysis ની ભેગા થવા મોકો મળે તો ચર્ચા કરીશું કે which DPP4 or which GLP-1. And GLP-1, if I give GLP-1, I don't give DPP4. Pioglitazone, if no LV dysfunction, 7.5, data from IRIS in metabolic syndrome, I exhaust everything, then I admit SU. And then only maybe a basal insulin if, of course, the patient is insulopenic. One thing is, if you have acute hospitalization, you think patient is likely to be insulopenic, add a long-acting basal insulin and then give SGLT2. Don't give it in insulopenic patient because only problem may be euglycemic ketosis. We had 4 patients out of 450 prescribed this therapy in acute MI discharge situation, which now data has emerged for MPulse. And all 4, first time I called diabetologist, the rest 3 we manage. 1 day management, unlike DKA. Fluid આપો 2 કલાકમાં patient કે હવે શ્વાસ નથી ચડતો. Another miracle that happens. But in heart failure, it does not happen. It happens only in diabetic acute settings. To the extent of safety, જે therapy COVID severe pneumonia માં tolerate થઈ જાય, એ બધે tolerate થઈ જાય. DARE 19 નામનું એક study થયું, where they studied dapagliflozin in COVID-19 admitted pneumonia patients. Did it worsen outcome? No. No decay, no euglycemic ketosis. It did not cause, there was a trend toward reduced hospitalization duration. It did not reduce mortality. So overall it was a neutral trial, but there was a trend towards benefit. But at least safety નક્કી થઈ ગઈ કે ન્યુમોનિયા કોવિડ ન્યુમોનિયા સાથે દાખલ થયેલા પેશન્ટને ડાપાગ્લિફ્લોઝિન ચાલુ કરો તો આટલી સિવિયર સ્ટેટમાં બી આ દવા ટોલરેટ થાય છે તો આપણા ઓપીડીમાં તો 100% થાય.
I think that will be the last question and wonderful post-lunch session. Everybody is awake, everybody is interactive. Maybe that is your energy.
I think they added dapagliflozin in the lunch.
Thank you very much. Now I request Dr. Sagar Solanki to hand over a memento to Dr. Kamal Sharma sir. And now I request Dr. Tanvi to hand over a memento to Dr. Avinash Wankhede. And I also request Dr. Tanvi to hand over a memento to Dr. Sagar. Now, next, thank you, Dr. Tanvi. Now the next is, we have Padma Shri Professor Dr. Vijay Raghavan sir session, and for that matter, I would like to invite Dr. Rajesh Rajan, Dr. Sagar Solanki, President of IACC, Dr. Vismay Parmar, President, IACC Gujarat Chapter, Dr. Avinash Wankhede, Secretary, IACC Gujarat Chapter. Now I request Dr. Bhaskar sir to please come on the stage. Dr. Bhaskar sir, please. First, I would like to felicitate the Bhaskar sir. It is a switch over करो. Slides चाहिए मेरे को. Yeah. As already declared, it is a Padma Shri Professor Dr. V. Raghavan sir's oration session, and Dr. Padma Shri Professor Shri V. Raghavan sir is a cardiologist from India, credited with the established first 2D echo laboratory in India. He did his early schooling in Trivandrum Model School and graduated in medicine from Trivandrum Medical College in 1964 and passed MD in General Medicine in 1969. He continued his study at a Christian Medical College, Vellore, obtained his doctorate in cardiology DM in 1973 before my birth, and started his career there as an associate professor. He moved back to Trivandrum Medical College in 1976 and continued his research on endomyocardial fibrosis and a variety of heart disease found common in Kerala, in association with Postgraduate Medical School and Brompton Hospital, London. He is the Vice Chairman and Founder Director of the Kerala Institute of Medical Sciences and the President of the Society for Continuing Medical Education and Research, Kerala. He was honored by the Government of India in 2009 for his services in the field of medical services and awarded by the Padma Shri. And for his session, we have a Dr. Bhaskar sir. Dr. Bhaskar sir is a practicing cardiologist in the Mumbai. He is a director and consultant interventional cardiologist at Jupiter Hospital, Thane, actively involved in more than 25,000 cardiac catheterization laboratory procedure during the last 20 years. Director, founder, member, consultant and interventional cardiologist at Asian Heart Institute. Worked as a program in charge of the IGNU and DNB course at Asian Heart Institute and working in the same authority currently at Jupiter Hospital. He has many awards, mainly chaired and delivered multiple presentations at national and international symposium at the various conferences, and winners of the B.R. Ramble Trophy, LTMG. In between, I request Dr. Manoj Grela to please come on the stage. Dr. Manoj Grela, please. Now I request Dr. President of IACCC to honor sir with the cap. Now I request Dr. Rajesh Rajan and Dr. Manoj Grela to honor sir with the shawl, please. Yeah, please, Dr. Manoj, please. Now I request President of Gujarat IACCC and Secretary of Gujarat IACCC to felicitate sir with the certificate. Avinash, please. And I myself facilitate sir with the memento. Thank you very much, sir. We are very much honored with your presence. Sir, yeah, yes, please. Sir, please. Sir, please, it's your Sarkar.
Good afternoon, friends. At the onset, there is application of Bayesian principles to the evaluation of coronary artery disease in modern era. Fine. Now at the onset, I will pose a simple question to everyone. How many of us are doing routine treadmill test for a young patient, say somewhere around age of 30, 35, as a part of executive health checkup? So fairly large number. We'll try and go through this article presentation, and maybe at the end of the talk, we'll again pose the same question and see where we are. Now the question which I posed was, how many of us do routine treadmill test for evaluation of coronary artery disease in a young patient, say maybe 30, 35, etc. And the answer was, quite a lot of us do it. There was a paper which was presented in Indian Heart Journal a couple of years back, trying to argue against this practice of doing routine treadmill test as a part of health checkup, which we all know is a booming industry across the country and maybe even across the world. The question is, when we are talking of doing any specific test, whether it is treadmill test or maybe any other diagnostic test for coronary artery disease, we need to evaluate the utility of the test. And what was found was that whenever you do a test, say for example, stress test or treadmill test, we know of what we say specificity and sensitivity of the test. What you mean by sensitivity is you pick up from a given patient, a subset of patients, people who are abnormal. That means the ability of a test to pick up abnormal from a group is the sensitivity. For example, there are 100 people, and of that, 100 proven patients of, say, coronary artery disease. And if you do a test, and it picks up, say, 75% of the patients, the test is abnormal, then you say that the sensitivity of the test is 75%. Meaning thereby, 25% of the patient who still has a coronary artery disease will not be picked up. That is what you mean by sensitivity. Then there is something known as specificity. Specificity is essentially trying to find out normals. That means if you have 100 normal patients and you do the stress test, number of patients where the stress test will be normal is going to be the specificity. That means if you have 100 normals and you say that 90% of the patient, it will be normal, then you say 90% is the specificity of the test. Otherwise, 10% of the patient in this so-called normal will have an abnormal stress test. Clear so far? Specificity, sensitivity. Now, by and large, we all, as a clinician, are used to it. Test is very specific, very sensitive. It's a good test, can be utilized everywhere. But is it really so? The answer to that is what was the Bayesian theorem or Bayesian principle, which tells us that besides specificity and sensitivity, prevalence of the disease is extremely important to understand the overall utility of the test. Now just take an example. I say that I take 30-year-old, 1,000 people working in a company where you do a treadmill test. Now, what is the prevalence of this disease? In this subset of patients who are 30, 32, 28, somewhere in that range, average 30 we say, average prevalence is 2 to 3%. That means out of 100 people, maybe to upper limit 5% would have coronary artery disease. Is that clear so far? Now suppose when I say, I just tell, for example, I would say 5% is the prevalence of coronary artery disease in the subset. That now I'm taking, I've taken 1,000 patients or 1,000 people for the test. Out of this, what I mean when I say 5% prevalence, out of 100, 5 would be abnormal, out of 1,000, 50 would be coronary artery disease. So now in this subset, 50 are coronary artery disease patient and 950 are normal. And you are doing treadmill test on every one of them. Now we know what is the sensitivity and specificity of this test. For practical purpose, real figures are 68 and 77. We would say 70 and 80 so that calculation becomes a little easy. 70% is the sensitivity and 80% is the specificity. Now, 50 patients are abnormal, 50 people are abnormal, and the sensitivity of the test is 70. That means 35 of those would have an abnormal treadmill test, and they are known as true positive. That means they have a disease and they have been labeled abnormal on the test. Another 15 patients of these 50 who are having abnormal disease, have a disease, would have a normal treadmill test. So they are false negative. That means they are negative, but they are false. They really have a disease, but they are labeled as false negative. This much so far clear? Out of 1,000, 50 abnormal, 35 true positive, 15 false negative. Now go to the other subset. 950 people are normal. 950 are normal. The specificity of the test is 80%. That means out of those 950, 80% of the patient, which would come to say 970, around 740 people roughly, would have a normal stress test. Other way around, how many normal would be there? Out of 950, approximately 200 at least. That is what is the figure. So now you have, now those 750 are true negative. They have no disease and they will have normal. Opposed to that, now 200 are false positive. So far clear? 1,000, 50 abnormal, 35 true positive, 15 false negative, 950 normal, 750 true negative, 200 false positive. That means in the 1,000 patients which we have done the test, how many overall positive? 235. Of which, how much are genuinely positive? 35. That means you come to a new concept, what is known as predictive positive value. That means prediction. That means if you have done a test in this subset of patients, more are false positive, small number is true positive, and the accuracy of the test, that means out of 235 positive, only 35 are genuinely positive, which is 15%, and 85% are false positive. Now, suppose if this person was coming and ask you, I am asymptomatic, what are the chances of disease? Even if you just do a King's square, what will be the answer? 50-50. You will be more correct there or with stress test? With stress test, your accuracy of predicting disease is only 15%. 85% are wrongly diagnosed of having a coronary artery disease when we don't have a coronary artery disease. And this is much lesser than even King's square or just telling 50-50 rule. Thereby, what it means is we are coming to the message that when the prevalence of the disease is extremely low, false positive is very high, true positives are very low, and the accuracy of the test is in the range of 10 to 15%, or other way around, most of the positives are really negative. And thereby, you subject them to unnecessary numbers of tests, because now that you have got positive, you will go and do the next test, maybe the third test, and so on and so forth. All right, fine. So anyway, just coming to that, we'll just go on the slides in a minute. So first important thing what you have to remember is that it is not only the specificity and sensitivity of the test which is important, but prevalence of the disease is extremely important. If you do the test in a patient who has a low prevalence rate, the positive value of the test is extremely low. Normally it will come between 10 and 15% and 20%, whereas majority of the positives are genuinely negative. And therefore, if you see a common day-to-day example, every single day I get a patient who said that I had undergone a stress test, it is positive, the family is panicky, the whole family comes, very young, 30, 35, asymptomatic, routine health checkup done, positive test, everyone is scared, at a young age has a coronary artery disease. the first thing which you will do as a clinician, you will tell him that by and large this is false positive. Don't get worried, don't get panicky, and your things may further go ahead further. It is positive, genuine positivity is only 7%, false positivity is 92%.
So that is how you calculate. If you don't want to calculate this way, you can apply this formula. We are not going into the depths of this mathematical formula. But with this formula, instead of putting all these figures, you can, on Bayes' theorem, you can calculate the same thing. And this is what it is. So basically, similarly, for example, this is another test. Like for example, you are doing a drug test. Consider a drug test, 99% of the time it is okay, 99% sensitive, 99% specific, and 0.5%, that is 0.5% of the people you use a drug. So this is for people who are running in a marathon. They say that you are testing for drug level in the blood. The test is 99% accurate, 99% specific, and still, if someone is positive, what are the chances that it genuinely has is only 33%. Meaning thereby, even with a test which is 99% specific and 99% sensitive, if the prevalence of disease is low, the final predictive accuracy is extremely low. That is what is the message, and therefore, so this is what we already discussed, sensitivity, specificity, positive predictive value, and there is something known as negative predictive value. A test which has a low prevalence when you do in it, the negative thing has very big value. In that example of 1,000 patients where I told about stress test, 950 people, I told you genuine was 750 and only one abnormal from other side. That means the negative predictive value in a low prevalence is very good. That means when you do a test like stress test in a patient with low prevalence, positive thing has minimal value or no value, more confusion. But if it is negative in that subset, it by and large means it is definitely negative. That means prevalence, low prevalence, and any test, positive predictive value, very little value, negative predictive value, great value. This is the first rule which I am telling you. If a disease is uncommon in a population, low prevalence in this case, 5% prevalence, any positive are more likely to be false positive. Vice versa will come to disease is highly prevalent in a population, say 95%. Suppose on a clinical history, you say that patient has angina on effort, etc., very classical angina. He says, when I walk, I get angina. When I stop, the pain disappears. Then clinically only you are close to 90% accurate that you have. When you do this test, the accuracy from 90 will go to 93, 94. So again, on extremes, when you are clear-cut positive, the test doesn't have value. When you are clear-cut negative, it doesn't have value. It is in that intermediate group where there is a doubtful situation, where there is some history of chest pain, etc., which looks like classical or atypical angina, the test has a value. So these three rules are most important. Number one, this is uncommon. Positive are more likely to false positive. But this is highly prevalent. And in that patient, if you get a negative test, it is more likely to be positive. Meaning thereby, if you say that patient has classical angina, and if you do a stress test and if it is negative, by and large it is false negative. And pursue with your answer. So positive value of screening, this is what we have already told you. Now, how to calculate? So it's so easy to calculate. Sensitivity of the total number, which are abnormal, is sensitivity. Of the total number, what is truly negative as specificity. And if you want to find out predictive value, what you find out? True positive upon false positive, the total positive. Suppose in the same example which I gave you, I told you 35 were positive here, 200 there,
235 is total. So 35 upon 235 is predictive, positive predictive value, and negative predictive value accordingly.
So primarily, having said that, positive predictive value, proportion of positive results that are true positive, this is all, I'll forget the mathematics because we have taken a lot of time. Now this is the most important again message. Predictive value is determined by the sensitivity and specificity of a test. Increased sensitivity means increased negative predictive value. That is what I told you. And increased specificity, increased positive predictive value. Now, the question which comes up is, suppose you want to do a stress test at age of 35. Does it mean that you will never do a stress test at age of 30, 35? The answer is not that. You have to increase the prevalence. That means suppose now in that 35 age group, he is getting some chest pain, which is sometime on exertion. Then the prevalence from 1% will go to 35, 40%. And the overall accuracy of the test will improve. That means in younger patient, when you want to do a stress test or for that matter any other test which is with low prevalence, try to increase the prevalence by picking up the patient and selecting the patient rather than doing routinely as a part of health checkup. So that is what it is. Prevalence is low. To increase the PP, we target screening to the highest risk of developing the disease. For example, if you are screening for CA breast, take females above 50 and above, and not in 30, 35. Or you are doing a stress test, you take people who says he has got exertional chest pain or he has multiple risk factors or positive family history. Then yes, it makes sense. But just as a part of routine, it doesn't make sense. So this is what we have. And so this is another important thing. When we are talking of sensitivity and specificity, focus on the disease is important. Important to epidemiologist and clinician. When positive and negative predictive value, focus on the test and important to the patient. For patient, predictive accuracy is very important. Now, besides this, there is another entity, what is known as, this is again same thing. I'm giving multiple examples probably, but one example which I have clearly shown you. Now another example which you need to understand is other way around, where the patient is having very high value, high prevalence, like classical angina, classical chest pain, proven coronary artery disease and all that. There these tests will add very minimal value. Accuracy from 90 will become 93. That means the additional percentage value is only 4%. Rather than doing all those things, it is best to go to another better test rather than this, and definitive test. So this is with prevalence of 10%, 1% I told you, 3%, with prevalence of 10%, the overall accuracy is 50-50. That means once your prevalence is above 10%, 20, 30, 40, 50, that is a subset where all these tests adds maximum value. They are known as patient with intermediate risk. Low risk, predictive value, high risk, very minimal benefit. Intermediate risk, where the risk is baseline 30, after doing the test, the post-test probability will go to 70, 80. It will improve your probability very high. That means all these tests, whichever it is, whether it is stress test, stress echo, thallium scan, CT scan, MRI, everything should be done in a patient with specific clear indication in low prevalence as a part of routine health check, never to be done with intermediate risk. That means where patient is having some pain, suspicious of angina, that sort of a step, it is very useful test. High prevalence, the value is very little. That is what is the overall message. Now this is again which you already enumerated, so I'm just, we have figures we have gone through, so we are not really going into it. Another important thing is what is also, so this is what is the most important chart. Pre-test probability, which means disease prevalence, for a diagnostic test which is a known sensitivity and specificity, decides the post-test probability. In this given example, patient, routine health checkup 30%, 1% T-test prevalence, sensitivity of 80-90%, post-test probability is only 11%.
Other way around, pre-test probability 90% with classical angina, good sensitivity specificity, the post-test probability is 94%, increased by 4% only. But intermediate risk patient with pre-test probability of 30-40%, with the same test, the post-test probability will go to 80-90%. That is the phase where this test adds maximum value in a given patient.
And there is something known as likelihood ratio. Likelihood ratio is definition-wise specificity and sensitivity taken into one formula, where if you don't know the pre-test probability, you can calculate the pre-test probability by specificity and sensitivity ratio. That formula I'll just show you. But essentially, likelihood ratio, that means what are the chances of the test being there. You take into consideration true positive and false positive and come to that conclusion. And that is another thing, if you go back to the literature, every single test, the likelihood ratios have been given. I'll just show you the chart. Now this is what it is. Like for example, if you see this chart on the red, the pre-test probability was 10%, and on the right you see the post-test probability has gone to 80%. This is an intermediate risk group patient. And this is what are various other tests, like for example, we want to diagnose cholecystitis with abdominal ultrasound, the likelihood ratio is 23. And this is anything where the likelihood ratio, these are pre-given, is 1, that means the test will not add to the value. As you go away from 1, either on positive or negative side, it add value. And this is what, for example, for us, acute pulmonary embolism, pulmonary CT angiogram, likelihood ratio is 29 points, an excellent test, or vice versa. And that is known as likelihood ratio. Now, so this is the final formula which is important. The entire message of the lecture is pre-test probability or disease prevalence with the patient and the test which is known sensitivity and specificity. The likelihood ratio and pre-test probability will decide the utility of the test, or what is known as positive predictive value and negative predictive value, or what is also known as post-test probability. Meaning thereby, every single test which you do, whether it is ultrasound, whether it's creatinine value, whether it's anything, you should know what is the pre-test probability and what is the likelihood ratio. And if you know this, and if the prevalence of the disease is low, and if you find any abnormal test, please say that it is mostly false positive. And vice versa, in a patient where the likelihood of disease is more, it is going to be adding to the value, and especially it adds value in a patient with intermediate risk. I repeat therefore that what we started with our first question, where we asked, do we do routine health checkup in every single patient of 30-35? It's a booming industry. Every single place you see it's going on. But if you go by science, if you go by what is happening, you are probably creating more cardiac neurotics by that. Much more number of patients undergo a lot more investigations, inconvenience, mental stress, mental worry, anxiety, etc., etc. And therefore, if I were to sum up, I would just sum up by telling that every single test, please look at pre-test probability or prevalence. If the prevalence is low and you still do the test, then only negative predictive value is important. If the prevalence is intermediate, excellent to do the test in that patient. And if the prevalence is other way around, very high, it adds very little value, maybe go to another better specific test. That is what is the overall crux of this Bayesian hypothesis, which tells us that nowadays we are doing too many investigations which has probably no value. On the contrary, negative for the patient, cost, psychological, physical, every way they are going to a wrong message and wrong pathway. And for pre-test probability again, what is important is, for example, we must have heard of what is known as, this is a very classical
thing which we have always seen, Diamond Forrester. These are what are known as, for example, a patient has non-anginal pain, between age of 30 and 39, the prevalence is 4%, between 60 and 69, prevalence is 27%. These charts are all available, and we all know elder patient, the prevalence is high, younger patient, the prevalence is low. And similarly, associated with risk factor also, there is a different chart. I'll just show you that. So this is what it is in summary. For example, you look at the various tests, the population, the sensitivity, specificity, but you look at the predictive, overall specificity, predictive property variables, exercise cardiogram is 41% only. Negative is more, if you see on the top. Therefore, I won't like to go through this chart in detail, but the message has been very crystal clear, very simple message. Look at prevalence of the disease before doing any test. And if you are still doing with a low prevalence, only look at the negative predictive value and don't look at the positive predictive value. And these are like exercise, ECG testing, intermediate sensitivity, specificity, limited by exercise capacity. I think we'll forget it. I think I'm already probably crossing the time. So I'll probably stop over here with a very clear message that we should be very, very clear about where to do the test and how to interpret the test. Thank you.
Thank you very much, Dr. Bhaskar sir. As it is an oration session, there is no question answer. Now I request respected Dr. Sekhar sir to felicitate Dr. Bhaskar sir with medallion. Now our next talk is
Thank you.
Connect karo. For our next talk speaker is Dr. Sekhar Ambadekar sir. He will brief us on heart failure with preserved ejection fraction. Dr. Sekhar Ambadekar sir is a senior interventional cardiologist with a special interest in preventive cardiology. Dr. Ambadekar sir brings to SL Raheja Hospital more than 35 years of experience in interventional cardiology. Dr. Ambadekar sir has extensive experience in teaching, having worked as a lecturer in cardiology in Grand Medical College and JJ Group of Hospital, Mumbai, where he has mentioned many graduates and postgraduates. Dr. Sekhar sir, please. And for his session, I would like to invite Dr. Vismay Parmar and Dr. Sagar Solanki to chair the session.
Yeah, good evening, friends.
And I also request Dr. Aswin and Dr. Venkatesh Prabhu to chair the session. Dr. Aswin, please. Dr. Prabhu Venkatesh, please.
Good evening, friends. Well, in the conference today, since morning there were a lot of performances with a lot of power, isn't it? And now we have come at the end of the day, where many spectators are already going. And at such time, last batsman has come to bat. Now, his job is, before interesting IPL starts, he has to have his performance. And last man, we don't really expect too much, isn't it? And we expect that his inning doesn't last for a long time. So if it is extending too much, you can pull him out, right? Friends, let us start with a case, genuine case. This is real life case
This was a 71-year-old woman, okay. And she was a hypertensive. Like many of our patients have been on combination of amlodipine atenolol, she was taking this medicine for hypertension. She was a diabetic on oral drugs, some diabetic nephropathy, creatinine of 1.7. And she had exertional dyspnea. And she was giving history suggestive of PND. Okay, she says tiredness all the time. There was no chest pain, right? Now this patient, of course, was examined, found to be comfortable at rest, not breathless. Pulse was okay. Some evidence of peripheral vascular disease. Blood pressure was not really totally well controlled, 160/90. GVP, somebody said raised, somebody said not raised. There was some mild edema. People were wondering whether it was because of amlodipine. There was no gallop, no murmurs. Lungs were clear. And abdominal, the liver was not palpable. So the first person who saw said breathlessness on exertion, maybe PND, some edema, GVP may be raised. So he diagnosed query CCF in a diabetic hypertensive patient with some peripheral vascular disease. This was the patient's ECG, which was slow progression of R wave V1 to V3, probably due to left ventricular hypertrophy. As you can see, STD changes also appear to be left ventricular hypertrophy. Heart rates on the slower side, patient on atenolol. Chest X-ray was done. It didn't show any cardiomegaly. Okay. Echocardiography was done. It was reported as left ventricular hypertrophy, which is symmetric. Okay. And LV cavity dimensions were normal. No RWMAs, EF55. So hypertensive heart disease, valves are normal. Okay. Okay. And normal cardiac function. Right. Now patient was referred to chest physician because breathlessness, can it be due to lung disease? He said there is no evidence of COPD or asthma. He did PFT, pulmonary function test. That patient is not very cooperative. Maybe this test, whatever has come, is normal for her age and maybe for her general condition. Okay, and patient was reassured. Family was told there is nothing wrong with the heart. Go home. In 3 days, the patient comes back with the same symptoms or worse. ECG and screening echo were done, they were still okay. Patient was referred to psychiatrist. घर में सास बहू के झगड़े होते हैं, उसको टेंशन में कुछ ऐसे सिम्टम होता है. This happens in old women. Friends, this was real life case. This was exactly 4 years and a few months earlier. I can tell you. I remember the name of the patient. The patient's face is in front of my eyes right now also. Okay. Now, since she was diagnosed initially as suspected cardiac failure, because symptoms appeared like that, okay, patient worsening, so can it still be cardiac failure? Normal ejection fraction. Was it cardiac failure? Never. And let me quote here one of my teachers, Dr. Ashok Tulpade, who was in Grand Medical College, JJ Hospital Cardiology. Dr. Bhaskar Shah will remember him. One of his famous statements was, there is never ever any never in medicine. You can not say something is never. कोई मेल को बच्चा हो सकता है क्या? मैंने बोला never. And that time, let me tell you, around that time, there was a case report in newspapers that a 16-year-old boy was there, and inside his abdomen, a baby was growing. Actually, it was a teratoma, but that came in the newspaper. So, friends, now I don't want to go into details of this. Dr. Kamal Sharma has also told us what is definition of cardiac failure, what are the stages of cardiac failure. But one very important thing that we now understand, and in 2022 it has become very common, that heart failure classification also by left ventricular ejection fraction, and something which is below 40% is left ventricular cardiac heart failure with reduced ejection fraction, and something which is more than 50% is heart failure with preserved ejection fraction, isn't it? And the range in between 40 and 50, earlier it was considered as mid-range heart failure, if you remember, mid-range ejection fraction. Now it is called as mildly reduced ejection fraction. And somebody who had heart failure with reduced ejection fraction below 40, but now maybe with your treatment and whatever you did, it has now increased by at least 10%. Suppose somebody who was 35 has now become 45, and certainly it has come above 40, is considered as heart failure with improved ejection fraction. Improved. Now it is not just called mid-range or mildly reduced, it is called as improved because earlier it was low. So that term tells you that earlier it was low because of your therapy it has improved. Okay. Now friends, this heart failure with preserved ejection fraction which we are talking, it's a clinical syndrome of heart failure. Please remember your clinical is very, very important. So even in the days of all computerization and so many gadgets at your service, clinical is number one. So clinically you suspected heart failure, don't disregard your diagnosis. Okay. But with that, whatever is the ejection fraction, there are common features in this type of heart failure that LV filling dynamics are changed, LV diastolic pressure is raised, there is LV systolic and diastolic dysfunction. Please remember I said systolic and diastolic. I am not only saying diastolic. Neurohormonal activation comes into play. You know, the natriuretic peptides, BNP and anti-pro-BNP we talk of. And there is impaired exercise tolerance. Because as you know, in cardiac failure, we always say there is impaired exercise tolerance. Right. Now, heart failure with preserved ejection fraction, there are various terms. Some people call it as heart failure with normal ejection fraction. Now, what is normal exactly? Because if you see various studies, some say 60% is normal, some 50, some 55. I have read at least a few studies where 45 was taken as normal. So what do we mean by normal? So that was not one. Some people say, why do you say heart failure with normal ejection fraction? Why don't you just say normal systolic function? Because this is not true in all the patients with heart failure with preserved ejection fraction. There is systolic dysfunction. Okay, though ejection fraction is normal. And therefore, friends, the best term which is ultimately is agreed upon is heart failure with preserved ejection fraction. Now you will say that if ejection fraction is normal, how can still there be systolic dysfunction? Friends, we know that heart left ventricle, for example, doesn't have only fibers running in one direction. There are some longitudinal fibers, there are some radial fibers, the mid-wall fibers are different than the base and the apex. So in fact, to be shown in another diagram, see, there is left ventricle contracts lengthwise, okay, and there is circumference also big shortens. At the same time, you know, like if you have to dry a wet cloth, what do? You squeeze it, right? Like this. One arm, one hand moves in this direction, the other hand moves like that direction. So left ventricle also is doing that. If at the base it is contracting clockwise, at the apex it is contracting counterclockwise. So what is seen is, in most of these patients with heart failure with preserved ejection fraction, longitudinal contraction is affected, but the mid-range, mid-cavity fibers are still doing very well. Okay? And the twist is also going on well. So these two compensate for that contraction decrease in the lengthwise. And why is that important is, therefore, in many of these patients, if you do what we call as GLS, global longitudinal strain, where we are looking at the lengthwise contraction of the left ventricular muscle, you will find that it is reduced. Actually, Dr. Avinash Wankhede's talk was supposed to be there much earlier in the morning, and I expected that it was certainly before mine, but unfortunately it has not taken place. So he'll tell you more about this, and he'll tell you why you should not look only at the ejection fraction but ask for GLS, isn't it? That is your topic. So I'll not go into too much of his topic. Let him give us complete talk. But please remember, friends, this is important, and this paper had shown us in 2017 that left ventricular ejection fraction, even if it is normal, longitudinal strain becomes very, very important in this heart failure preserved ejection fraction. So he that papers really clearly said that in these patients, GLS is very, very important. Okay. Now, clinically, friends, these patients of heart failure with preserved ejection fraction, there are many comorbid conditions. Generally happens at the older age. It happens women more than men. Okay, hypertension is very common in all these patients. 80 to 90% patients of these are hypertensive. Obesity is common. Diabetes is 20 to 30%. Atrial fibrillation, sometime either before it was already there, it was at presentation, maybe there. So it is very common. Coronary artery disease is not as common as in heart failure with reduced ejection fraction, because in reduced ejection fraction, we know some part of the muscle is actually lost. So ejection fraction may come down. Similarly, renal disease, sleep apnea, pulmonary hypertension are common. So this is actually comparison between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. The same points, if you compare, then okay. You'll say that in heart failure with reduced ejection fraction also many of these factors can be seen, but they are more common in heart failure with preserved ejection fraction. Okay. Heart failure with preserved ejection fraction, you see, ejection fraction is good, so outcome should be good. No, friends, 5-year mortality is still 60%. Okay. Increased morbidity, that is, after diagnosis, 50% of them get hospitalized. So, if not treated, this is natural history. And poor quality of life, their exercise tolerance is low. So, morbidity and mortality is not low in them. Okay, perhaps it is not as bad as in heart failure with reduced ejection fraction. Okay, what is common in them is increased left ventricular stiffness, distensibility. Heart is supposed to not only contract but relax and receive blood. So that distensibility is reduced, LV compliance is reduced. For the same volume of left ventricle, now diastolic pressure is higher in these patients. Left atrial pressure is higher also. Okay, right. So what will be seen then in the echo? We know, we have all been doing echoes. Most of them have normal volumes, left ventricular. So it is not dilated left ventricle. Okay, because of preserved ejection fraction, it is emptying itself well, at least at rest. Only 5% has got some mild enlargement. LV mass is increased because left ventricular hypertrophy is common. It is what we call as concentric remodeling and diastolic dysfunction. Now here comes that diastolic dysfunction. All of you again have been doing echocardiograms. I don't have to tell you what is diastolic dysfunction. We grade them as grade 1, 2, 3, 4. Okay. Grade 1 is impaired relaxation pattern, we say, where, like we of course do this by mitral valve flow Doppler and tissue Doppler of mitral annulus, isn't it? And by that we know E wave of mitral diastolic flow and its ratio to mitral annular movement E prime. And by that we grade diastolic dysfunction into grade 1, 2, 3, 4. Okay. And by that, as we know, as the diastolic dysfunction worsens, it will go to upper and upper grade. Grade 1 diastolic dysfunction is very common in all elderly individuals. After the age of 40, 45, 50, grade 1 diastolic dysfunction is normal. Please remember, all these people with grade 1 diastolic dysfunction, we don't call them as heart failure with preserved ejection fraction. Every diastolic dysfunction is not heart failure. Heart failure is again a clinical syndrome. So clinically it has to be heart failure. And then you are seeing that there is diastolic dysfunction with normal preserved ejection fraction. Then you are going to term it as heart failure, not just by echo finding of diastolic dysfunction. As it worsens, diastolic dysfunction worsens, LV feeling pressure increases, then it goes to grade 2, grade 3, grade 4. Okay, right. And for this, all of you who have been doing echoes, I would appeal to you that this particular picture you should have in your echo lab. You should certainly have this. For your quick diagnosis, how to say that left ventricular diastolic pressure is increased or not. Okay. So when you are looking at that, you look at ratio of mitral E and A. Okay. Normally, in all normals, E is bigger than A. That is all totally normal. In all young normal individuals, you see that. Grade 1 is where A becomes more than E. Okay? If it is E by A less than 0.8, the ratio is less than 0.8, okay, it is what we call as grade 1 diastolic dysfunction. E by A above 0.8 but below 2, that means now E is more than A, or just little smaller than A, or now more than A. Now in this, whether it is raised LVEDP or not, that you have to see. If it is certainly more than 2, take it as it is increased already. Okay? Then for that you don't have to do anything more. Right? Now if it is in between, then what you do is look at E by E prime ratio, and that you, whenever you look at that, you please look at average. What I mean by mitral annulus has got medial end and lateral end. You please measure by both and take out average. If it is below 14, okay, or more than 14. If it is above 14, LA volume, LA is also dilated, and if there is tricuspid regurgitation due to pulmonary hypertension, of course, and if the tricuspid regurgitation jet is at a speed of more than 2.8 meters per second, these 3 criteria you should use. If you have got 2 or 3 criteria negative, it is not increased. LV filling pressure is not increased. If 2 or 3 are positive, it is increased. Okay? If it is in between, actually you could not get all 3. There was no TR only. So there were only 2 available. And then only out of that 1 was positive, the other was not. Then what to do? Then what is said is, you do left atrial reservoir strain. That means like you use strain imaging for ventricle, do it for atrium. And look at that. If it is less than 18, it is elevated filling pressure. If it is more than 18, it is not. Now this regarding LA reservoir strain, etc. Again, I will not go into details because tomorrow Dr. Vijay Raghavan's talk is on that, LA quantification. So please listen to that, how to calculate this, etc., etc. He will tell us and how it is important. So this is very important. So this happens very quickly. When you do echo, you have looked at E by E prime ratio. Okay, if it is certainly more than 2, okay, you know it is raised. So you can immediately say diastolic dysfunction with raised LVEDP. If it is certainly more than less than 0.8, you know that it is not raised. In between, you use 3 criteria. We always measure LA, and please make it a practice not to only measure the LA diameter, but LA volume, and that you have to standardize it to the body surface area. So that means when the patient enters, before he comes on your echo table, your staff has to take height and weight. If you put it into the machine automatically gives you body surface area. You don't have to really calculate. Okay, and all your measurements also are indexed to then body surface area. You don't really have to spend too much of time for that. Okay, right. So friends, in short, this is what you do for LV diastolic dysfunction. These are the echo findings. Left ventricular mass index, relative wall thickness more than this, that is increased, LA volume, E by E prime ratio, tricuspid regurgitation, and pulmonary artery pressure. These criteria you use for echo. Okay, and by that, there is a scoring system. You can actually use this score. It is heart failure with preserved ejection fraction, right? HFEPEF. So remember this, HFPEF. There are 2 points in H. If the patient is obese, etc., body surface index is more, that is 1 point. If the patient is hypertensive, again, you know, these are the points which go in favor of heart failure with preserved ejection fraction. So obesity, hypertension, F for fibrillation, that is atrial fibrillation, P pulmonary hypertension, elderly person, and filling pressure that you are doing by echo. As score goes higher and higher, chances of heart failure preserved ejection fraction diagnosis go higher and higher. Along with this, you use biomarkers. BNP, okay, NT-proBNP. And by this, normal you know is below 100 of BNP and NT-proBNP is below 300. These levels go up in heart failure with preserved ejection fraction, but they don't go as high as they go in heart failure with reduced ejection fraction. So friends, clinical plus echo plus these points together, you use for making diagnosis of heart failure with preserved ejection fraction. So this should be your algorithm. Clinically suspecting heart failure and with preserved ejection fraction is more than 50%. Look at diastolic dysfunction. Average E prime, that means medial and lateral only E primes. I'm not talking of ratio here. If it is below 9, oh, okay, then it is, look at whether LV filling pressure is increased, that is E by E prime more than 13, it is certainly that. If it is not, you use the other criteria and so on. So this algorithm you can follow. Okay, you made a diagnosis, right? What about treatment? Because whenever we talk of heart failure with reduced ejection fraction and how to reduce morbidity, mortality, oh, you have got so many things. You have got beta blockers, you have got ACE inhibitors, ARB, RNE, MRA, okay. Then you can use devices, you can use other drugs, you can use ivabradine and combination of hydrolazine as well as isosorbide dinitrate, you can use mitraclip, CRT, ICD. Friends, unfortunately, studies with all these which help heart failure with reduced ejection fraction, multiple studies, they all failed in heart failure with preserved ejection fraction. Studies with digoxin, studies with ARBs, valsartan, candesartan, okay, ACE inhibitor, perindopril, beta blockers, nebivolol, carvedilol, MRA, eplerenone, there was a study called as RAMP-EF and TopCat with spironolactone. They all failed to show any improvement in morbidity, mortality in patients of heart failure with preserved ejection fraction. So this is again comparison. So these drugs which all work very well in heart failure with reduced ejection fraction, in the heart failure with preserved ejection fraction, they don't give you this results at all. Then what to do? This is the question, isn't it? That means, okay, making all these diagnoses by spending so much of time, taking use of this, some test, etc. You diagnose, okay, and do what? Just tell the patient that outcome is very bad? Okay, so therapy, what are we supposed to do? Number one is, please remember the symptoms of breathlessness, whatever PND, etc., they are all because of congestion. Okay, congestion systemic, congestion and pulmonary also. Certainly you are supposed to give relief to the patient. So you using diuretics, cutting down, you're asking for fluid restriction, sodium restriction, yes, that is necessary. We have to give relief to the patient. Morbidity, mortality, of course we have to think of, but certainly symptoms have to be relieved. Number two, certainly controlling BP, all those factors which are responsible for heart failure, preserved ejection fraction, yes, of course you are going to control. So patient is hypertensive, controlling blood pressure is important. Sugars, if patient has ischemia which is causing this, treating ischemia to the best of your ability, if required, even intervention. So that is going to help. Okay. Renal function, if the patient, because renal dysfunction is going to worsen this cardiac failure, yes, sleep apnea, treating sleep apnea, anemia, that is all going to help. Controlling the rate and rhythm. If patient has atrial fibrillation, fast ventricular rate, controlling that is going to help the patient. Okay, and that is what the guidelines said till recently. That doing this, controlling pressure well, giving diuretics for symptoms, etc., they formed, like class 1 indications. And all the other factors which I told you, they either go together, that should be done. They are likely to be helpful. I just summarized in one, what is class 1 there, class 2A there, class 2B, class 3. Class 3 means routine use of nitrates and this should not be done. Okay. And routine use of nutritional supplements. Some say that, okay, you CoQ enzyme inhibitors, you give to all patients of heart failure, preserved ejection fraction. Give vitamin E, vitamin C and D. No, that's not. This was in the guidelines till recently. And suddenly, last 2 years, everything changed. Why? Partly we heard about this in Dr. Kamal Sharma's talk, right? He told us that studies came with SGLT2 inhibitors in heart failure with preserved ejection fraction. Now, about all these other studies, look at the top one, which came in 2021. Emperor preserved. That means empagliflozin in reduced the preserved ejection fraction. So emperor preserved. And that came, and what they looked at, heart failure hospitalizations and cardiovascular death, and they showed that there was reduction of 21% in them, okay? And p-value was extremely significant. So they were all patients of heart failure with preserved ejection fraction. They looked at these primary endpoints. There was, and then they saw the breakup also. The first and the recurrent heart failure hospitalizations reduced by 27%, okay? And as he also told us, renal function deterioration actually decreased, and therefore this is very good. And this was very useful in all subclasses of the patient. That means whether they were male or females, whether they were diabetic or non-diabetic, okay? And, okay, whatever was their renal function to start with, and whether there was atrial fibrillation or not. With all these, there was improvement in all these, okay? And as we know, we are following up a patient, some improve, some do not improve. So the difference started coming right from beginning. Now look at this, within 12 weeks, improvement. This is the blue thing is improvement. And how improvement occurred compared to placebo. Please remember, in addition to all the other standard treatment, so that ARNI, beta blocker, MRAs, etc. were given. In addition, when SGLT2 inhibitor is given, certainly it showed improvement. And people who do not improve, or there was deterioration, that deterioration in the functional class also was much less in empagliflozin group than the dapagliflozin group, right? And okay, because of that, did the side effects occur more? No. As he has told us, again, I will not go into those details, but side effects were not worse in empagliflozin. No hypoglycemias, no renal dysfunction, etc., etc. Right. Okay, friends, another thing now, more recently, this trial came, Deliver. Now see, it's not even a month ago. This was presented on 27th August 2022, and it has come in the NEJM. You can read that because it is available on the online. Now these were patients, again large number of patients, more than 6,000 patients, where they were randomized to receive either dapagliflozin 10 milligram or placebo in addition to all standard treatment. They were all eligible for this study. They were all over the age of 40. They were all NYHA class 2 to 4. Left ventricular ejection fraction was more than 40. That means some had mildly reduced and some had normal of above 50. Okay. They all had structural heart disease. Their BNP, NT-proBNPs were high, and they were either hospitalized or they were stable patients. And what were the results? Again, I just summarized here the results. Followed up for more than 2 years, a little less than 2.5 years. Primary outcome, and what was the primary outcome? Composite of cardiovascular death and heart failure, okay? Heart failure hospitalization or urgent heart failure visit. That means patient on that suddenly becomes bad, comes to you either in the OPD or as admission. And they classified these two patients as patients having ejection fraction more than 60% and less than 60%. Because you know, earlier many things like your ARNIs and beta blockers and all that, they showed that higher the ejection fraction, results were not significant. Above 60% not useful. So there they looked at what dapagliflozin does to people with heart failure with ejection fraction of more than 60%, but heart failure because of our other criteria. And they were also looking at total heart failure events and cardiovascular death, change in the quality of life, cardiovascular death and all-cause death. What was found? Over 2.3 years, dapagliflozin, the primary outcome occurred. That means heart failure hospitalization and cardiovascular death. In 16.4%, in placebo it was 19.5%. Okay, so it came down by 18%. And similarly, worsening of heart failure itself came down by 21%. Cardiovascular death also came down by 12%. So these Deliver results additionally were similar in patients even if they had ejection fraction of more than 60%. So like Dr. Kamal Sharma told us, they had to show something better than empagliflozin. isn't it? So they earlier empagliflozin didn't consider this point at all. Now here they showed that even if ejection fraction is above 60, it can be useful. Diabetics and non-diabetics, of course, it is equally useful. And adverse events were as much as placebo only, not more than that. So their conclusion was that dapagliflozin reduced the combined risk of worsening heart failure and cardiovascular death among patients with heart failure and a mildly reduced or preserved ejection fraction. So in short, friends, whenever you are using ejection fraction to guide your therapy, as it is higher and higher, okay, you can still use SGLT2 inhibitor if you have clinically diagnosed heart failure and clinically and by your other supportive methods. Whereas only if it is reduced, then your beta blockers, ARNI, spironolactone, etc. are going to be useful. But even if it is above 50, 60, still SGLT2 inhibitor is going to be useful. As ejection fraction increases above 60, etc., I told you other drugs may not be as useful. Because of these studies, what Braunwald says, Braunwald, whose textbook we have all read, from my postgraduate days to your postgraduate days, even after qualifying, we are already, all of us, I am sure, we are reading. He clearly said that it would appear that finally the dam has been broken and that heart failure with preserved ejection fraction is no longer a stepchild. Stepchild मतलब क्या होता है? उसको कौन देखता है? उसको कौन क्या स्पेशल देता है? कुछ फर्क नहीं पड़ता है, वो तो ऐसा ही है. No, this because of SGLT2 inhibitor. Of course, Braunwald said this after Emperor Preserved came in, and he must be further pleased when Deliver study also came out with dapagliflozin. So it is now our job increases. Please remember, friends, even in heart failure with preserved ejection fraction, we should use now not only other treatment, but also we have got specifically SGLT2 inhibitors which will give us improvement. So friends, take home message is, in heart failure, please remember clinical assessment is supreme. Just, and basic investigation we should do, okay, ECG we should do, echo we should do, biomarkers, but you will do in suspected patients. Otherwise, Dr. Bhaskar Shah just told us that you can't do it in every individual. And then by Bayesian theorem, our utility of all these investigations will go down. So where you are clinically suspecting heart failure and you use this, our diagnosis will be better. We should not become only ape-centric. Looking at echo report, hey, 55%. No, look at other things. Again, Avinash's topic it is, I will not go into that, why we should do other. But let me tell you, even today, now I don't know what happens in the places where you practice. I practice in Mumbai, and I tell you, in Mumbai it still so happens that on the echo, final impression of echocardiography, first page, I see ejection fraction written. I don't always see a comment about diastolic function. I don't see a comment about raised LVADP or not. I don't see a comment about left atrium is enlarged or not. Because echocardiography is also very, very happy saying ejection fraction is normal. And many times, patient going for some surgery, pre-operative checkup you have been asked to do, and if ejection fraction is normal, you tend to say, everything is fine. Please don't do that. Let us look at the entire patient first, of course, and then see the echo, utilize echo well. Treatment of correctable factors is, of course, essential. Everything that works in heart failure with reduced ejection fraction may not work here. Diuretics for symptoms and signs of congestion you must use, but use of SGLT2 inhibitor should be brought into practice as shown by both Emperor, Preserved and Deliver. I am saying shown by these studies, of course, because these are recent, they are not yet come in guidelines as such. But now, yes, it is good therapy we know. And whether the patient has diabetes or no diabetes, in such patients, we should use, and then certainly you can make the heart much happier and it will work better. Thank you. Thank you very much.
Thank you, sir. Thank you, Shekhar sir, for
here
such
if somebody uses, where is our friend? Yes, whether dapagliflozin or empagliflozin. Now, both the studies, now in this particular one, both drugs showed benefits, of course. You know that now I just told you what is the difference between the two studies, little less. But therefore, I don't immediately jump to the conclusion. Okay, okay. Since it is, like heart failure, I use dapagliflozin more than empagliflozin. When it is...
If cost is not factor then? If cost is not the factor then also?
No, then it is equal. But still, like we are habituated to writing dapagliflozin. Let me be honest, now this between us on the scientific things, let me accept that yes, I've been writing. But no, not with a particular notion that dapagliflozin is better than empagliflozin and therefore I'm writing it. Yes. Yeah.
But sir, only in one slide you have mentioned that when HAP is more than, LVEF is more than 50%, SGLT2 inhibitors have advantage. But what we are practicing for years, like spironolactone, in one slide you mentioned ARNI and SE inhibitors have a declining effect.
Yes. And that is, I'm not saying that. There is a literature for that.
Yeah, this is the last question. Please, we are running short of time.
No, but we can discuss over tea. We can discuss over tea.
Yeah, you can discuss over tea, always.
Right.
Thank you very much.
Janaganamana?
Yeah, Shekhar sir, yes sir. It's now I request Prabhu sir and Ashwin sir to give a moment to Dr. Shekhar sir. Now I request all the delegates to be present during inauguration session because it is very important for us PGDC faculty. I think I am clear what I mean to say. The Chief Guest is General Secretary of Bharatiya Janata Party, Gujarat States. So please call your friends, those who are not present in the hall at present. So it is entirely
Dr. Ashwin is
all of us
felicitating
duty
Dr. Prabhu
to be call all the delegates
and vice
inside
versa.
the hall.
And Dr. Ashwin.
Yeah. Yes, friend. Now it's some time for fun with learning, and for that we have Dr. Ronak sir and Dr. Anand Ahuja sir. There are two teams. One is the chairman team and one is the president team. I request all the delegates to vacant first 3 rows and please sit to the back side. Please. First, please vacant first 3 rows. And I request both the team captain, Dr. Shekhar sir will be the player from the Dr. Sagar teams and Dr. Bhaskar sir will be the player from the Dr. Rajesh Rajan team. Dr. Rajesh Rajan is having team A and Dr. Shekhar sir and Dr. Sagar is having team B. So I request, Dr. Rajan, yours having team A, this row and this row, front 3. Dr. Sagar, team B, this side. And I think Ambadekar sir, I personally request him to play. Yeah.
Hey, it's better that everyone plays.
It is better everyone play. So sir in the Sagar's team and Bhaskar sir is on the yes, Dr. Chaki is here. Can anybody call Dr. Chaki? Yeah, sir. Dr. Chaki sir and I, so-called judge. Please, sir. And now it's over to you, Dr. Ronak and Dr. Anand, to explain all the rules. And in between, I request both the captain to call his team member. Please, everybody come.
Please, anyone can join.
Otherwise, I will call 11 people. Okay. Yeah, team is already made as per my knowledge.
Pre-decided team will join the team.
Team A, okay. With my. લાવો મને આપી દો કાગળિયું. લાવો. ટીમ એ the chairman's team, Dr. Rajesh Rajan, Rupam Sharma, Mohammad Safiq, Dr. Gaurav, Kumar Gaurav, Dr. Vinit Jagnani, Dr. Nikun Chovatia, Dr. Saurabh Bhatti, Dr. Dennis Dada, Dr. Kapil Khanna, Dr. Amin Jaria, and Dr. Manoj Gerela. Please stay with the Dr. Rajesh Rajan. And team B, Dr. Sagar Solanki, Dr. Kishore Gerela, Dr. Soyab, Dr. Jignesh Kataria, Dr. Hitansu Panchal, Dr. Tanvi, Dr. Munir Ahmed, Dr. Hiren Gala, Dr. Aswin, Dr. Santosh, and Dr. Mayur Chaudhary. Dr. Mayur, yeah, please, is entirely yours, sir. Please.
Thank you.
Request Dr. Mitesh to score this IPL.
Captains, please introduce yourself. Please. Captain of Team A.
Who are the captains, please?
Yes. Okay.
Rajesh Rajan and Dr. Sagar.
Yes, Team A.
We need to be here. Captain need to be here for a toss. It's like a cricket match.
It's a format is a cricket match.
So before we go to quiz, let me explain you what it is.
Yes.
So it's not a quiz about medicine. We are not going to ask you any ECG. We are not going to ask you any echo, not even X-ray. But still questions are related to medicines or cardiology. Wherever possible, we have to try to keep it to possible related to cardiology. So to just explain you the format, there was a cult classical movie called Anand. So the question will be like, what was the disease Rajesh Khanna was suffering in that movie? So there has to be some relation with question or answer, or some circumstances will be connecting with medicine. So that was, anyone knows the answer? Yeah, so that was lymphosarcoma of intestine. No, there won't be any options. No. Time limit here, actually there is time limit of 30 seconds, but for this questioning, we have not kept any time limit, but still I'll request everyone to be in time, keep 30 seconds time limit.
Let's not disclose more of questions, but explain the format, please. Yeah.
And format I'll explain. There are 3 overs. First over will be 6 questions.
Yes, I will explain when it comes.
Yeah.
Every over has a different format. So
and every over has different rules.
Let it be suspense.
It's simple rules. It's not difficult.
Toss. Yeah.
So let's go to the toss. Who will bat first or who will ball first?
Dr. Chakida will toss. Yeah. We all say all the best to Chakida. He is contesting the election for the West Bengal Medical Council.
Okay.
He is the contestant in the West Bengal Medical Council, Dr. Kaushik Chaki.
Yours is Team A, right?
Yes, Team A. So Team A has won the toss and it has chosen to bat first? Yes. Yeah. So explain what are batters going to do and what are bowlers going to do.
Okay, so let's go to first over.
I'll start.
Yeah, પાછળ માઇક અહીંયા જ રાખો છો. Okay, so meanwhile it starts. The over consists of 6 balls. 2 balls are for 2 runs, 2 balls are for 4 runs, and 2 balls are for 6 runs. Now the batting captain has to choose the batsman. That batsman will come and sit over there. Every ball batsman will change. So everyone will get chance to answer. Or they have to answer compulsory. We will not discuss question before you choose the batsman. Suppose batsman gives correct answer, 2, 4, 6 marks will be awarded to your team. Suppose batsman passes the question. That question will go to bowlers. There will be 3 bowlers. They can discuss among themselves and answer. Suppose if player answers wrong, batsman answers wrong, and bowler answers right, batsman is out, for first 2 overs, he can again play in third over.
But first 2 overs he cannot play. He's out
First
of
2
the.
overs he cannot.
Yeah.
30 seconds is arbitrarily time limit. So please try to maintain the time limits. We are not going for any buzzer, or we are not going for any 30-second timer or anything like that.
There's no display.
Prompting absolutely not allowed. Suppose prompting from this side, made we audience.
Then we'll award the runs to the opposite.
Opposite side.
Yeah.
No, it's not dumb charades.
भाई શું change?
Yeah.
ભૈયા શું change
Yes.
કરવાનું?
So if the bowler answers, the batsman is out and the bowler will get the points.
Yes, that I'll explain in next
We'll
slide. Once
explain.
it comes here. Once it comes here, I'll explain that rule.
Yeah.
Audience answer, Dr. Pragnesh will decide if both teams passes. If both team passes, audience answer, they will get this prize. So meanwhile it starts, let's go to Anand movie again. What was the name of Anand's doctor in that movie? Little difficult one.
I know.
It was Dr.
Bhaskar
Bhaskar Banerjee. And what was the name of the book which was written by Dr. Bhaskar Banerjee in that movie? What was the name of the book?
Okay, we can.
It's very simple question. You concentrate on the name of the movie, you will get the answer. Anna. So that was a hint. Wherever possible, we'll try to
give
give the
clue.
hint.
Okay. So this is first over.
Yeah, so this we have already explained. First over, there are no negative markings or no negative runs. How runs are scored, that I have explained. Correct answer, runs awarded. Wrong answer, 0 run. Batsman is in danger zone. Batsman can get out only if bowlers give correct answer.
If the bowler also fails, the batsman is not out. I like it, sir.
And opponent team, the 3 chosen bowler, they will get half of the original runs for the correct answer. Okay, so who is coming as a batsman?
So we'll start with Manoj Girela.
First is for 2 runs, that I'll tell you. First is for 2 runs.
Okay.
And bowlers? 3 bowlers will remain same throughout the over.
And I request all the team captain to send the player fast.
Start. So the first ball is for, it's a full toss for 2 runs. So simple.
Simple. He is known to have first human to human dash transplant. If you want, I can give his name. His name is Dr. Christian Bernard.
Heart.
No prompting, please. Please.
हो गया heart transplant.
Okay, so that is easy question to start with. So that was heart transplant. Next batsman. 2 marks to
Next batsman.
Team A.
हो गया.
Kapil.
1 question per batsman. Then only everyone will get a chance to.
Please you decide your next batsman, please. Please, next batsman.
You will get chance again in 3rd over.
Please don't prompt.
Yeah, batsmen who are going to play, please sit
keep,
on
stay ready.
4 seats.
Yeah.
So second question is a audio question. You listen to the song. Which symptoms does this song title suggest? You have to tell that title or whatever symptoms. No answer from audience, please. Audio?
Audio.
Asystole. Silence means asystole. You have not played anything. There is no voice. So asystole is there. If there is, what you will say?
Audio issue. We are back. the bat.
We will come to audience question. Wait.
What is the symptom?
Lose motion.
Audience, no teams, audience. Okay, sorry. Bowler. Breathless. So title of the song was Breathless. Shankar Mahadevan song. So one
Next,
mark, two.
next, please.
One run.
Next batsman. Dr. Dennis, please. Scorer be accurate.
Okay. So it's a Yorker now.
So this is an example. On left side of the screen there is a photo of face. Right side there is a book. So that makes a face plus book is Facebook.
Please, no prompting.
What is this medical terminology? No hints. This is a major hint.
Yeah, we will say.
Crisscross.
Wrong.
It is a just minute.
Cross match, yes. So this is cross.
Next batsman, please. Next batsman.
So that is cross match.
Rupam,
He gets one
Dr.
run.
Rupam.
We get 1 point. And there are 2 wickets for team A. So whenever there is a tie, we will consider wickets.
Dr. Upam, please.
Sir, you're out for this particular match.
2 runs.
No.
2 runs to
He did
team
not.
B.
2 runs to 2B. Team B.
Yeah. So 2.
This was for 4
This
runs.
was
so
for
half
4.
mark, so that is 2 runs.
2.
2 batsmen, sir.
No, the previous passed, so he's not out.
Previous was wrongly answered.
Yeah,
No,
that
no,
was wrong.
wrongly-
That was
wrongly
So
said.
2 wickets.
2 wickets.
Sorry. So team A has lost 2 wickets and team B has
Okay,
scored
so
2.
batsman is ready again for 4 runs. That is the 4th ball. This was the movie, quite old movie.
So which medical condition made Imran Khan lucky in this movie?
Movie name was Luck, released in 2009. If you can decode the hint is there.
Hint is there, yeah.
As it's an old movie, I'll give you one more
No,
clue
enough.
that is related to heart. As we all are cardiologists, this is
10
related
seconds
to
only,
heart.
Rupam. Dr. Rupam. I think pass.
Okay,
Yeah,
that's
time is
fast.
up. So
No, only for the bowlers.
bowlers,
Only for the
yeah.
bowlers.
Bowlers. Please, bowlers. There are only 10 seconds for bowlers. Is pass from bowler side also? They are also.
Yeah, it's pass.
Audience. Yes, excellently.
Dextrocardia.
Avinash, please give one book to the Hitansu.
The hint was right to left. That was
Right to left, yeah. Now next batsman, please. Next batsman, Rajesh Rajan.
next
Vinit.
is for 6 runs.
Hey, Mike.
So now we have a bouncer for 6 runs. Okay.
The inventor of
Sir, यहाँ देखिए.
Inventor of stethoscope.
Leeuwenhoek.
René Laennec. Let me complete the question. It is not the question.
Wait. It's not Leeuwenhoek.
From which country René Laennec was? The hint is there in the photo only. If you can find that.
Yes.
Please.
No prompting.
No prompting, please.
England. No.
Sorry.
It's
That's
wrong.
out.
Bowler.
France.
Yeah.
Paris.
So you can see
There is
the
a Eiffel Tower.
There is Eiffel Tower.
Next batsman, I think last batsman of this
Kumar.
over.
Team B gets 3 marks.
And team
A
is
wicket.
1 wicket.
Six ball after 1 over. After 1 over.
So this is the last ball of the first over.
Again for 6 runs. Neil Armstrong, the first astronaut to walk on moon, died at the age of 82 years in 2012 as a complication to which cardiac surgery? There are no hints in the photo.
Don't even look for that.
It's a CABG.
Yes, correct. So first 6 of the match.
First 6, sir.
So after the 1 over, team A is a 8 runs and team B is a 6 run. And there are 2 wickets. 3 wickets, sorry.
3 wickets lost. Okay. So now team A will choose the bowlers, 3 bowlers, and
3 bowlers from Dr. Rajan.
Team B is first over.
Kumar Gaurav, Dr. Muhammad Shafiq, and
so you can
Dr.
send 3
Amin
bowlers.
Jaria.
Yeah.
Go there, sit.
Yeah, first player. Yeah, Dr. Tanvi. Yeah, Lady Luck. Lady Luck of the team B.
Good luck. So are you ready?
Tanvi, you can see here, yeah.
This is a full toss for 2 runs. So this famous scientist died at the age of 76 years due to which vascular disease?
There is hint.
Yeah, there is a hint on the screen.
Please don't prompt.
No prompting,
Please don't prompt.
No prompting.
Enjoy
There
that.
is a huge hint. Huge.
It is not a hint, it is an answer on the screen.
Actually, there is answer.
Yeah, there is answer, it is not hint. No, it's passed by.
Pass.
Yeah.
So, Shafiq.
Yeah, yes, for bowler.
Which one?
Yeah, so that was abdominal aortic aneurysm.
Yeah.
Wow.
So team A get 1 mark. 1 point.
One drop.
Next player, please.
No wicket, 0 wicket.
No wicket.
Past question.
It's a past question. So next batsman.
Yeah, Mayur.
Okay. So
Dr. Mayur.
Okay.
Full toss.
So again, it's a full toss for 2 runs.
दिल जलता है तो जलने दे. Identify the symptoms.
Gastritis, heartburn,
Something related to heart. That is
heartburn.
Heartburn.
Yes, right answer.
We'll consider this.
Okay.
Next player,
So,
please.
2 runs.
नहीं
runs
नहीं
for
नहीं
B.
नहीं send the player, send the batsman.
2 runs.
2 runs.
Next is 4 runs, huh?
Next is 4 runs.
4 runs.
This is 2 runs. Next is 4 runs. Mayur. Yeah, Mayur आ गया.
So that's again a same form.
Yeah.
Face plus book is Facebook. So you have to identify this nice couple.
Oh, wow.
You have to identify this couple.
Couple.
Like face plus book is Facebook. This plus this is what?
Remember, it's a Yorker. You could lose your wicket
Yeah,
also.
it's a Yorker.
Play safe.
If I'll give you answer, this is very easy. Once I give answer.
Time is over. Bowlers. Bowlers. I think also they have passed audience.
Excellent.
Yes, wonderful. It's the Lisare and
Lizare. बहुत सारे लोग. No man.
5 seconds only. 5 seconds only. It's a judge decision. Yeah, it's okay. Now next question, please.
Okay. So, no run scored, no wicket lost. Okay, next batsman, please.
4.
Yeah, captain, khud gabbar.
Okay, sir.
So this was quite little bit old movie.
Which cardiac procedure was the central theme of this movie?
No, it's not controversial.
It is not?
Given in movie.
Yeah.
Correct. So
Wonderful.
heart transplant.
Wonderful. Well played, well played. Next,
Well
next
played.
batsman, please.
So 4 runs. 4 runs for B. 4
Yeah,
runs.
for the 6th run.
Hitanshu is our Hardik Pandya.
Hardik Pandya.
Wait, and it's going to be a bouncer.
Sir David Littman, a cardiologist in Harvard Medical School professor, was from which country?
There is,
Hint is there if you can decode.
there is a hint is there.
No prompting.
No prompting, please.
What's the answer?
Yeah.
No prompting.
Please, no prompting. Yeah.
Wait.
Please, team B. One.
Germany.
Germany. There is a hint.
Germany.
There is a dog.
There is a pot of German Shepherd.
German Shepherd, yeah.
So that was a hint. You prompted, I heard he did not. So that's why I allowed the question.
Okay.
No wicket.
He has passed, so no wickets lost.
3 points to team B.
3 runs.
Team A, sorry.
So
Please, next question, next batsman.
Last ball again 6 runs.
Last ball.
Next batter. No.
No.
New player.
Arey, Shikhar sir.
Thank you.
Yeah, it's a bouncer.
Okay. So, Saif Ali Khan, Chote Nawab underwent which cardiac procedure? in the
Angioplasty.
past? Wait. What is it?
Angioplasty.
Okay, angioplasty. Yeah. 2013.
So, it's after the second over.
So that's 6 runs for B.
Let me know the score, total score, sir. Total score. After the 2 over, team A 12 run and team B 18 run.
Okay, so let's come to team A again.
So the format is slightly different.
Same thing, you have to send 3 bowlers
Again,
as was first over.
3 bowlers.
One batsman come from this side. Whoever was out cannot come in this over.
Yeah.
They can come in third over.
So, Nikunj.
And there are
Display banda.
there are
Bhai,
negative
display banda.
markings.
Now there are negative runs here. So you can lose runs if you give a wrong answer.
Only thing changed here is negative marking. No. Once you have passed, there are no negative markings, 0 runs. If you have given wrong, negative marking.
So opening
So
batsman.
you can get out and also lose runs.
Wrong answer, negative marking. Passed, no negative marking. Bowlers half marking. If they give wrong answer, fortunately or unfortunately, bowler does not get out. They will get half. They will give negative marking.
Yeah,
They
negative.
will also get negative mark. Yeah, they will also get negative. Negative mark for everyone.
पर क्रिकेट में बैट्समैन ही आउट होता है ना, बॉलर कैसे आउट होता है?
Even audience will give negative mark.
It's googly.
You have to give the gift.
Yes, it's googly.
And this is related to, not related to movies. This is related directly to cardiology.
Okay. So the batsman, please ready, sir?
For 2 marks. Blood investigation very sensitive, but not specific for venous thromboembolism is
D-dimer.
correct.
Very good.
Yes,
This is a little bit easy.
Yeah, easy. So 2 runs.
Next
to
batsman,
A.
please.
Next batsman.
Again 2 marks.
Uh,
Next batsman.
Saurabh Bhate.
Saurabh Bhatti, please.
Ready? Sorry.
So mid-systolic click is heard in which common but not so innocent cardiac condition? No prompting. I heard 2 prompts at least. Mid-systolic click.
Pass. Pass, please, bowlers. It's bowler's turn.
Yeah, perfect. That is MVP.
MVP. That's true.
1 mark to the bowlers.
1 run for team B. 1.
1 run for team. Next batsman.
Bhaskar Shah, sir. Next batsman.
Next batsman.
Next batsman.
Yeah, Khud Gabbar, Dr. Rajesh Rajan.
आ जाओ ठाकुर.
Okay, so 4 marks. You will be happy seeing urine sugar of 4 plus in a diabetic patient receiving which class of drug? Wait, no prompting. No. This is full toss agree. 4 marks, no prompting, please.
Your time has started. Pass.
Wait. Bowlers.
SGLT2
SGLT2 inhibitors.
No. 2 marks. To team B.
2 marks.
Okay,
Dr. Amin.
Next batter.
अरे आमीन एक बार आया था ना
Yes,
बैट्समैन बन के.
Dr. Amin Jaria.
He was batsman once. He was out or he was.
No, bowler.
Not out. It was passed, so not out.
So, patient being treated for atrial fibrillation complains of blaring while driving at night.
Oh.
Which drug he must be taking? No prompting. You will get chance first. You
Yeah.
will get chance second, third, fourth.
First chance is to Bhupat, okay? If there is audience poll. Ritesh, sorry. I think it's passed to team B.
Gets passed. Bowlers.
Pass.
Audience.
Dr. Ritesh.
Amiodarone.
Yes, Amiodarone. Yes, please, Avinash.
So no marks.
Yes, next batsman, please.
Dr.
No
Vineet
runs, no
Jagnani.
wickets.
Amiodarone causes corneal scarring. So patient can get blaring at night. Although it's a
Dr.
rare
Kapil.
side effect, not very common, but yes,
Out of
it is. Next for 6 runs.
6.
Yeah, Dr. Bhaskar sir for 6.
Team A, you will really need to pull off. You're lagging behind. Please.
So commotio cordis is ventricular fibrillation and sudden cardiac death due to. Audience can raise your hand, no prompting. 1 from audience. 2, 3, 4.
You pass, sir?
Yeah, it's pass.
Okay.
Yes, bowler team, bowlers, pass.
Pass.
Yeah, to be specific, he had blunt trauma to the chest wall.
Okay. So,
Yeah, thank you.
no runs and no wickets.
Here.
No wickets. You got already one, so let him get.
Avinash, at last. Avinash, at last to Dr. Prabhu.
Okay, next batsman.
Manoj
Next
Girela.
batsman.
Manoj Girela.
Dr. Manoj Girela for 6.
Sir, your question.
Alpha methyl dopa given for hypertension in pregnancy. It's a drug of choice, kind of. Should be stopped immediately postpartum because it increases risk of a complication. To mother, what? That's why it was 6 runs. Till now, nobody from audience.
Oh, no, don't prompt.
So everyone will give their price back.
Price back, yeah. Yes. Hey, no Google search.
Please don't prompt.
Wait,
Yes, it's pass. Pass.
नहीं.
Hey, wait. Time is over.
Termination, medical termination.
It's wrong. Wrong, -3. Wrong, -3.
Okay, then let's consider it as a
Yeah,
pass.
it's time out by judge, so it's time out. So no minus point.
So
Yeah.
no minus point.
Yeah, no minus
But
point.
Bowlers gave correct answer. It's a peripartum or postpartum depression. So 3 marks to team.
3 runs for B. Yes.
Yes, please, bowlers.
So bowlers, please change.
So now bowlers from team
After
A.
the 3 overs, total score is
Manoj Girela. Go there. Bowler,
Team
bowler.
A 14 run, Team
Kapil.
B 24 run. Now there are batsmen from Team B. Mike.
Are you ready, sir?
Yeah, ready.
Okay. Please quiet. Please
Please
audience.
quiet. Please don't talk.
No prompting. You can raise your hand.
So which side effect of spironolactone can occur in males but not in females?
Many.
Gynecomastia.
Yes, right.
So 2 runs to team B. 2 runs. Your next batter. Please be ready with...
Please be ready with the next batsman. Yeah.
Please
Now
wear
you know
your
the
pads
format.
and
It's
gloves.
about 4 run. Next question.
Okay. So next is again for 2 runs. So while palpating a radial artery in a sitting position, you ask the patient to take a deep breath and look to the opposite side. What are you trying to diagnose? Why do you want to do that?
I'll pass.
Team B, Team A, sorry.
No. Bowlers wrong. Bowlers. Wait.
Eight.
Bowlers.
So
One
team
mark negative.
Bowler
A,
1
one
mark negative.
negative.
Now audience, please.
Audience, yeah, thoracic outlet syndrome.
Yeah. Please book to the Dr. Suyab.
What is the test called?
Now audience, one more advanced audience question.
Test name. Yeah.
No, what is the name of the test?
What's the test called? Anyway, next batsman's ready?
Nobody from us.
Pass.
Nobody from us. Answer will tell you on T.
Okay. Googly for 4 runs. Thiazide worsens dyslipidemia. Which other antihypertensive drug also adversely affects the lipid profile?
Yes, Yogesh, we will ask you.
Pass.
Okay. Bowlers?
Yeah. Yeah.
Sorry,
Please.
I will not give you because it was a
the
very
team-
loud prompt.
Yeah.
And maybe that batsman has, the audience has to give a prize.
Yeah, audience.
Loud prompt from audience.
Loud
This is
prompt.
a loud prompt and please
Yeah, and
don't-
for the team
it's
member.
Not appreciated, please.
So there is no points.
No marks scored and no one is out.
Out,
Till
yeah.
it's passed.
Yeah, please.
Yeah. So no wicket lost. Your next batter, please.
Next question. Batsman, who is the batsman? सर आप जाइए सर आइए Come on, sir.
So again, sir, it's a googly for 4 runs. In class 2 or class 3 heart failure patients with ejection fraction less than 35%, besides pharmacotherapy, ICD placement reduces mortality by 30%. What's the full form of ICD?
We want complete and proper answer. Not even single word change here and there is allowed.
Implantable cardiac defibrillators.
Pass to bowlers. You want to change anything in answer? No, full form.
Sorry.
Intra both wrong. Both will get half mark minus.
They're wrong.
Hence, 2 marks minus to both. Audience. It is implantable cardiovascular defibrillator.
Next batsman, please.
This was for 4 runs.
Yeah.
So Team B is the -3. Team A is the also.
No, it was for 4 runs.
4 runs.
4 runs, sorry.
-2
for the both. Yeah, Captain Gabbar Khud.
Okay. So again, now it's a dusra ball for 6 runs. Which antiplatelet agent is approved in fixed dose combination with aspirin for the treatment of stroke, but not for coronary artery disease?
No prompting.
No prompting, please.
No prompting.
Please do not do that. Or play here.
Clopidogrel.
Clopidogrel.
Wrong.
टीम अभी 2 ही बाकी है जो बोलना है. Yeah, you can discuss only. Time is limited.
Sir, please don't prompt. The bowlers are yet to.
Yeah, your time is. You are running short of time. Yeah, audience.
Audio, one second. There. Dipyridamole.
Dipyridamole.
Yes. I think last ball.
Yeah. Team B -3.
-3. To
Team B -3.
So that is now team A strategy. If you can't score, don't let the others score.
Pass it.
Okay. So this is another dusra for 6 runs. Hypercalcemia due to excessive vitamin D ingestion is more likely when patient is on this particular group of antihypertensive drug.
Thiazide group.
Yeah, thiazide for diuretic.
Wow.
Excellent.
Sixer.
Even one sixer can make a difference.
1 6 can.
One sixer can make a difference in the score.
Yeah, 1-6 can change the match. Now after the 4 over, score is Team A 11 run, Team B 29 run. बॉलर में चलेगा सर. चलो प्लेयर फ्रॉम टीम.
No need to.
The format is changed now.
नहीं, they are changing the format.
So all the players who were previously out can also participate now. It is a rapid fire question round. You get 10 questions and you have total 3 minutes to answer. You can pass a question because in 3 minutes, if you do not get to the last 2 or 3, you don't get to answer them. But if you pass one question, you cannot come back to the previous question also. So you have to be very careful.
And I think only one person will answer. Only one.
Yeah, the
only one
answer
person.
from captain. There are negative markings. Negative markings.
So correct
Half
answer
negative,
is
50%
4 runs.
negative marks.
You can cover. So there are 4 runs for each question. So 10 questions, you can score 40. You have good chance. But if you answer a wrong, you'll get -2. You designate one spokesperson or captain. Only his answers will be considered the official answers. You can tell him, yes. But yeah, absolutely.
Yeah, so suppose a captain gives 2 answers and first answer is incorrect. That will be considered incorrect.
The first answer given by the captain will be the official answer.
Whatever
But remember,
team may say, whatever it is.
now remember the catch. You only have 3 minutes. Whatever
Yeah,
amount
only
of
have 3
discussion
minutes.
you do.
Please settle down. We are running short of time.
Remember, you only have 3 minutes for all the discussion for 10 questions. Are you ready?
Yeah, he has mine.
Okay.
Team B will remain silent. Audience will remain silent. Past question we will come later on. There are no markings for past questions. That will be audience questions.
The scorer will have to be very vigilant now. Okay?
Yeah. Dr. Rajesh Rajan is the spokesperson. Start.
And sorry, correct mark 4 runs for each question. -2 mark for wrong answer. There are no 2 mark, 4 mark, 6 mark.
All are for 4 runs. Okay?
-2.
This is a slog over. Every question is for 4 runs. Every question.
-2. So first is our audio questions. First listen to the audio. I'll come to the question. So which medical terminology is depicted by initial few words of the song? Hint is there.
Insomnia.
Yeah, insomnia.
Insomnia. +4. Okay, next. You don't have time to applaud. Which artery gets compressed in the beauty parlor stroke syndrome?
Carotid.
Wrong. -2. We'll come this again.
Wrong. -2. Next.
Dr. John Wilde is known as the father of medical dash.
What?
If you can decode, hint is there.
You have a time limit of total 3 minutes.
Ultrasound.
Ultrasound. Correct.
Ultrasound is
4 marks.
+4.
A very famous movie. A quiz cannot complete without this. What was the name of Munna Bai's hospital? You have to be very specific on this.
You're losing time.
You are losing time.
Dr. Murli Prasad Sharma.
Wrong.
Wrong. -2. Next.
A very interesting movie, Something the Lord Made. This movie was about what? A hint. It was something about congenital heart disease. The name of doctors are Dr. Alfred and his assistant Vivian Thomas.
Your time's running out. Please be
You
careful.
are running time.
Pass. Okay.
Okay. Pass. 0.
1 minute 10 seconds.
This is Space Plus book is Facebook. What is this? Identify this. Captain
Malaria.
Has to answer. Captain has to answer.
Malaria.
Malaria. Yeah, correct. 4 marks.
4 +4.
We'll come to the question. We'll
Okay.
explain.
It's a rapid fire, please.
What?
What does she hold in her right hand?
Sitla Devi, widely worshipped in North India as a Devi of pops. What does she hold in her right hand? It was photoshopped and it is not there. What is supposed to be there?
हाथ में क्या नहीं है? Something is missing.
Hint. Any hint?
No hint.
No.
Sorry.
You are running short of time.
If you want hint, you will get this thing in your household.
Only 10 seconds.
Okay. Pass.
Pass. Identify the symptoms.
Time up. Yeah, it's last question. Yeah.
5 minutes.
We'll give the time to.
In last few words.
Yes.
Last few words.
Hallucination.
Uh,
Visual hallucination.
We'll keep it on hold. We'll come to that. Let judges decide on that answer. We'll extend the time to 2 minutes more.
Yeah. Okay. Fine.
What is the special about this day? It's her birthday. Hint, if you have worked enough in your wards, you will get the answer.
Nurses Day.
Nurses, 4 marks.
Great.
And who's she?
Nightingale.
Yeah, Mary Nightingale. So this is last one. You have to name the American billionaire who is diagnosed with prostate cancer. There are 2 hints on the photo.
Yeah, it is extended time. 5 minutes.
So there was video and audio.
Video, audio.
Bill Gates.
Wrong.
Wrong. -2.
So we'll come to the question of this. They said hallucination.
Yeah.
Actually, it is illusion.
Illusion.
I
think we can give the mark. I think we can.
No,
we will
it's
give the mark.
different.
You can give marks. So
Yeah, we will give the mark.
that
Yeah.
Question number 8. We'll come to the answer. I'm coming to answer. So
Yeah.
first was insomnia. Second,
I
anyone
request-
from audience? Vertebral artery. It is not carotid artery, it is vertebral artery. Third is medical ultrasound. This is ultrasound produced by bats and dolphins. This was Hari Prasad Sarma Charitable Trust, not Murli Prasad. Murli Prasad was name of Munna buying that movie.
After the third over of the team A is 25, team B is 29.
This was a movie about BT shunt. BT shunt. You said top. BT shunt.
Even
So
if you
sign
pass
of
the
the
entire
card,
over,
but
you win.
Yeah. Yeah, if you pass your
This was
entire
malaria. She holds broom.
10 questions,
broom,
you will
jhadu,
win.
Jhadu. You gets in your household. So spend some time at home.
Chalo.
This was
Yeah.
everyone knows. And this was Warren Buffett.
Yeah, Warren Buffett.
This is a Buffett, and there is a famous line by Warren Buffett.
Okay, so now, who's the captain who's going to be?
Yeah, Dr. Sagar will answer. Dr. Sagar will answer. Chalo, start.
Wait.
Wait.
There are no audio on this. I have to only edit the audio.
Actually, if you don't answer a single question,
You will
still
win.
win. But if you answer wrong once, you could lose. You could lose.
Still try to answer. Be fair.
Be fair, yeah, it's okay.
Yeah, let's play.
Play for 50 runs.
Equally, yeah.
Not for max.
Okay. Your time starts now.
Just a second.
I think रोनक भी नाम पढ़े तो पहले क्वेश्चन स्किप करिए. माइनस हल से.
You have to name this Hindi movie where this song belongs to. And this is the hint. Yeah. Row. Yes. So this is the hint. 4 marks.
+4. Okay.
Question 2.
What disease is referred to as cattle class syndrome?
Pass. Okay, we'll come to this.
Next.
What is an older term for the mechanism of tachyarrhythmias via re-entry? Hint is there, if you can recall. Okay.
Next question.
So, the great work of Michelle McNally and her teacher, Mr. Debraj Sahai. You have to name the movie.
Yes, Dr. Sagar, be fair and answer.
There is a hint. Yes, it's a black.
Black.
+4.
+4. Next.
American medical drama series premiered in May 2005. And now 19th series is going to be.
Wait.
You cannot answer. You have to name the series. Grey's Anatomy.
Grey's Anatomy. Next.
So the next one is Face Plus Book. Face Plus Book. What is this?
Okay, nice question. Yes, you are taking too
Your
much
time
time.
is running out.
Pass,
sir.
pass.
Pass, yes, great.
Next.
He is known as a physician of God and Dev of Ayurveda.
Dhanvantri. +4.
Identify the symptoms.
This is hangover the next day.
भाई ये अपोजिट टीम वाले हिंट दे रहे हैं.
Okay.
Next question.
Which was the first liquid pasteurized by Louis Pasteur?
Yeah, hint is there in the picture.
Pass.
This occurs when you travel from one time zone to another.
Jet lag.
Jet lag, +4.
+4.
So,
Nice.
let's come back to the answers.
Yeah.
Okay, the
So this is
answers.
Answers are first is rogue, second one is deep vein thrombosis, third one which they did not answer.
Check it out.
Audience.
Winner team के captain को
Circus
देखा
movement
कि
tachycardia. From there, Pragnesh bhai.
Yeah. भाई book Avinash book.
Circus movement tachycardia. So the older term. So this was black in entire presentation. This is the only slide which has
Slide
black
which is
background.
black.
Yeah, but this is a black background. That is the biggest hint in entire presentation. This was Gray's anatomy.
Anatomy.
So that was Gray's anatomy. No, this is not right. But still, you have to decode the hint.
Okay.
So what is this? Audience. Filariasis.
Yeah.
This is file plus area. That is filaria.
हाँ भाई इनको बुकाओ.
Dhanvantri you answered. Hangover you answered. First liquid pasteurized was wine. And this is
Jet lag.
We have some more questions for audience if you want.
Yeah, there are few questions.
Only
There are few
only
questions for
for
audience only. हाँ कहूँ છું. Yeah. There are 3 questions for audience because we have to shut down the LED. Yes, its temperature is ઠંડુ કરવું પડશે LED ને એટલા માટે. LED ગરમ થઈ ગઈ. હા.
મને આપી દે. I'll answer. I'll give you the question.
Yeah, there is some technical errors, so we will wind up the end IPL here. Team A 25 runs, Team B 53 runs, and I request Dr. Rajan, the captain of the runners team, to be on the stage, and I request Dr. Shekhar sir to, and I request Dr. Rajan to hand over the medallions to his team members to save the time. Yeah, Dr. Rajan, please hand over to your team. Now I request Dr. Bhaskar sir. Dr. Bhaskar sir. And I request Dr. Sagar to hand over the medallion to his team. Now I request Dr. Vismay and Dr. Sagar to hand over the memento for the excellent and fun come knowledge quiz to both Dr. Anand Ahuja and Dr. Ronak. Please. Sir, please. Now I request Dr. Mitesh Chauhan to give a memento to our judge, Dr. Kaushik Chaki. Dr. Mitesh, please. Dr. Chakida, please. And we all give all the best to Dr. Chakida as he is contesting election for the Medical Council of the West Bengal.
We need a team photo. Team photo.
Yes, yes.
Come.
Now I request both the team to take a team photo with Chakida. चलो भाई તમે LED બંધ કરી શકો છો